Hey, Tina, it's Lorraine. I'm going to advance your slides for you. I'm just running to the bathroom, so I'm ready to roll it at 9 o'clock.
Okay, sounds great. Thank you.
All right, I'll be right back.
Okay.
You're almost not general. So Tina, how is everybody?
Everybody is good here. We have 0 patients with COVID, so that's good. It's always a good thing.
And so Tina is, and I forgot her name again, the other dietitian there?
No, she's not. She's normally off on Mondays.
Oh, okay. All right, this way I don't have to worry about introducing her.
We will have one of our PD nurses, our home nurses, Lynn, will be joining us at one point.
Well, I'll let you introduce her since you know all about her.
Yep.
Okay.
And our social worker may pop in and say hi.
Oh, that would be great. And I'm going to advance the slides for you, so I'm just going to stay here. I may blacken out my screen, but I will be listening depending on how. Sometimes I want them to like ask a question and unmute and kind of turn on. So otherwise I'll probably have everyone at least say hello and introduce themselves, and then they can blacken out their screen. But I would like a few of them to stay on, because otherwise I feel like it's very hard to know who you're talking to and feel like they're with you. So I have a quick clinical question for you. So I saw a patient with CHF, and she has stage probably 3B kidney failure, mostly because of congestive heart failure, I believe. So when she was in the hospital, the RD recommended Neprovite instead of a regular multivitamin. Would you agree with that? So she's not on dialysis yet, and hopefully won't be. But that's because when I was looking it up, it said more for dialysis, but I was wondering if she's,
A renal vitamin is actually just vitamin B complex and C, so there's no harm to it.
There's no harm to it. Okay. We just don't want her to get some of the other ones. Okay.
It's actually being on the safer side, so no problem.
Okay.
I'm just looking at my.
And do they need a prescription for that? Because then the cardiologist said, do we need a prescription for that? And I was like, well, I assume so, but I don't know.
Yeah, they do actually need a prescription for that. If the patients don't have great medical insurance, I'll tell them just to get B complex with C anyway.
Okay. Thank you.
Sure. I don't see you yet. I think Lynn is trying to get in.
Lynn's the nurse, or?
Yep.
Okay.
It's Raniola, right, Lynn? Yeah. Okay.
I see one more intern. A couple more interns, I guess, are coming on.
How many do you have this year?
So we have 16, but we also have the distance interns joining us, and I think there's 5 of them.
Okay.
So I think 31 interns in total.
Wow.
And no, not 31. I said that wrong. 21, sorry.
I'm just going to close my door.
Oh, that's fine. And is Lynn on or not yet?
No.
Okay, so what I'm going to do is introduce everybody, and then I just want everyone to unmute and unblock your screen and say hello. And then periodically, you don't all have to have your screen up because that might be distracting, but I do expect a lot of questions, and make our speakers really feel like you're there and participating, okay? I know you guys know how to do that. So, so I'm going to just say welcome to this again. This is our second seminar where we've had the distance and the on-site interns together. So we just want to say welcome to everybody. And how does it feel to be in the home stretch?
Really good. Excited.
Good. What about on-site people? How does it feel? Upala, how does it feel?
Excited, waiting for these days. So just can't wait to be done and be out there.
Okay. All right. So today we're very lucky, and for the last several years, we've been very lucky to have Tina Titone, who's the RD at DCI Kidney Center. It's in Tech Park, where you guys didn't largely get to go except to visit probably Alyssa Feldman for Diabetes Center. It's in the same building, if any, for those who went there in person, which I think most of you did, unless it was the very beginning of the year. And for the distance people, Tech Park is our, I don't know how far, 7 minutes from the hospital. It's where some of the office buildings are that see our outpatients. But DCI is not technically connected to Stony Brook. It's a separate entity, correct?
Correct.
And in years past, some of you were able to do an elective with Tina. This year was a little harder, and last year as well. So I'm hoping this coming year that can be reinstated again as an elective to do the 3-week elective with Tina at DCI and some of our other kidney centers. I think Southampton Hospital is accepting people to do a rotation at their kidney center, their dialysis center. So again, we're hoping all this will open up and be good again. So Tina's been doing this for a long time, and she'll explain all about her varied past in clinical and why she likes working for DCI. And I believe the PD nurse is also going to join us, if she hasn't already, to go over what it's like to train people to do PD on site. So without further ado, I'm going to turn it over to Tina. I'll be advancing the slides, so I'll be here. So first of all, let's, I see Willie at the top of the screen. So Willie, you start off, you introduce yourself and say hello, and then let's people just keep going. All right.
Hi, Tina. Hi, everybody. My name is Willie. Glad to be here today. Thank you.
Jessica.
Hi, my name is Jessica.
Melissa.
Hi, my name is Melissa. It's nice to meet you.
Alana. You're muted.
Everybody can hear me. My name's Elena.
Caitlin.
Hi, I'm Caitlin. Nice to meet you.
Utpala already said hello, but she can say hello again.
Hi, I'm Utpala. I'm the on-site intern. Nice to meet you.
And Upala actually has an interest in doing dialysis perhaps in the future.
Yes, in the future. Yes.
Awesome.
Okay.
Thank you.
Vince, you're next.
Good to see you, Lynn.
Hi, my name is Vince. Very nice meeting you. Excited to learn more about dialysis.
Skylar.
Hi, I'm Skylar. It's nice to meet you.
Samantha.
Hi, I'm Samantha. Oh, we've got two Samanthas.
Oh, that's right. And Samantha. Okay, so both of them will introduce themselves. That's right. Mariam.
Hi, I'm Miriam. It's nice to meet you.
Tina.
Hi, Tina. It's nice to meet you. My name is also Tina.
Chris.
Good morning. How are you? My name is Chris.
Stevie.
Good morning. Hi, my name is Stevie. Nice to meet you.
Caitlin. Caitlin's out in the sunshine. I can see her.
My name is Caitlin. I'm a distance intern. Nice to meet you.
Kristen.
Hi, I'm Kristen. Nice to meet you.
Allie.
Hi, my name's Allie. Thanks for being on today.
Betty.
Good morning. My name's Betty. I was also looking forward to doing my elective in Renal, which unfortunately couldn't happen this year.
Caroline.
Hi, I'm Caroline. Nice to meet you.
Rachel, we're just introducing ourselves, so say hi.
Hi, everybody. My name is Rachel.
Brianna.
Hi, I'm Brianna.
And Samantha already chimed in when the other Samantha, so just wave, Samantha. R. Okay, that's Lynn. Let me just see if I have anybody else who I think. Let me go to the second page. Or am I doing this wrong? I'm doing this wrong probably. There we go. Oh, Kara's also listening in. So is that everybody? Did I miss anybody? Okay, so then I'm going to turn it over to Tina Titone.
Okay, good morning, everyone. Just want to tell you a little bit about myself. So I'm a renal dietitian here at PCI, it's Denver Kidney Center. I've been here going on 6 years now, in July. I did my internship through Aramark, um, and I did most of my rotations in the city, even though I lived on Long Island, so that was a challenge. But the best rotation that I did actually was my rotation for renal. I really loved my the woman who taught me everything about renal. She walked into the dialysis unit. Everybody knew her name. She knew their names. It was just amazing the rapport that she had with her patients. And that's something I always wanted to do. Unfortunately, I ended up in management in dietary at Stony Brook for a couple years. I did not like that job. I worked from like 5 a.m. to 3 p.m. A lot of long hours, pay wasn't great. And then I went on to work at North Shore Hospital at Plainview. And I worked there for 17 years while raising my kids. I worked 3 days a week. Total hospital setting, you rarely got to see the same patient twice. I did a little bit of outpatient counseling, which they started up just before I left, at a clinic that they had just started just outside the hospital. And I really enjoyed that. And that kind of sparked my interest in maybe trying to go for renal, being a renal dietitian. I was very worried during my interview. I was very excited. I really wanted this position, but I didn't know if I'd be able to get it. It was full time. I didn't really have any renal experience other than my internship and, you know, the few patients I saw in the hospital that were kidney patients. We didn't really, I felt like I wasn't educated well enough to educate the patients in the hospital. Hopefully you guys got a little more education on kidney disease during your internship. But I learned a lot just being here, rounding with the doctors, talking to the nurses, fellows, residents. And I'm really happy with my decision, and I'm sure I will retire in this position. It's wonderful knowing all your patients, you know, walking into the dialysis unit and they all know your name. You know a little bit about them, all their histories, their stories, and I'm really enjoying it. So I hope some of you will be interested also. It's a great job. So behind me, you'll see is our home nurse, Lynn Raniola. Lynn, can you just wave? There she is. She'll be joining me in just a little bit. She's going to be talking about peritoneal, a little bit about home dialysis. All right. So I don't see the slides. I don't know if the slides are up.
I'm going to screen share now.
Okay. Okay. So nutrition and dialysis. We're going to go over why nutrition is important. It's vital for the dialysis patients. It's another reason I love my job, because our patients without a proper diet will not thrive. The diet is very, very important to their everyday life. I'll explain my role, the renal diet, of course. We'll also talk about parenteral nutrition, which some of our patients do receive here. Again, we'll go over home and PD, peritoneal dialysis, and I'll discuss a little bit about QAPI, which is our quality insurance improvement, and our care planning. So why is nutrition important to our patients? It helps decrease their risk of morbidity and mortality. Their symptoms can improve. Symptoms that are common to dialysis patients are shortness of breath, itchiness, nausea, fatigue, decreased appetite. They often find if they're following a good diet, they will have increased energy, less fatigue. They'll maintain their skin integrity, improve their wound healing, optimize their bone health, and it also will help fight against infection. So my role here, educate, educate, educate. We educate not only the patient, but anybody involved in that patient's care. So be it the aides, be it the sons, the daughters, the families, the parents, the patients. Educate everybody involved with the patient's care. We review monthly labs with the patient and the doctors. We round with the doctors, social workers, and charge nurses as they're available at least once a month. Generally Mondays and Tuesdays we round. We also assess and educate our home patients who come in once or twice a month. There have been occasions where we've actually gone into the home, actually not since COVID, but we've gone into the home for patients who say were hospitalized for a long period of time and were so debilitated they couldn't get here to the clinic. So we've actually done some home visits as well with the doctors and nurses. We recommend medications, protein supplements, vitamins, parental nutrition. We interview, assess patients. We assist them with obtaining medications as needed. That's a job that we do along with usually our nurse practitioners, doctors, social workers. If patient get acquired medications, sometimes we give them samples. Sometimes we're helping with prior authorizations, financial assistance, those kind of things. Everything is documented. Wherever you go, if you don't document, it didn't happen. So always, always remember that. No matter if you're a dietitian, nurse, doctor, if you don't document, it didn't happen. I am actually a care plan coordinator. I'll go into that a little bit later. We have coffee meetings once a week, once a month. I'll go into that later also. And then there's the regular team meetings amongst all the staff here, the main staff, dietitians, social workers, nurse managers, the administrative assistants. We all come together about once, maybe twice a month to talk about anything. Lately it's been, COVID or maybe new medications that we're bringing into the unit, whatever it might be. Okay. So the renal diet, is it the same for everyone? No. You can't do, back in the day when I was in the hospital, the renal diet was, 60 gram protein, 2 grams sodium, 2 gram potassium, whatever it may be. It's not the same for everyone. Our diet is specialized for each individual patient. When the patients first come to me, I give them a general overview of the diet, but I really can't counsel them specifically until I see their lab values. Also, you have to look at any past histories. Do they have CHF? Do they have diabetes? Do they have any skin infections? Do they have any wounds? Have they had any surgeries? Are they having trouble with chewing and swallowing? So all those things go into play when you're talking about the diet with the patients. So the main components of the diet are definitely sodium. That's number one. I do tell all my patients, even initially, sodium will be restricted. Sodium is very important, of course, to help regulate blood pressure and blood volume. Your body needs sodium for your muscles and your nerves to work properly. We encourage the patients to avoid salty snacks and salt substitutes. Salt substitutes can contain potassium. It's a little hidden source of potassium, so you have to be careful of that. We discourage them adding salt at the table, salt when you're cooking, avoiding canned, processed, smoked, and pickled foods, avoiding cheeses that aren't low sodium, definitely deli meats. Excess sodium can cause fluid retention. Sodium tends to draw fluid into the body. It's very hard to get rid of the fluid if you follow a high salt diet. Patients with fluid retention also usually have shortness of breath. Of course, fluid retention leads to weight gain, and it could also lead to elevated blood pressure. So our general recommendation is about 2 grams of sodium per day. And then for potassium, that is a restriction. Not all of our patients are on a potassium restriction. Some are actually on a more liberalized diet, but I'd say probably 90% of our patients need a potassium restriction. Potassium is important for normal functioning of the heart, the nerves, the muscles. It's found mainly in fruits and vegetables, but also in dairy products, in beans. Main sources are oranges, potatoes, tomatoes, bananas, cantaloupe, and sweet potatoes, many more. High levels can cause cardiac abnormalities, even heart attack, respiratory failure, nausea, vomiting, muscle weakness, and I've even heard patients say they experience a temporary paralysis. Low levels or hypokalemia can occur if a patient has nausea and vomiting. We have some patients who have chronic diarrhea and they tend to run very low potassium levels chronically. And those patients actually, if their potassium levels stay low for a period of time, they can actually give them some more potassium during dialysis. It's called a 3K bath. Most of our patients are on a 2K. Our general recommendation is 2 grams of potassium per day. Our PD patients, although they have a little more liberalized diet, and they usually can tolerate a 3-gram potassium. Other components of the diet are phosphorus. This is the hardest thing, the most challenging thing to counsel your patients on, and the most difficult thing to control and get within normal limits when you're looking at your lab values. Phosphorus is an important component of your cell membranes and your bones. The main sources are dairy, beans, nuts, chocolate, beer, cola, processed foods, and deli meats. But lately, even if you look at items, even maybe your apple juice, whatever's kid juice, maybe out there, your iced teas, whatever it may be, a lot of them contain phosphorus additives that they use as preservatives, and those are that's called inorganic phosphorus, and it's harder to get rid of than any other type of phosphorus. Say regular phosphorus that's found in dairy products is organic, and that's a little easier for your body to get rid of, but these preservatives make it very difficult to get your phosphorus levels under control. And a lot of patients, because of that, are on something called a phosphorus binder. And there's multiple phosphorus binders that our patients do take. And they take between, it could be 1 pill with meals, or they could take up to 6 to 8, I've seen, with meals. And they're rather large pills. Hyperphosphatemia can cause itching, red eyes, increased risk of bone fracture, and secondary hyperparathyroidism, which I'll talk about. That's a high PTH. Hypophosphatemia is very rare. I usually only see this in patients who are not eating well, maybe patients that just came out of the hospital. Most patients are asymptomatic until late in the disease. Symptoms are muscle weakness, bone softening, and neuromuscular problems. Protein. We can't emphasize this enough with our patients. Protein is measured by albumin. It aids in growth and maintenance of body tissues. It aids in wound healing and fighting infection. Low levels are directly related to increased mortality in renal patients. The best sources are meat, poultry, eggs, fish, and dairy, although we have to be careful with dairy because of the phosphorus and the potassium content. And our protein needs for our patients are 1.2 to 1.3 grams per kilogram, a little bit higher for our PD patients. And you see the PO4 limit, the phosphorus is generally about 800 milligrams per day. So fluid. Fluid is very difficult for some patients. They really need to restrict their fluids, and the reason for that is because kidney patients don't urinate as much as you and I do. Some don't urinate at all. Some have normal urinary output, but the majority have diminished output. So the general rule with fluid is 1 liter per day, plus whatever they're urinating, whatever their urine output is. Sources of fluid are beverages, foods with high water content like lettuce and fruits, any items that are liquid at room temperature, so that would be like ice cream and jello, ice pops, soups, and ice. Overhydration or fluid overload can lead to edema, swelling of the, usually in the feet and legs, but I've seen it in the face and the abdomen. Could lead to high blood pressure and shortness of breath. Our general restriction, like I said, is 1 liter per day. It can vary on the patient. If they're urinating a great deal, it can be as much as like 1.5 liters per day, but generally 1 to 1.2. Calcium. Calcium is a building block of bone. It's important for muscle and nerve function. Your sources are dairy, green leafy vegetables, fortified juices, medications, and some fish. Hypercalcemia. Symptoms may include decreased appetite, nausea, vomiting, abdominal pain, confusion, irritability, and coma. Long-term hypercalcemia can cause calcium deposits in the joints, soft tissues, eyes, and blood vessels. Low calcium or hypocalcemia symptoms include numbness, tingling, seizures, and muscle twitching. I usually see if patients have low calcium, they usually tend to get tingling or numbness like in their fingers and their toes. Okay, nutrition assessment. This is performed upon admission. Patients first come to the unit at 3 months and then annually, or if a patient is deemed unstable, which I'll go into later. Oh, I do have it there. A patient could be unstable because of multiple hospitalizations, weight loss, or psychosocial factors. We assess height, weight, BMI, GI symptoms. We'll ask if their appetite, is good, fair, poor, any nausea, vomiting, diarrhea, constipation, heartburn, change in taste, any difficulty chewing, swallowing. A lot of the questions that you guys have probably asked any patient that you're interviewing for the first time. We also will ask if they have any itchy skin, which is very common for patients with high phosphorus. Do they have any wounds, especially if they've been in the hospital or they're bedbound, they're not moving around a lot. Or they may have had surgery, amputations. Do they have any edema or swelling? Are they dizzy, short of breath? Do they have any loose or missing teeth or ill-fitting dentures? Do they have any sore or bleeding gums? Then we'll ask, and it's great if a family member comes with a patient when they have when they're assessed, but they don't always come with somebody. But we want to know who does the cooking, who does the shopping, who does the housework. We want to know that because we may need to educate that person who is helping them with cooking and shopping. We want to know if they exercise. We want to know their activity level. We ask how often they eat out, where do they eat, to kind of get an idea. Are they eating mainly fast foods? Are they eating healthy foods? We also interview them to see if they have any cultural or religious beliefs that may affect their nutrition intake. So do they avoid pork? Are they vegan? Are they vegetarian? So that's all going to affect their diets. Also, you want to ask them, do they smoke? Do they drink alcohol? Do they abuse drugs? Are they urinating like I went into before? You want to know if they're urinating and how much they are, if they know. They generally don't know. Some patients do. Do they salt their foods? Do they use salt substitutes? Because you want to educate them on the salt substitutes because many contain potassium. Are they consuming protein supplements at home? Protein bars, bread, cereals, shakes. And then the patients that have been here already for a while, they're tolerating the protein supplements that we provide. You want to go and look at their past history. Do they have diabetes? Are they checking their blood sugars? Do they see an endocrinologist? Do they have any malabsorption syndromes? Are they having chronic diarrhea, nausea, vomiting, gastroparesis? Any cancer? Are they going through chemo treatments? Because that will affect their intake. What is their lipid status? Do they have any neuropathy already? Do they already have pain or tingling in their extremities? Do they have CHF? Which you know they're going to have to really, really watch their salt and fluid intake with that CHF. I already went into that with the diabetes and if they're avoiding sweets, are they taking insulin, or if they're taking oral meds. Again, allergies, any food allergies, foods they're not tolerating, foods they're avoiding. How well do they know their diet before they come to you? Are they following a special diet? Did they see that dietitian in the hospital? Were they able to get a good education before they came to me? Most likely it's a no. If you guys know by doing your rotations in the hospital, it's very difficult to educate patients in the hospital. They may be in pain, they may be tired, there's lots of interruptions. It's very, very difficult to educate a patient in the hospital. And pretty much that's the last thing they really want to know about at that time. They want to, they want their food when their food's coming and they want good food, but they really don't care about their diet. They just want to get out of that hospital. So that was something very frustrating when I was working in the hospital. I had all this good information I couldn't wait to share. But the patients weren't always receptive. Here, the patients are receptive. They know that if they follow their diet or don't follow their diets, they are going to feel either really good or really bad. So you really feel important doing this job. Also, before your patients come, you want to know if they're on any vitamins already. Are they taking any of those phosphorus binders? Do they know what they are? Are they taking any multivitamins? A lot of patients are on vitamin D or calcium supplements. So you want to know all that information, especially when your labs come back. If you have low calciums, high calciums, you want to know if they're on any calcium supplements.
Tina, can I ask you a question?
Yes, definitely.
It's Willie here. You mentioned supplements. Two questions, two-part. Are there any ones in particular that maybe you would recommend for your patients that are looking to take something because they can't eat as much as they would like to? And second part to that question, if someone is recommended to have supplements, does insurance cover it or they have to purchase out of pocket?
Okay. Supplements are not covered by insurance.
Okay.
Some of them used to be, but they're not. There are some supplements we can help the patients with. Some of the drug companies have
Renal ones.
Yeah, like Nepro is one thing that we recommend. That company, if they buy in bulk, they can get a nice discount versus getting the Nepro at Walmart, Target, or even their pharmacies.
Okay.
So we can get them a nice discount. So we have a special form for them to fill out.
Okay.
So Nepro is number one. The only thing, it provides extra fluid, just 8 ounces. So they have to include that in their, in their fluid intake. We do also have here, we have something called Protein X. You guys may be more familiar with something called Prostat. Or sometimes they just call it like a liquid protein supplement at some of the nursing homes. That is 30 cc's, like 2 tablespoons. It provides 18 grams of protein. It is sugar-free, but patients find it very sweet and syrupy. And it also almost has like a vitamin-y taste. That is something some of our patients do tolerate. We have another liquid supplement. It's called Liquicell. So same thing, 30 cc's. Also here we have it's called the Gelatine Plus. It's really cool. It's a 20-gram protein jello. It's 4 ounces. Again, it's very sweet. It has a lot of carbs. I have tried all of the gelatin sugar-free jellos and they are disgusting. I don't think any of our patients would tolerate them, so I haven't even ordered them. Another thing we do have here, fortunately, is Zone Perfect protein bars. Those are a big hit. Patients actually kind of hoard them a little bit. We limit all of our supplements to 2, but some patients will they'll ask one nurse for their 2 bars, and then they'll ask another nurse while that nurse isn't looking for 2 bars. But the Zone Perfect bars have been amazing. We actually have, out of all the DCI clinics, one of the highest protein rates here. And I think that is because of the protein supplements. Our doctors here strongly believe that if the patients keep their protein levels up, their albumins up near 4, that will have less hospitalizations. So we do strongly encourage the supplements here. There are some other supplements that patients that we do recommend, like Boost Glucose Control is a good one for diabetics. It's not very high in phosphorus and potassium, so that's another one I recommend. And also there's, what is it? There's used to be like Boost Breeze. I don't know if that's out anymore or in Live. Those are fine. Those are like a clear liquid supplement. So if patients are having like chronic diarrhea or malabsorption syndromes, those might be better tolerated by them. A lot of the patients will complain that like the Boost Glucose Control, the Nepro, sometimes it gives them diarrhea. I think it's so much stuff in it. The Nepro is like 19 grams of proteins, 470 calories. That's another thing. It's a really big calorie source. So you don't want somebody who's maybe obese to be drinking, 2 Nepros a day. That is great for people who are just at the hospital that may be underweight, need to gain some weight, also who are urinating. If they drink a couple of Nepros a day, that it does amazing things. I've seen the Nepro really help our patients get their protein levels back up. It contains a lot of vitamins too for them, and it's very low in phosphorus and potassium. So I love Nepro.
Excellent. Thank you, Tina.
Sure. So within 2 days of the patient's admission, we usually have their lab results for them. So we'll sit with them chair side and we'll again go over the diet. And now we can go into the diet a little bit more and specialize it just for them based on what their levels are. So we'll get kind of an idea what they were doing at home, what they need to work on. Most patients, their protein levels are not good. Most of them have been hospitalized. It could be days or weeks or months prior to coming to us, and a lot of them have low protein levels. So that's something we always push. The salt restriction, definitely. If they have low blood pressure, we can be a little more lenient, but usually sodium we do restrict. A lot of them do come to us. They're very edematous usually when they come. They usually have a lot more swelling before they come here, but a lot of them still have residual swelling, so we definitely have to watch the salt and the fluids. The potassium, like I said, we'll know when we get their lab values. Some of them are low. Some of them may have vomiting, nausea and vomiting. It's a common symptom. Those are uremic symptoms, they call them. It's very common for a patient to have nausea, vomiting, and or diarrhea when they come to us. So they may have low potassium in the beginning, and we don't have to restrict that so much. Phosphorus too. Some patients start off, they're not on any phosphorus binders, but as time goes on and they're eating better, they usually end up on a phosphorus binder. So you'll see the general guidelines there. We look for an albumin greater than or equal to 4, phosphorus 2.6 to 5, potassium 3.8 to 6 for hemo patients. It's a little lower for peritoneal and home dialysis. PTH, parathyroid, less than 600, calcium 8.4 to 10. Hemoglobin A1C, you'll see it's less than 7%. It's a little higher than you guys are probably used to seeing, but we're a little lenient with that. Cholesterol less than 200, triglycerides 150. We do cholesterol and triglyceride levels, but they're not fasting levels. So, if their cholesterol is up around 300, then yeah, we'll counsel them. But if it's 230, say, it's they've eaten usually before their blood test, so we'll tell them it's high on the high side, but they should get a fasting level at their primary care physician. So our general proof. Yep.
Just one quick question. How often do these patients usually get lab drawn?
Okay. Generally once a month.
Okay.
Usually the beginning of the month. And if something is way off, say they come back with a potassium level of 6.8, then we will redraw that usually a week later. And we'll keep on top of those patients because we want to know there may be something they're chronically eating and we just need to figure out what they're eating. Sometimes they also need to go on, it's called a potassium binder they have out now. There's actually 2 potassium binders. They do still use Kxalate, but that's a little rougher on the patients. 2 of them actually have sodium in them, so you have to watch the sodium and the blood pressure and the fluid. But there are potassium binders now, which are pretty awesome. There's one called Valtassa, which isn't tolerated as well because it's very gritty. It's a powder that they mix with water. It doesn't mix well, but it does bring down the potassium, and we have found it to bring down phosphorus also. So if they tolerate it, it's awesome because it usually brings their phosphorus levels into normal range too. Okay, and the usual calories are 25 to 30, a little bit higher for our peritoneal patients. Diet education is ongoing. It can vary from month to month. You may have a patient who's really good with potassium, 8 months out of the year, and then the other 4 months they have high potassium. You may find in the summer that they're eating tomatoes from their garden. Or I had one patient, she always had good potassium, and 1 month she came with a really high potassium and found out she was binging on peanuts. She said, I don't know what happened. I just eat a whole can of peanuts. And so it's just ongoing. Sometimes you just need to remind patients, it's amazing that they forget, like orange juice. I have so many patients who've been here for years and they'll come back with a high potassium. Oh, are you drinking any juices? What are you eating? I find out, oh, I've been drinking some orange juice lately. What? You've told them that till you're blue in the face that, to watch out for orange juice, but they just seem to forget sometimes. So it's constant education and reminding them. We do round at least once a month with our patients. I love to round with the doctors when the results first come in, the lab results. We hand out the patients report cards. We usually have all like the albumin, the phosphorus, all those general, those labs there with the goals and then at their actual range. And we'll actually put smiley faces and stickers on their report cards, just like when you were in school. And the patients really look forward to seeing the smiley faces and the stickers every month to show, that they're doing a good job.
Would you mind if I ask a quick question?
Sure.
Sorry to interrupt. So for these labs, are these for just like all of your like peritoneal and hemodialysis and just end stage renal, or is this categorized to which population or just a general?
These labs that are on the screen right now, the only one that is different would be the potassium. We're a bit stricter with potassium, 3.8 to 5 for peritoneal and home, because hemodialysis patients are getting dialysis 3 days a week. Peritoneal and home dialysis patients are doing 5 to 7 in general.
Okay.
There are some home dialysis that are doing a little bit less, but most of them are doing more than 3 days a week. So we would expect their potassium levels to be better. PD, they're doing, most of them are doing dialysis 7 days a week. So they should have better levels of potassium, which means they should also have a more liberalized diet because they're constantly doing dialysis. And they're doing for longer lengths of time. Hemo is usually about 4 hours. The peritoneal lin is between 6 and 12 hours, right?
Yeah.
About 6 to 12 hours. So it's a lot more. It's definitely more gentle, but it's a lot more dialysis. Okay, let me just see if I'm getting back on track. Yeah, on rounds with the patients, I know we go over their labs or report cards. We'll assess them for any changes in their health. Were they recently hospitalized? Do they have any new wounds? Any changes in appetite, nausea, vomiting, diarrhea, and changes in chewing and swallowing? Are they tolerating their medications? Is their phosphorus high because they can't swallow the pills anymore? Are they making them nauseous, giving them diarrhea? And I really enjoy rounds because I find, whereas in the hospital, I remember leaving Post-it notes everywhere in the chart for the doctors. I don't know if you guys are still doing that, but here we actually have like a good say. The doctors will actually, you know, if a patient's phosphorus is high or their calcium is high or calcium is low, the doctors will actually ask me, you know, what do you think we should do? I love that. You feel like you actually have some power, you have some input. I feel like what I have to say and what I learned in school it actually matters. It's frustrating in the hospital, leaving Post-it notes everywhere and still going back a week later and still seeing the same Post-it note and your recommendations weren't taken. We can actually enter supplements too. We can add and take away supplements, you know, in the computer, put in the orders for those. So that's some power that we have. I don't know if you have that power in the hospital. To add and take away supplements. But we used to have to leave little Post-it notes for the doctors and pray that they ordered the supplements for us. Next, I'm going to go over PTH. We will get to Lynn very shortly. Yes, the next slide. So PTH, this is another thing that goes along with having kidney disease, having a high parathyroid hormone, but having high PTH. So PTH is your parathyroid hormone. It's made by the parathyroid glands, which are located in the neck near the thyroid. What does that function? It regulates calcium and vitamin D levels in the body. And a healthy dialysis average level is less than 600. That's our desired level for optimum bone health. In kidney disease, the kidneys are unable to make vitamin D and remove toxins such as phosphorus in the body. The parathyroid glands will make more PTH to break down the calcium in the bone to compensate for the lack of vitamin D production by the kidneys. If PTH gets too high, more calcium is removed from the bones, and phosphorus levels will also increase in the body as a result of worsening kidney failure. The combination of high levels of PTH, calcium, and phosphorus result in bone damage, calcification of blood vessels, and also, as you see in those pictures there, those are calcification of the skin. You'll see skin breakdown. You'll see like the black scabs there on the fingers and the white parts. That's calcification. Also, is calcification in the bone. So they're also having calcification of their blood vessels. And this is all very frustrating for us as dietitians and the doctors, because a lot of times like that calcification in the bone and the blood vessels, the patients don't always feel anything from them. It's usually too late, you know, when really bad things can really happen to them. So you're trying to tell them that, you know, your PTH is high, we need to do something about it. Your phosphorus is high, your calcium is high. You need to do this, that, and the other thing. You know, watch your diet, take your binders. Unfortunately, if they're not having symptoms, they won't take their binders. They won't, you know, they're taking enough pills already. They don't always want to take that phosphorus binder because they're not itchy. They don't have any skin breakdown. They don't know that their blood vessels are full of calcium. So phosphorus is really, really difficult to control. Symptoms of high PTH can be decreased appetite, nausea, vomiting, abdominal pain, irritability, itchy skin is number one. Bone pain, actually, a lot of patients will have bone pain when their PTH levels are high. I have noted down there some things that are lower in phosphorus. I already went over some things that are higher. Those are like beans and your dairy products, chocolate, beers, colas, nuts, and seeds. Things to lower PTH. One thing that definitely lowered is parathyroid surgery, but we want to try to avoid that as much as possible. We do have a couple of medications. We have an oral medication called Sensipar. We do try to start that. If the patients have normal to high calcium levels, we'll start them on Sensipar A lot of patients don't tolerate that. They get nausea, vomiting from that. So we can put them actually when they're on hemodialysis on an IV medication called Parsabiv. So that patients have been able to tolerate a little bit better. We may also, if sometimes patients have a high PTH, but their calcium levels are normal or on the low side, we can actually prescribe some vitamin D supplements. Sometimes that brings it down. Also getting their phosphorus under control. A lot of times if their phosphorus is very high for a long period of time, we'll find that their PTH starts to climb. So we encourage them again to take their binders, follow a low phosphorus diet. Any questions on that, guys? Okay, we're gonna have Lynn speak in just a minute, our home nurse. I just tell you, generally, we see our patients twice a month in the home clinic. Usually they come in for their first visit for their lab work. Things have changed with the pandemic now. Sometimes we do the clinic visit all in one. We draw the labs and we do the clinic visit, which I don't like too much because I have their labs only from the previous month. So I just know what they, kind of were eating and doing the previous month when I'm seeing them that month. And I'll have to usually give them a call when their lab results come in to kind of tweak whatever education I gave them during their actual visit. And we're also seeing some patients via Zoom. We call them telehealth appointments. You guys probably all have them yourselves. So we'll talk to the patients just like I'm looking at you guys right now, talk to them and kind of try to assess them just via Zoom. I really much rather see them in person, but we want to keep them safe. So, yeah, the best thing to do is to have them in for their monthly labs, review them, and then see them again later to review their labs and assess them again. Okay, so their diets are generally a little bit more liberalized. They may be, because they're doing dialysis 4 to 7 days a week, they can tolerate a little more fluid, a little more potassium, sometimes even a little more salt. So that is definitely a plus. And also the dialysis, as Lynn will go into explain, is it's definitely a lot gentler on the body because they're not trying to pull all those toxins out of the body within 3 days and 4 hours per treatment. So they're doing longer treatment and it's much gentler on the body. So I'm going to hand it over to Lynn right now, and she's going to tell you a little bit about home dialysis. So Lynn, do you want to come over here? Or are you good over there? I don't think so. As long as your speaker's not on, you should be okay. Hello? Is your speaker on? Maybe just mute your speaker. Sorry, guys. How do you do that? Huh? How do you do that? Just come over here. Just come over here.
So I muted Lynn's because there's too much background noise. Can you guys hear me?
Hi guys. My name is Lynn. How are you?
Hi.
Hi. I just came out of the hospital I was working there for about 24 years. I was about 19 years in dialysis, hemodialysis. It was great, but I wanted to expand my knowledge. And, dialysis is going to the homes now. So I really wanted to do home hemo and learn PD. There's one takeaway that I took from the hospital about nutrition. A patient, I keep hearing, nobody taught me how to measure my fluid. So I would go in and teach them to buy a Coke bottle or any bottle, empty it out, either 1 liter or a 2 liter, depending on if they're in 1,000 fluid restriction or 1,500. And then I would tell them to pour it in to the Coke bottle after they're done drinking like their coffee. And this way they'll know how much they have left for the rest of the day. Also in the hospital, those people love those pictures sometimes we have to take them away. They love to fill it with ice, and they don't realize that the ice really counts. They can fill that ice about 3-4 pitchers a day. So, just keep your eye on that too. So now I just want to go into peritoneal dialysis. People do this at home. It's about 4 to 7 days a week, more like 6. And they're going to, let me just, so before they even start PD, they're going to have a consult with the surgeon. And first of all, the nephrologist is really going to decide what dialysis that they're going to do, home hemo, or peritoneal. So now they're going to consult the surgeon. They're going to have their PD catheter placed in the pelvis. Tina, can you help me with the camera? Now there's 2 types of catheters that can be placed in an area in their chest, which is more for like obese patients, and more for like obese patients and people with ostomies. So after a week, the nurse will assess the dressing, the site, see if there's any drainage. They may have some mild pain, but it usually goes away like a day or 2. So they're going to check it for any oozing, any redness, any signs of infection, oozing around the catheter. And let's see, I just lost my train of thought. So they're going to flush it with like 100 cc's of solution. It's a dextrose solution. It's low calcium peritoneal dialysis solution. So we're going to flush them, just to flush, just to make sure the catheter is patent. Now you may see a little blood drain out, but that's okay. That's from the surgery. You may see that with their periods. Sometimes it'll be blood. The fluid goes in a catheter into the peritoneum. That's your whole belly, all back here. It fills in all the space. About 2 liters. It could be manual, which is about 4 times a day, where they put it in, they'll drain, they'll fill, and then they're dwell. And then they can go to work. This is manual. And they can drain. It has to be in a clean area. They have to drain, fill, and then dwell again about every 6 hours, 4 to 6 hours. And then they do it again at night. And then there's another one that is the machine. Now, the cycler, they do it at night. It's about 1.5 to 2 hours, about 6 times during the night, 4 to 6 times. And that's how they get their dialysis. And then they'll be empty during the day. Now, when they're manual, the people have to hold this in during the day. So they may feel full. They may just, a little puffiness to their abdomen. So they might be a little self-conscious. And let's see. Basically, the people are much more happier doing this. They're able to work. They're able to have more control at home. They don't have to come to a dialysis unit and sit there for 4 hours without control with 2 needles in their arms. They have a catheter in their chest. That can only last maybe 6 months to a year. It's in their heart. We don't recommend that. So, we recommend them to get either a fistula or go right to the surgeon and get a PD catheter. We have to teach the patients not to wait until they're into CKD 5. You want to teach them about this around CKD 3 or 4. And you want to prepare them. A lot of people out in the community are not prepared. They wait until they're super sick. They wait until they're full of fluid. They're yellow. They have encephalopathy from the uremia. And, we want to educate them. that you want to be healthier. So they have this, it's a good option. They teach the families. Usually you need, another person, and we teach them like about 2 weeks into it. And then, well, no, we're constantly teaching. We're teaching before and throughout the whole time, but they're very independent. They don't recommend it for people who have dirty houses, who are dirty people, like, don't take care of their hygiene and all because of risk of infection. You don't want to have, every time you have an infection, it ruins the peritoneum wall. So after a while, and also the fluid also ruins the peritoneal wall. So after a while, they're gonna have to switch over to hemodialysis. So I think that's about it. Any question? Oh, also with the catheter, sometimes it's down in the pelvic girdle, and it can get like stuck against the wall when they're emptying or like curled up. So sometimes we leave a little bit of fluid left in, so it'll float up. We will drain them, but we'll leave like maybe 100 cc's in the belly so the catheter will float. That'll prevent, most of the time they'll feel cramping, not most of the time, but there's a chance that they could feel cramping when it's going in, and it'll go may go up to the shoulder, but it usually abates. So any questions? This is my first Zoom, guys, so I'm public speaking a while.
So I do have a quick question to either of you. This is Utpala. You can hear me?
Yes.
Oh, okay. So the earlier lab screen that you showed before, I know you mentioned it was for in general. And then if the levels are well controlled, the diet is liberalized. So for in PD, are the labs still done every month, or because it's being done so often, do you still monitor them often?
Usually it's done every month, and as needed. But yes, done every month.
So again, if the patient has very high potassium levels, or say very low potassium levels, if they're like 3.3 potassium, we may want to redraw it. Same thing if the potassium's high. Sometimes the calcium is very high or very low. We might ask them to come in and have it redrawn. During the pandemic, what we've done also, so they don't come to the clinic, we may ask them to have their labs drawn at an outside lab too, and we'll get the results that way.
Okay. I was only thinking because if they're getting the PD done so often, like every day, for so many hours, does it affect, do you want to monitor their levels more often? That's all.
Usually they're told by the doctor to watch their diet, or like Tina can give, they'll test it, right?
Yes,
the potassium binder, or they have to do more dialysis. So, they add more dialysis, more dwell time. Maybe add another, hour, have it dwell. And then they may add another cycle or another day. So usually it's about like 4 to 6 cycles a day. So, and then they'll retake the lab work.
Okay.
And then also with the hemoglobins, PD does not make them, makes them less anemic than hemodialysis. Hemodialysis, you're spinning their blood, it picks up clots. It doesn't pick up clots, but it starts to clot the tubing. So you're losing blood like that. And then when you rinse them back, you don't want to give them all that saline. So it kind of looks like Kool-Aid, and that's their blood in the dialyzer, and you're throwing at their blood pretty much. So they're more anemic than PD patients. PD patients, are less tired, have more energy. So But like I said, the doctors really need to start educating the patients and, having the community come to us to get them prepared before their kidneys go into CKD 5.
All right, thank you.
Yeah.
I have a question for Lynn and Tina. For the PD patients, like you said, they're using that, you do the dextrose flush. Do you take into account like the dextrose in the dialysate into their needs? Like, do you?
I mean, it adds a few calories, but yes, with diabetics, you may have to adjust their insulin, their pills. They may have to take their sugars. They may absorb a little bit of it, but you have to just regulate it.
Okay. And also, you said you recommend the PD catheter is what you normally recommend as opposed to the chest catheter.
Right.
Okay.
Yeah, the chest catheter is really just for obese people and people that have ostomies and stomach surgeries like that. So it goes up here.
Okay.
And it does the same thing.
Sorry, I'm just trying to like understand everything. So the one that you said the difference is some people can do it overnight. So
Yes.
So when they do it overnight, they have to like basically do the dialysis every, you said 1.5 to 2 hours. Is that what they have to do at night?
Well, the machine does it. The
The
machine will
machine does
constantly,
it.
yeah, drain him, put it in, dwell. Yes. Drain, fill, dwell. It'll constantly do it.
And is that, you think that's easier than like going to work, you said, and bringing that like bag around?
It's entirely up to the patient. The thing is, sometimes the cycler keeps them up all night and they don't sleep because of the alarms. I mean, sometimes, they're not draining well, so they have to stand up. They have to change their position. So we get a lot of complaints like that. Their spouses are getting kept up. But yes, I mean, and then they have the rest of the day, to themselves, unless they have another fill in the morning and carry it around with them.
Okay, thank you.
Yeah.
I have a question. Has there been like a shift in the dialysis, like patients with dialysis, in them doing more PD? Is it more common now, I guess is what I mean?
I don't know.
I don't think it hasn't increased. I've been here for almost 6 years now, and I'd say the numbers have been pretty stable patient-wise for us. We generally have about like 23 patients on PD, and I know the government has pushed for more home dialysis, but I have not seen a big increase.
Yeah, I heard something like 2025, they're trying to push more people towards it.
They definitely are trying to push more people to doing, home dialysis and peritoneal. Home dialysis, Lynn may have a little more to say about that, but that is very, very involved with training.
Yeah,
there's a lot that goes into that. You're dealing with blood and needles, and that takes weeks and weeks of training, whereas a patient on peritoneal can be trained within a week or two and then go home. So that's why we really push the PD. If they're a good candidate, if they don't have a lot of scarring and stomach issues, and they can get the catheters, the PD catheters, we definitely want to push for that.
Yeah, we want them to be more independent.
Right.
A lot of them, they don't want to be hooked up to a machine, and also that they need a family member to help them and watch them and stay there and hit the alarms while they're, hooked up to the machine, because they're hooked up like this. And
that's for the hemo versus
hemo,
PD.
right, versus PD, right. Yeah. So, but yeah, we are pushing. We get a lot of young patients that come for education, and they start hemo. A lot of them come over from other countries, and they are so sick. They come here for the medical care. So, they're young, 20s. We want to do the PD with them. We want them to, have fun, and, there's a lot of depression in dialysis. You have to really watch for that. one guy, he didn't want to come anymore. And was PD allowed? Emergency Medicaid or no?
Yeah.
Yeah. But my hospital didn't push for a PD. I don't know if it's a money thing but they didn't really push for our patients. So you guys have to be advocates for our patients. Thank you guys.
Thank you.
You.
Thank you.
Thank you.
Okay, I think I have a little more time. I don't bore you guys too much. Did you have any other questions about home dialysis at all?
I had a question or diet related. I'm just curious, when you have patients who are obese, which I'm sure you have a lot of, what weight do you use to determine their needs? Like, do you use their actual body weight or use some kind of like adjusted body weight? Like, how do you calculate?
Adjusted. We use adjusted, definitely.
So I know there's like different, like which adjusted formula do you use?
So I use their actual minus their ideal. And then I multiply that times 0.25%.
Oh, okay. Okay, yeah, so that's what you use.
Is that what you guys are still doing, or it's been a while, but that's what we do.
So use that for protein and calories and fluid and everything. Okay.
Yeah.
Thanks.
Mm-hmm.
And Tina,
you continue to adjust as your labs come back too. I mean, and you track their weight gains and stuff like that. So, but yeah, if they need more protein than that, of course, we'll recommend that.
And I think Stevie asked this question, Tina, about the dwell time with the diastole or the peritoneal. You do count some of those calories in there, correct?
We do. Most of our patients, I'd say at least 75% don't really see any true weight gain. I find also that, especially if they're doing like that day dwell, like some of the patients some will just do dialysis overnight. So all their stuff is done kind of while they're sleeping. And they don't have anything in their bellies during the day. But some of them do, especially as time goes on, that the peritoneum doesn't work as well with diffusing the toxins. So a lot of them will have a day dwell in, and that sometimes affects their appetites. So I think that's why we don't see a lot of weight gain also. But I have had a couple of patients complain that, they've gained weight. So we try to encourage, since they are more active usually and feeling better, to exercise. So not that I don't encourage that with all of our patients, but definitely encourage the exercise. So this is the supplements. Actually, they're here on the screen. There was another one, definitely whey protein powders. They're awesome. I do encourage patients to use those. The pea protein also, but the whey protein, they can add it to, like I said, when they're making their oatmeal, if they want to add it to their water before they make their oatmeal, if they're cooking it on the stove, and then using that as their liquid to make their oatmeals, add it to pancake mix, add it to French toast mix, make smoothies, again, watching your fluid. It's a very easy way to get, 20 plus grams of protein in. So the whey proteins are another great thing. There also are tons and tons, you guys see in the grocery stores, there's cereals now, there's oatmeals, there's high protein breads. It's amazing our patients can't keep their protein levels up because they're putting protein in everything. They're adding, like I said, they're putting protein in everything. There's so many high protein bars and things like that. The bars we have to watch, I tell the patients too, if they don't like the zone bars, they're actually kind of sweet. The carbs are up there. I think they're a little over 15 grams of carbs per bar. I encourage them to get a few bars, find one they like or a couple they like and bring them to me or take a picture of them so I can just make sure they're not high in phosphorus or potassium. You'll see they're putting a lot of chocolate and peanut butter in bars, so that can increase the phosphorus and potassium levels. So they need to watch with that. But you know, the ultimate goal is to have them eat actual food with protein in it to get their protein needs to meet them. Something else we have for some patients, there's some patients who are just don't have the appetites, or maybe have chewing, swallowing problems, or constantly hospitalized. We can recommend IDPN or IPN. That's a parental nutrition. So it helps, not a great deal, but I have seen it help a little bit with protein. I think it helps them more with their energy levels, fighting infection, things like that. Like you won't see the albumin jump from, you know, 3.1 to 3.6 within a couple months. I might see it go up a couple of tenths from 3 to 3.2. It doesn't seem to increase the actual albumin much, but I find that they have more energy and are hospitalized a lot less if they tend to run low albumins and they're on this parental nutrition. And in hemo, it's awesome. It's hooked up, you know, the bags, you see the picture down there. The bags are hung during dialysis and the protein goes in as they're getting their dialysis. So it's no extra time on the machine. They don't feel anything. They don't have any symptoms. Been lucky enough for that. I haven't used the lipids. You don't want to use that if you want to get some more calories into a patient. I haven't used it because there are more side effects, and most of our patients are at their goal weights. I do have a few that are underweight, but most of them are at their goal weights. In PD, I don't use this as much, but there is a bag, just like Lynn showed you that bag of dialysate. They actually make a special bag for the peritoneal that filters and it goes right into their gut and they absorb the proteins in the bag, just like the other bags that they use for dwelling. So how much more time do I have left?
So, well, we were thinking you could go till 10:30. So, and if you go less than that, we'll just give everyone a break and Josephine will be in at 10:30, whatever you decide.
Does everybody want a break or do you want me to talk more?
I have one question I can ask you.
Yes.
It's Willie again. Have you had any of your patients coming to you and asking you about deactivated yeast?
I have not.
Deactivated yeast is at 2 tablespoons, actually provides like 8 grams of protein. It's yeast that no longer works in raising bread or anything like that. And vegans use it a lot to add stuff to their food because they don't have
Is
a lot
it
of high
also
protein.
called just nutritional yeast?
Exactly, yeah.
Okay, because I've used that also. Okay.
Yeah. Deactivated, yeah, that's what it's yeast that doesn't rise.
Okay, yep. Nobody has asked me about that.
Because it has a cheesy, nutty flavor to it, so
it does, right. I know I've played around with it myself.
Yeah, my wife and I just started to play around with it.
Yeah, I haven't had any patients ask me about that. I did recommend it to one patient because they loved popcorn and they were buying, you know, the microwave popcorn. This is one of my patients who I educate over and over and over again on phosphorus. And trying to find him snacks that he likes to snack on. His phosphorus 1 month was like 8.8, supposed to be 5, right? So I asked him what he's eating, you know, and like, what are you snacking on? Because I know he's a big snacker. He's a big guy. He goes, oh, my wife got me these great trail mix bars at Costco. Trail mix is like a total no-no. Trail mix has the nuts and the seeds and the chocolate and the raisins, all stuff that you know they really shouldn't be eating. And then I asked him how many you're having per day, and he said 4. So it's not 1 bar, you know, he's indulging in and taking his binders with. He was having 4. So I recommended some popcorn recipes for him. I tried to encourage him to make his own. And to use nutritional yeast was one of the things that was recommended. But I don't think he'll ever do that. But I tried. You know, they could do hot sauce on their popcorn too, a little bit of Parmesan cheese. You wanted to kind of discourage the salt. So
thanks.
That was a little side story there. Quappy. This is something I've done in the past, and I ended up doing it here again. It's quality assurance, performance improvement. I don't think anybody likes doing Quappy stuff. So the whole team meets once a month to report on patient data from the previous month. So like nursing will do the amount of hospitalizations, admissions, readmissions, infections, vaccinations for patients and staff, mistreatments, etc. We're responsible for all the nutrition labs you see there, the albumin, potassium, cholesterol, calcium, and phosphorus. And the goals that we strive to achieve are listed there. So albumin, we want greater than 40% of our patients with albumin at goal, greater than 80% of our patients with potassium at goal, and et cetera down the line. So I told you about our clinic. The goal for all the DCI clinics is greater than 40%. We've had as high recently as greater than 70% of our patients meeting goal for protein. So that is really, really awesome. I love to see that. Again, it helps, helps the patients feel better, less fatigue, less risk of hospitalization. Hopefully they'll live longer too if they keep their protein levels up. I do see patients who start trending down with their albumins, down around 3 or even lower. I just know that something's going to happen. They end up getting infections, they end up hospitalized, their wounds aren't healing. So I do really, really strive to push that protein. If our group of patients doesn't meet that certain goal, the parameter, then we have to come about with an action step of how we're going to increase that. So if our albumins weren't high enough, we would maybe encourage more patients to, or maybe make sure they're tolerating the protein supplements that we're giving them in center. We may need to counsel them more. We may need to do some more in-servicing, maybe put up some, make a really nice bulletin board in the lobby for them to help educate them. So those are things that we'll have to do. We've also done contests in the past. We'll put out recipes in the lobby for them. Also encourage recipes, like I said, like the whey protein powder, adding that to French toast pancakes, things like that. And then when we round with the physicians, always that's a good time to educate.
So Tina, I'm always impressed with that, because even when you just look at hospitalized charts of patients who are, who are in, we rarely see an albumin over 4.
Yep.
So that's amazing, and it almost seems like an unattainable goal, because even in the patients, even some of them who aren't severely ill, they're rarely at 4. That's kind of amazing.
Yeah.
Has anyone else seen the hospitalized patients? What is the numbers you're seeing for albumin in a lot of them? Maybe not critical care, but just in the generalized population that comes in.
I see more like 2.5 and 3.
Yeah, definitely not 4.
Not 4, definitely not.
I mean, some of them have had recent surgeries, so some of that's like dilutional, but it's just like in that population, it's just so hard to see a 4. So good job.
Thank
I
you.
would have thought impossible job. But. And then do you do the product for the calcium and the phosphorus too? Like I used to teach the interns to calculate that, or is that not something that you guys are doing anymore?
That's actually something we started looking at a little bit more now, because they're pushing away from, I wouldn't say our clinic specifically, but they're trying to get patients with the lower calcium phosphorus product and staying away from calcium-based binders. That's where a lot of patients are getting their calcium from. Calcium is very effective at reducing phosphorus, but we want to make sure that the calcium levels don't get too high, because then we have that calcification risk where you're calcifying the blood vessels and getting the skin breakdown. So that is something that we're starting to look at. Unfortunately, the calcium-based binders are cheaper. They're more likely to be covered by the insurance companies. And a lot of our patients who don't have insurance, most of them are taking Tums, because Tums have calcium in them. So a lot of them are taking Tums because that's all they can afford. They can't afford their prescription meds. So it's definitely a challenge. It's definitely a challenge. So. And just balancing out calcium, phosphorus, and PTH levels every month is a challenge. You know, once the parathyroid gland starts going crazy, it's very challenging to figure out what you're going to do because there's a couple of different medication options. So you have to look at all those levels closely. And number one is phosphorus. You want to get that level down. And once that's controlled, and then you can look at the calcium and the PTH and figure out what you're going to do. So I kind of like that though. I love when the labs come in. I love editing the labs and trying to figure out what the doctor may decide to do before we go on rounds. So I don't know, something I enjoy. And like I said, we have a great doctors here who will listen to us and take our recommendations. So we really work together to try to get the patients, you know, to their optimal health. So I don't know if you find that in the hospital.
The formula for the calcium phosphorus product and the ranges is on the initial sheet I gave them. I think I got that from either yourself or your predecessor. I gave it to them as labs during orientation. So that long sheet of labs that I gave you and that their ranges, that calcium phosphorus product is on there if you don't know what I'm talking about or you don't remember what the numbers are.
Right. They got the nutrition report card too, right?
If not, we'll post it. We'll post it on Blackboard. I think Sharon did that already, but if not.
If you need it again, I can send you another copy of it.
If it hasn't changed from last year, we can move it forward for that.
It has not changed. It has not changed. It has a lot of information for the patients. It has up to 3 months worth of their lab, so they can see any trends in like phosphorus, albumin, etc. It also has diet education right on the report card. So it'll have, you know, some explanations as to why their levels may be high or low and some of the symptoms they may have because of those high or low levels.
Okay.
So, one other thing is care planning. It's another favorite thing of mine. I actually became the care plan coordinator. I volunteered. So once a month, we meet for the incentive patients. We meet once a month. It's a social worker, nurse manager, the dietitians, the doctors. If there's a fellow or nurse practitioner, we like to have them there too, to discuss all our patients that are on the care plan list for the month. All the patients who are on this list are invited to attend. They receive a letter at the beginning of the month to see if they want to come to the meeting. We actually have been kind of pushing for just like conference calls, kind of like the Zoom call, but we just actually call them during the meeting and we just have a little conference call that they can be in on. They can ask any questions that they want about dialysis, their treatment, their nutrition, any questions they want to ask the staff, they are welcome to. Otherwise, the staff will just discuss the patients, see how they're doing, how their dialysis is going. We talk about any factors that may be affecting their dialysis treatments, if they're missing treatments, if they're having psychosocial issues, whatever it might be. The team will get together and discuss them. And at the end of the meeting, we will decide if those patients are stable, which means they won't need another care plan for most patients. It's usually for a year. The newer patients are 3 months. After they're admitted, they have an initial care plan, then a 3-month care plan, then after that it's annual. So if they're stable, it's every year. But if a patient is unstable, we will continue to do assessments and care plans on them every single month until they're deemed stable. We have some patients that are always on there, multiple hospitalizations, chronically missing treatments. We have patients who constantly cut treatments by an hour or more or missing treatments. So those patients we have to follow every single month. So those are our most unstable. So I'm just going to end with this. A dietitian's role is very valuable. Patients who are poorly adherent to their diet, their treatment, and or their medications may experience uremic symptoms. And they come to us a lot, usually when they first come to us, they have these symptoms: taste changes, poor appetite, fatigue, itchiness, edema, dizziness, shortness of breath, even pica. I don't see it as much. Most of the pica is just ice chips. that I've seen. I did have one patient when I came here who was eating, I think like laundry starch or something like that. So something weird. Most patients is just ice. They may have tingling of the extremities, seizures, muscle cramps, bone joint pain, heart attack, confusion, weakness, nausea, and vomiting. So as you can see, if they don't follow their diets, they can get very, very sick. And these symptoms can come and go. We have patients too, like Lynn kind of touched on it with the PD patients. They might start off with, 6 hours of treatment overnight, and they start feeling fatigued. Their appetite starts dropping. They might start gaining large amounts of fluid. We then have to increase their PD treatments, either the amount of cycles, so that's the dwelling time, the infusing and then dwelling and draining, increase the cycles, increase the time they're on dialysis, sometimes add the day dwells to help them get more dialysis. Sometimes patients will come to us on hemodialysis. They'll only be getting 3 hours of treatment when they come because they're still urinating a lot and they're still getting rid of toxins on their own. But as time goes on, they're urinating less and they may need more dialysis. We also have patients with large fluid gains. They're getting short of breath. They're having trouble walking up flights of stairs or even just walking out to go bring their garbage pails in. And they're having a really hard time, cutting back on fluids. They'll have to come for extra treatments.
Do you ever have a situation where somebody would be on both hemo and peritoneal dialysis?
That only happens when people are usually transitioning. Usually if a patient comes in from the hospital, say they already have a PD catheter that was put in the hospital, you can't start doing peritoneal dialysis right away. So they'll usually be getting hemo, they call it hemo backup, while that PD catheter is healing in there. Also, if a patient if they get an infection in their PD catheter, which is very easy to do, it's very tricky, like with that catheter that's sticking out, if they're not really, really careful of keeping everything sterile, keeping the room clean, keeping animals out of the room, etc., they can get an infection called peritonitis. And if that happens, sometimes they have to go on hemo backup also. So they go on hemodialysis for a while. They've also had some patients on PD who've had nephrectomies. So it may be a transplanted kidney or one of their own kidneys that's just gone bad and they have to have a nephrectomy. And after that, they may need to be on hemodialysis for 4 to 6 weeks while that's healing. So that has happened too. But it's generally not both at the same time. If everything's well, it's not both at the same time.
Thanks.
Sure. Any other questions, guys? No? Anybody interested in becoming a renal dietitian, they think?
I know we have one. I don't know how many more. Well, actually two. Two of you have expressed an interest.
Two had said, right? Okay.
I'm also very interested in doing renal.
And who is that? I can't see.
Rachel.
Oh, hey.
Yeah, I definitely love it. I'm not leaving here. It's really great.
I have one question for the intradialytic parenteral nutrition. Is that hard getting that covered by insurance? That kind of goes in and out of vogue and the literature and everything. So
yeah, I'd say probably 90% of our patients I've tried to get on it, having no trouble getting it.
And it's covered by insurance. Okay.
Yeah, it's covered. Mm-hmm. And if it's not, they will work with the patients for some kind of financial plan for them. But most of the patients I've been pretty there's two I could think of in the last few years that weren't able to. It was too expensive even with financial assistance. But yeah,
what
most
are
of
some of the common diagnosis you would put somebody on the intradialytic parenteral nutrition?
Patients definitely with poor appetite, with their albumins usually are like 3.3 or less. I have one patient who's in the vet's home. He was a former cook, hates, I don't know if you guys have been there. The food is said is terrible. He said he doesn't even recognize the food. He's very, very picky. He won't even take the supplement, the shakes they give him because he's afraid of gaining too much weight. So his protein's always low. I'm always fighting with him. So he's on IDPN. He's like average. He's a normal body weight, but his protein just is stuck at like between 3 and 3.3. So he's on it. Fortunately, he hasn't been in the hospital since he's been on it, so that's good. Some patients just poor appetite. No matter what the family does, I can think of another patient, poor appetite, not eating. Even though they seem to be getting adequate dialysis, still just no appetite. A lot of times it's multiple hospitalizations. People have been in, say, 5 times in the last 3 months, and every time they go in the hospital and come out, their protein drops. So I could see somebody who has a 4.0 albumin, they'll come out and have a 3.3. I'm like, oh, and it takes forever to get back up there. So yeah, those are usually instances. You may also have somebody with amputations.
Okay.
A lot of people in rehab, because they're just not eating well. I always hear complaints about the food at the rehabs. There's only one nursing home, I think it was Affinity, was the only one I heard that patients actually like the food and they thrive there. But otherwise, patients really seem to decline once they go to rehabs. So.
And then you said it happens during dialysis. So how is it, just if you could explain the lines real quick, because it doesn't get dialyzed off, does it? It goes in, and just so we have a little idea of the mechanism.
I'm not sure exactly how that works, but I know some of it does get dialyzed out. I think they account for that, these companies, but some of it does get dialyzed out. So.
Okay. And I guess some of the fluid too, so some of the protein remains.
They always account for the fluid because it is, the protein is in a fluid bag. So the nurses do account for that fluid too, to be taken off during dialysis. Because yes, patients will complain, that they think they're getting their swelling from the IDPN solutions, but we're accounting for that. So that's taken off.
Okay. Anyone else, since I've been hogging the questions, anybody else have any questions? Okay, so Tina, please also thank Lynn for us. And
I will.
Thank you for, again, doing this for us. And like I said, I will be in touch. I'm hoping next year's electives, we can start sending people back in-house again.
Yeah, I hope so. Not a mask.
Yeah. Well, they can wear the mask and, some of the long-term care.
Yeah, I know. It's just in general.
Yeah.
I hate wearing them.
Yeah, and how often do you guys have to be swabbed? Are you swabbed once a week or?
We don't get swabbed. We do have to screen though. We get, there's a questionnaire we have to fill out when we walk in the door. We get screened, our temperature screening, our pulse ox, and just the, regular questions, any shortness of breath, any, new or persistent cough, fever. So it's the same screening the patients go through.
Because we, for long-term care, a lot of the interns had to get swabbed once, sometimes twice a week.
Yeah. Well, my daughter up at college, I know she gets swabbed once a week. So.
Yeah. And we do have somebody who remain nameless, lives on campus, I think had to get it more often too.
Yeah. It just all depends on the facility. I know we had some patients who actually work in nursing homes and they were getting swabbed twice a week. So it all depends. But yeah, thank goodness, no swabbing for us.
Very good. Okay, Tina, thank you. So I think I'm going to let Tina go, and I'm going to give you guys a 10-minute break, and Josephine will be back with you guys. So it's 10:35, so at 10:45, meet back on Zoom. Okay? Sound good?
Yes.
And thank you, Tina.
Thanks,
All right, thank you, everyone.
Tina.
Thank you, everyone.
Thank you.
Bye, guys.
comments? So they'll be waiting for you at 2:45. I just gave you a minute break. I think so, right? Josephine can log on. Yeah, right? I don't know, I was leaving today for you, let me just check. I think that you can. Sun coffee. It'll change. I'm gonna flip it my calendar so I don't. That's perfect. Thank you. She had emailed me one, and I researched her. It's fine. Told her what it was. She did apologize. She emailed me and we did apologize. And it's just my whole time. I don't do the pattern for her that. I'll give her another time. The chances we sent around during the time I would have met with her, I was on Zoom, so I just recorded what I would have said to her. And then I sent her the link. So I said, listen to that and then send me a new outline. She had to change the outline. So she's supposed to send me an outline by the end of the day today, then I'll get it. I'll just, you know, if she's not going in there, maybe I'll mute it. You want me to, I can do it. I touched the thing. Oh, now why is that still there? Oh, and Sharon, how do I get rid of this other thing? What's that? I'll have to get my presentation.
And I'll be here until Kara's talking after you.
Oh, so you are here for a little bit.
So I'm gonna go over there like probably around 12:30 or so, or 12:15.
Oh, okay. Then you're
Whenever,
here.
so I'll be here if you need.
Okay. Hi, everyone.
Hi.
I'm my presentation. Let's see. My talk is a kind of fun, lighthearted one. I didn't have it in my office. Okay. So what do you guys see? Do you see the presentation though, or do you see the little slides?
Neither.
I just see you.
Thank you. Let's try that again. No, I did not share my screen. Okay, now do you see the beautiful red cabbages?
Yes.
Thank you. Okay, so this presentation is just really about team building, professionalism, and when you start working, how to optimize your participation in a team and therefore the activity of your division. So most of you have seen a nutrition division meeting, maybe not, or a clinical nutrition meeting. So we're a large group, we're about 35 RDs, although we rarely have a meeting where all 35 of us are there. But there's a big range of different work styles and personality types that as a leader, you want to try to maximize the input from all the people on your team. Because you hired people because you thought they were talented, had skills to offer, and you want to get everybody's input. And that's not as easy as it sounds. One of the things we have encouraged you to do during your dietetic internship is to participate in meetings, voice your opinion, but also evaluate what's going on in the room, use context clues as to when is it best to speak, when is it best to kind of hold off and maybe think of how to voice your opinion at another time or in a different way. So today we're going to go through the Myers-Briggs personality test, and we're not going to do it in writing, but we're going to talk about some of the different ways in which that instrument is used. And it's used in industry and has been used in industry for many, many years. And some companies will do personality tests, some corporations will do personality tests to kind of evaluate people's personality types to help build teams. So you want your team to consist of different personality types. You don't want people to be all the same. And one of the things in hiring is that we tend to hire people like ourselves. We tend to understand people that are more like ourselves. And so it takes some effort to look at diversity in all different ways and trying to build a team with different types of professionals and people that voice their opinion and plan differently. So there's no right or wrong type. It's just building a team, a cohesive team, and helping people to recognize
differences and best work together. So we're going to look at 4 different ways in which people work. I'll say work. And there's going to be some breakout. There's going to be, I'm going to describe 4 different parts of this personality test, and then pose a question, and then put you in breakout rooms. You're going to put yourselves in breakout rooms based on where you think you are. And then we'll come back and talk after each categorization. So let me explain this a little bit more. Okay, so the Myers-Briggs instrument assessment reports your natural preferences on 4 pairs of opposites. So they designed this tool, or create this tool that has opposite ways to do 4 different things: direct and receive energy, take in information, decide and come to conclusions, and approach the outside world. So for direct and receive energy, there's extroversion or introversion. I'm going to turn my phone off. Taking in information, some people use their 5 senses, some people use their gut or are more intuitive. Decide and come to conclusions. They distinguish between thinking or feeling, and approach to the outside world, judging or perceiving. Now, right away, I think we tend to think that one in each of these pairs is better for work. But that's not necessarily true, and we'll talk about that as we go. All right, so the first one, opposite ways to direct and receive energy. So, and this is probably the easiest one to understand. People who prefer extroversion or extroverts, and people who prefer introversion or introverts. So there's a few different, do have some notes here that I'm looking at. Okay, so how people respond to questions. So do you respond immediately, or do you reflect and then respond? Enthusiasm. Do you take more or show more energy and enthusiasm, or you reflect more and you're a little bit quieter, keep enthusiasm kind of tucked inside? Are you energized by interacting with others, or are you energized by the opportunity to reflect more? Are you sociable and expressive, give nonverbal information and gestures, or are you private and contained, harder to read because reactions are inside? It's sometimes good to be hard to read, sometimes. Do you communicate by talking, and you may interrupt people? You know, I'm an extrovert, and I have to be very careful not to interrupt people. I tend to step on people's words, especially people that speak slower. And I really try to watch it, and I'm successful sometimes at stopping myself and sometimes not. I was on a admin call in the morning, and the chief, not medical officer, chief quality officer, I guess, a physician who's been here forever, I cut him off. I couldn't believe I did it. And as I'm doing it, I'm like, you're cutting him off. And I really had to just finish. Like, backtracking was not an option. That would look worse. But I really struggle with this with some people that are a little bit more thoughtful and more, I'm going to say more thoughtful in their response. So introverts communicate more they prefer to write as opposed to speak, and wait for space. And do you work out ideas by talking them through, or do you work out ideas by reflecting on them? I have to laugh because my husband is such an introvert, like all these things. And I'm always stepping on his words too. Extroverts, their interests are broad and many. Introverts tend to have more in-depth focus on fewer interests. Extroverts learn best through doing or discussing. Introverts by reflecting and mental practice. And extroverts tend to take initiative readily in work and relationships. And introverts are selective in taking initiative when the situation, when the situation or issue is very important to them. So keywords, just as a summary, so extroverts are more action-oriented, outward, people enjoy interacting with people, interactive, have many interests, expressive, do think do. Introverts reflect, they might favor reflection more, they're more inward, more private, concentrate on fewer interests, typically, but more in depth, might be more quiet, and they think, do, think, as opposed to do, think, do. So I want you to be thinking which you think you are. Now, we're not doing the questionnaire, which is more like you may want to put yourself in a category and want to be an extrovert or want to be an introvert. So you might put yourself in that category, whereas the questionnaire makes it a little bit harder, like it'll put you in a category. But for now, just put yourself in one of those categories. And we're going to have you go into a particular breakout room in a moment. But we're going to do an activity. So you're going to form groups among yourselves. And there'll be a group of, you're going to either go into the extrovert breakout room or the introvert breakout room. And you're going to think about these questions. So jot these down, if you will, because I don't think you'll see them when you go in your breakout room. So what are the implications and applications of these differences? Let's say if you work as a team of nutritionists in a hospital, long-term care facility, let's say, or food service. So what are the implications and applications of these differences in the teams that you have seen? What communication challenges do these differences pose? So what communication challenges would occur? What kind of misunderstandings between these two types occur in your experience in watching teams over the year? What would be one request you have for those who are the other way? So if you're an extrovert, I want the extroverts to think what's one request they'd have of the introverts. And if you're in the introvert group, what request you would have for the extrovert group. So what are the implications of the differences? Communication challenges. What misunderstandings might occur? What type of misunderstandings? And what would be one request? So, minimize this for a moment. So do you guys see this breakout room, A or B?
No, we're just
I have to open all rooms. Let me open all rooms. My mistake. Okay. So let's say the introverts are going to be in room A and the extroverts in room B. Okay, so introverts room A and extroverts room B. And I'm going to open the rooms and you should be able to go in the room you want to put yourself. So A for introvert, B for extrovert. And I'm going to give you 5 minutes and then we're going to meet back. Okay? Okay, see you in 5 minutes, which will be 11:04. Are you guys able to go? No. You still can't go?
The breakout room thing, and there was an A and B, but now it's just like a blank screen for me.
Huh. I wonder if anybody went. Let me try.
I did see some names popping up in the different rooms. And it looks like those interns are not here anymore. So I think some people are in the rooms.
But unassigned. So I see there's quite a few of you though who are not.
Where would we see?
Everyone just got booted. I got booted too. Jessica, you still in?
Yeah.
Yeah.
You guys got booted from the breakout rooms?
I had to reload everything. Yeah, and right now, if you look at the breakout room, there's only like 7 people in both rooms combined. So I'm gonna try and join room B again, but it booted me out, and I had to re-upload the Zoom link.
So Willie, how do you see an option to get into room B?
I had seen at the bottom, like when you first opened it, like the same place you would see the share screen button. To the right, there's breakout rooms, and I was able to click that, and I saw A and B, but then something happened, and then I couldn't join either. And now it's just a blank box, like there's no A or B there.
I'm gonna try again, room B, and see if it lets me in, or it might boot me again.
All
Will it
right,
be the list?
Where are you going though?
Jessica, do you see at the bottom of the Zoom screen, like the share screen button?
Yeah.
Look to the right on that bar, and there's like 4 little squares. It says breakout rooms.
I don't see that though, Sam.
Next to on the bottom of the screen, next to record and reactions, it
Yeah,
should
Mom,
say break.
we don't have that though. I feel like
Okay.
some people have it and some people don't, which is weird.
When you get it too, if you go to room B or room A, you go towards the right, and it'll all of a sudden it'll just say join out of nowhere.
Oh, I see. If you scroll over the number
Yeah.
of people in the room, it says join.
I just don't even have the option to join.
what if you click on the more at the end of that bar where it says mute, stop video, participants, share? There's the 3 dots that say more. If you click on that, do you see breakout room? I'm trying to look for a pattern among those of
I've
you.
seen the breakout rooms box, but like it's just white. Like there's no A or B in it anymore. There's no anything.
To see if Sharon has any words
Yeah,
of wisdom.
I was gonna say she might know how to just put us in the rooms.
Yeah, I don't even have like a box that says breakout rooms, so.
Neither do I.
Some of them don't see the breakout room option.
Yeah, I don't see anything.
So I can see that some were able to, some are unassigned, so these are the ones that don't see the option. Then A and B, those folks were able to do it.
So go next to Elena's name. Does it give you an option just to assign to?
Oh, well, I can ask you guys. Elena, do you want to go to A or B?
A, please.
A. Betty, A or B?
B, please.
Brianna, A or B?
A.
And I'll give you guys one more time. When you get to your groups, tell them you have 5 minutes from now. Caroline?
B.
Jessica?
A.
That's the nurse. Samantha?
B.
A.
Oh, there's 2 of us.
That was.
Oh, did I just send Samantha to the wrong room?
I
Well,
clicked no.
What room did you want to go to, Sam?
Lampert?
Oh, Lampert. You brought it back. Yeah. I thought you said B, right? Samantha Lampert?
A.
Oh, A. Okay, sorry.
This is Samantha Arena.
Rena, yeah, I keep forgetting there's another Samantha. Sorry, Sam.
So that's okay.
How did she get back?
I don't know. Samantha Arena, where do you want to be?
Rena.
Samantha who?
You.
Me.
Where do you want to go? B. She
Thank
wants
you.
to go to B.
Thank you. Stevie?
A, please.
And Tina?
A, please.
And then how come I don't see Samantha? We see her on screen, but I don't see that I have an option to.
It's so weird.
Just get weirder.
Because she didn't join the room yet. So see if you can move to, and you wanted A? Samantha Lambert? We'll move her to A. Okay, now you should be able to go there. Does it give the option? Yeah, she's leaving. Okay.
You can tell she's leaving?
Because she's frozen.
Oh, okay. Phew. All right.
I
at
don't know,
least
that's
I
bizarre.
can
It just must be something
in
that
their
they're missing.
preferences
Yeah,
or-
something, because Stevie's back.
I accidentally joined the introvert room. Accidentally, definitely an extrovert.
Let me see if I can find you, Stevie.
Sorry.
So Stevie, you want to be the B, right?
Yes, thank you.
You should be able to go now.
Oh, there we go. Thank you.
Why? All right, at least I know I can send them. I didn't know.
That's strange. Though. Whatever. Okay.
And then you that took 5 minutes. That
Go
took.
on.
Hey, Shaq, do you think you can call this nurse though, or call the agency, whatever? Because, you know, something might come on screen that they don't want us to see. Oh, yeah. Hello. You guys are seeing the presentation now. I always forget which screen is shown.
Yes.
Thank you. Welcome back. Sorry for that confusion. We won't break out for each question and we'll never finish. Some we'll just talk about. All right, so as people are coming back in, so communication challenges. Let me hear from the introvert group first, if you don't mind. Anybody in that group willing to share what you guys thought were communication challenges? Not sure if everyone's back yet. Let me see. Okay, so most people are back. So for those that were in the introvert group, can you share what your group thought might be some communication challenges?
I'll go. So we kind of just answered the questions like all together, but I think one of the communication challenges that we came up with was that sometimes like while we're still thinking or reflecting, the extroverts might like chime in before we're ready. So it's kind of like overpowering, I guess, to our ideas sometimes.
Absolutely. Anyone want to add to that? And then from our extrovert group, can someone share some misunderstandings that might come up between the two types?
I think that we had similar thoughts. It was really that as extroverts, we can sort of have reactions and we expect other people to, you know, react the same way, but we don't necessarily know what people are thinking and we can kind of make assumptions to bridge that gap. But really, we're just not giving introverts time to really process and respond in the way that they'd like to.
Mm-hmm. So sometimes, go ahead.
We also talked about how when we're so quick to speak, sometimes like we may not be listening to introverts as well, like not being as receptive to their thoughts because we're already like, I guess, expressing our opinions or interests or whatever.
Mm-hmm.
And not only that, I think also sometimes not even listening to other extroverts too, right? It doesn't matter who's there. Once I'm the one talking, you know, I want to say what I have to say.
It's true. Extroverts might not just be not listening to introverts, but to other extroverts as well.
Yeah, Chris and a couple other people and we all kind of thought that we need to actually work on that as an extrovert to say, hey, we need to take almost a step back and say, okay, let's stop and think and let's listen to everybody else, because sometimes we can dominate a discussion, and not that it's intentional or unintentional. We also need to take everybody else in the room into consideration, and it's something that we need to work on as an extrovert. Most of us agree to that. Yeah.
So as from the introvert group, can anyone share a request you would make of the opposite?
I would say just be more patient and like, consider that like, even though we might not be saying something, we might have something to say, but like if you're overpowering, we're not gonna like, chime in and interrupt you and say anything.
Mm-hmm. And extroverts to introverts, any requests?
So we kind of came up with be more vocal in what you're thinking about, because a lot of times we feel like you guys probably have better ideas because you've actually taken the time to think about it. Please say it.
That was one thing that kind of came to my mind too, just to use like the inpatient nutrition division meeting as an example. You always go through like the outline at the beginning for everybody, which is great. But I think even for introverts, if, they had that like, half an hour before the meeting, just to sort of read it over and get their wheels turning so they can kind of take the time before to process, what they have to contribute to the meeting could be beneficial.
And as we're talking, another thing I'm thinking that I should do for those meetings is to encourage people before they leave for the day, or before close of business, or even if they're home, to write me what they want, what they're thinking, but perhaps didn't feel comfortable sharing or didn't get a chance to share. Just drop me an email so that they still have a way to communicate their ideas, because as many of you are saying, introverts can have very good ideas often because they stop and think more. But we have to help them have other opportunities maybe to share that.
So we were in our group also, in the introvert group, we also talked about sometimes how having that mixed group, having the introvert and extrovert, it would help the extroverts help the introverts to speak up and express the ideas. Just because you see them talking, it might urge you to talk also, give the feedback. It would take some time, but it helps them too, knowing that everybody's in the same boat.
So one thing I think I've said to all of you, and I say to my team as well, is you have a responsibility as a professional to participate in team meetings, because again, you are hired for your skill set. So you have a knowledge base and skills and great ideas. So you have a responsibility to optimize the function of your group by participating, and to be thinking of a way that you can do so comfortably. And maybe it isn't more in emails after a meeting summarizing your perception of what occurred and ideas or decisions that were made, and then having your input in a written format. But to be thinking for yourself, what is the way you can convey your ideas. So when you start working, be thinking about that. I mean, the first month or so, the first few meetings, you kind of want to sit back and kind of understand the flow and the personalities and kind of take all that in, but then start tiptoeing into the water and contributing your ideas either at the meeting. And also, extroverts have to really, and I really do struggle with this and work on this, to stop interrupting people and to give people time. There's also the clock, and the RDs have 14 to 16 patients to see, and the meeting is really an hour. And in the beginning, I used to go over an hour, and I got the feedback like, stop doing that, Josephine, because we have so many patients to see, and I can talk forever, and I needed to change that and to make sure I stop within the hour. So as an extrovert, we have to try to give introverts more time and not jump on their, not step on their words. But introverts too have to kind of think how, to I forget if it was Sam's point, to kind of look at the agenda beforehand and to be thinking how you want to communicate your opinion or your idea, and make that effort, even though it's not comfortable and it's not maybe a skill set of yours it's not in your skill set to put together ideas quickly. You like to think more, but sometimes you have to say, I'm not sure if it is the best plan, but this is what I'm thinking. And to be comfortable verbalizing something that maybe you're not 100% sure of yet, but it's your perception or your idea. So both have to give a little bit and try to meet in the middle.
But Josephine, I feel like it's not like, sometimes it's not that introverts like take longer to process. It's more like, I'm waiting for you to say like, so who has an idea or who has an opinion, and then I'll give it. And instead, before you ask the question, like an extrovert's already giving their opinion or their answer. So it's like, I was waiting to be directed, like, now is your time to talk, but somebody else just jumped in and talked before we realized the meeting even started, kind of thing.
So
it's not like we really didn't, like, it's not like we're not processing in the same amount of time, like we need to prepare for those things. It's just, we're waiting to actually participate, to be told to participate in some situations, I think.
So I didn't mean processing as if, I'm sorry if I made it sound like there's a different speed of processing. I was thinking, and maybe I'm wrong, is a different level of conviction maybe before you verbalize, that you want to be really sure before you say something, but maybe that's not true. Maybe
no, sometimes yeah.
But so then, when you do like a target fitness group, it was easier in person, I think. Same thing as running a group weight management program, for example, is there are some people that always want to talk, and there are techniques to kind of shut them down a bit because you have to. So in a group, you cannot look at them, right? Because if you're not looking at someone, they're less likely to talk. So that's one thing you do. Or sometimes, so in a Zoom meeting that I'm actually trying to scroll through my gallery to see everybody, virtually it's a little bit harder, I think, to do. In person, by looking at somebody, you can also, give your attention to them, and they might feel like they should say something if you're looking at them. So that's one thing. But in groups, I have had to tell people, I need you to, we'll get to you in a moment, or not right now, or this is not the best time. And sometimes it's easier to do through verbal and not verbal language, but sometimes you have to verbalize it. And verbalizing it makes the person a little bit more uncomfortable. So sometimes I try not to verbalize it and do it more subtly. But sometimes in group settings, I've had target fitness groups where there's been one or two people that just, and then introverts will email me saying, I feel uncomfortable, or I don't feel comfortable, voicing my opinion. So it's a lesson not only in management, but in group patient care as well. And group programs, through your business plans, I really try to encourage you guys to think by budgeting how much more you can make by doing groups as opposed to individual counseling, although, a balance of two is good. So managing group takes practice, continued practice. Okay, we'll move on a little bit. So opposite ways to take in information. So sensing or intuition. So I think we tend to think sensing is better, right? If you use focus on realities, verifiable facts, experience, what is real and actual, versus focusing on possibilities, the big picture, insights, patterns, and meanings in data. So looking at data in trends. But again, both are important because, especially with something new like COVID-19, there may not be so many facts. And sometimes you have to think, well, what is similar to this? Okay, let's look at the R's literature in vitamin C, because there's no vitamin C literature on COVID-19. So again, both are important. Sensing, people who prefer to gather information through sensing, observe and remember specifics. Intuitive people remember them when they relate to a pattern. Some people trust their experience, others their inspiration. Some get to conclusions by building carefully and thoroughly towards them. Some intuitive people will move quickly to them, follow hunches. You can see the pros and cons of both. Ideas and theories, so people that prefer sensing understand the ideas and theories through practical applications, and intuitive people want to clarify them before putting them into practice. And those are the key words. So it's interesting. So working through this new master's, developing this new master's that's going to be based on the future education model for our profession, in that undergrad, you can do anything, major in anything, and then the graduate level would be where you do your didactic work integrated with clinical training, like medical school is. So we've been working on this for over a year now. COVID delayed things, but some people get very stuck in the details, and I tend to want to push forward on the big picture, and it's taking us too long. We're just getting too stuck in details. But the detail people will keep stopping me in my group, which is good, because some of the details I want to skip over are important, and I'm not really giving that enough emphasis, because I'm just like, we have to get this in. There are 5 other programs in New York State already, and it's getting harder to get good applicants in the internship program because people are going to those future education models because they don't have to deal with DICAS and the uncertainty of DICAS. So I'm like, we got to move, and people are like, pulling me back for details. And at some point I'm like, okay, yes, they're important, but we can sort some of this out later. We have to get this proposal in. So it's a balance with both. And both are important. And there is some friction at some of these meetings. Like, I'm sure I know. And sometimes I have to like make sure, check with people, make sure they're okay, because I'm pushing a little hard. Okay. So we're not going to break into groups because we're getting a little, that was kind of painful. And we took a lot of time. So ideally, if you are someone who is more gathers information by sensing or intuition, just for a moment, look at this image, and then I'm going to ask you a question as a group. So I'm going to give you just literally 2 or 3 minutes to look at this picture, study it a bit. Okay, so this is a tough one because it's an unusual picture, right? So can anyone, if you consider yourself someone that is more, got more sensing as opposed to intuitive. So sensing, people that see facts and realities, specifics. If you consider yourself someone more like that, could anyone share what you see? So the answer key would tell us that people who are sensing want to really look at the details. So, for example, if you read the outside, there's a mistake in the quote, right? It's usually Jack be nimble, Jack be quick. Jack jumps over the candlestick, not the flame. So people with details will get hung up in the details of what they see. And people that are more intuitive interpret the big picture and look for the conceptual meaning. So this guy's a puppeteer, right? And you would notice that there's other puppets up here, and what's the story he's trying to tell, and more of an overview as opposed to the details, because there's a lot of details that you could want to interpret or that catch your eye, as opposed to standing back and looking at the big picture.
That's funny because I was thinking I was more of like the intuitive type, and I literally read the outside panel and was like, that's wrong, and just kind of brushed over it and was like, but what else am I supposed to be seeing here? Like, so kind of solidified it for me.
Other people jump to details?
Yeah, like why the A, the I, the A, and the S? Why are those highlighted in red? And the C? Like why? There's no pattern. Like that drives me crazy. It hurts my eyes to look at because it's like the A and the I and the A, I could say, okay, they're vowels, but the S and the C, that's just random.
And you want to make sense of it. Yeah. So there are a lot of details that you can get hung up on. Similar to this project that we're doing, there's so many details. So again, not that one is right and one is wrong, but it does help you as an individual in your own professional development to try to pick up qualities of the other, right? To recognize the importance of detail, but try to see the bigger picture and do strategic planning and think big, but not get frustrated with the details as some of us can sometimes. So there are good qualities in both. Okay. And then there's opposite ways to decide and come to conclusions. So thinking and feeling. So in science, we tend to think thinking is better, right? But not always. So with thinking, you step back to get an objective overview. People prefer feeling. You step in to identify with those involved. You prefer to analyze or you prefer to empathize. Guided by cause and effect reasoning if you're more of the thinking category, and guided by personal and social views if you're more of the feeling. Solve problems with logic or by assessing impact of decisions on people. I mean, you can imagine that both are important in healthcare. You strive for an objective standard of truth in thinking versus understanding harmony and positive interactions. You are reasonable, you're compassionate, you can be tough-minded or tender-hearted. You want to treat everyone equally or be treated as an individual. That's an interesting difference. And in healthcare, because we're dealing with people at very emotional times and with very emotional issues, food, eating, death and dying, etc., there is a need for both. But some of, with dealing with a lot of death and dying this year with COVID and some of the case studies that people have had recently that have been very challenging, Lisa Richter and I were like, I don't know where I fall in this category really, because I've asked Janice, our peds dietitian, many times, how do you do what you do? It's so hard, and there's so much empathy that you have, but you have to make decisions and you have to move forward. And what Janice will always say to me every time I've asked her is, I just focus on making their life a little easier, making their life just in some small way a little easier. Because it's really hard if you're a feeling person, which all of us are, I think, because you go into the field. So all of us to some degree are, but it can be really hard. So we're trying to get someone before the distance DIs. You guys would have graduated, but we can keep in touch. We're trying to get one of our social workers, and we're just working on timing to give us a talk on dealing with death and dying in healthcare. Because it's been a very tough year, year and a half almost. And it will continue to be tough. And if you work in inpatient or long-term care, you're dealing with very critically ill patients and death and dying, and it's hard. So I think in healthcare, we're a little bit of both. This was the associated words in summary, and this question is interesting. And we're not going to break up into groups, but imagine that it's kind of funny. Imagine that you've been invited to a party with a close friend. Your friend arrives ready for the party. You look at what the person is wearing and say to yourself, oh no, is she really going to wear that? Or is he really going to wear that? What do you do in that situation? I think because it happened this weekend with my husband. I keep talking about my husband because we're so different. And he was wearing something, I'm like, I didn't say anything because we really weren't going to see anybody that we knew. So the question is, oops, did I go the right way? Yeah, what would you say in that situation?
Oh, just on something similar, like on a sidebar, when someone sees someone and they don't want to say anything. I was in the store the other day and there was a woman babysitting her granddaughter, and she was walking around with a walker and had one of those toilet paper covers sticking out of the back of her pants. And she must have been walking around for like 15, 20 minutes. No one said anything to her. I walked up to her, I said, ma'am, you might want to just run back to the bathroom. And that's all I said to her. And she's like, why? I said, there's something in your pants. And that was it. Yeah. And she was so appreciative. She came up to me like 20 minutes later and she's like, thank you so much. Thank you. Thank you. No one said anything. Thank you. Thank you. And I was like, no problem. No problem.
So you were empathetic. And
I felt bad. Because no one was going to say anything. She was going to walk around the rest of the day like that. And I'm like, come on, come on.
Any ideas on what anyone want to offer what you'd say in this situation? And what's guiding you?
I would say nothing.
Yeah, same. Like if it's
because you're there already. You're at who knows how far away from home it is. You're there. What is the person, what you gonna do? Like you're just gonna make them feel bad, and there's nothing that you could really do.
Yeah, there's a subtle interpretation here. Like I wasn't sure if they were meeting before they went to the party, like they come to your house and you go to the party together, or if they're at the party. So that's that would make a difference, Rachel. You're right. Because if they're there already, what are you gonna do?
I interpreted it that way as well. Like you have an opportunity before it to be like, oh, what are you doing there? But, if it's something like Willie said, like, yeah, I would say something. But if in terms of like somebody making a personal style decision that I think is a little off, I'm not going to say anything because, they're doing what they want to do. So
let them be them.
Fashion's not really my expertise, so I may or may not pick up on it unless it's really ridiculous.
So I went to a talk like this, and this was shared with me. So the thinkers concentrate on achieving the desired outcome. They want to get their friend to change. So they tend to be frank and to the point, especially I think if it's going to help them, not embarrass themselves, like Willie was saying. Feel it, people with that are more feeling, think how the friend will feel at the party and concerned about others' feelings. You can think of it that they would take a tactful and indirect approach because they would feel that the person might be made, people would be thinking badly of them at the party. So they're trying to help them.
May I have your attention? May I have your attention, please? There has been a fire alarm reported in another area of the building. Please stay in place and await further instructions. May I have your attention? May I have your attention, please? There has been a fire alarm reported in another area of the building. Please stay in place and await further instructions.
I'm going to squeeze
That's
this in.
been happening a lot lately.
Could you read this to yourselves, what's on this slide for me because of this? Because I really have to let Kara start.
May I have your attention? May I have your attention, please? There has been a fire alarm reported in another area of the building. Please stay in place and await further instructions.
if
May I
we're just
have your
would you
attention?
be able to
May I have
mute
your
because it's like a little distracting.
Fire alarm reported in another area of the building. Please.
Thank you.
It's going to come back on in about 30 minutes or 30 seconds. Let me just go to the next slide and then there'll be the summary slide. Okay, let me get to the summary slide. So people that approach the outside world from a judging perspective, which I don't like this term because it sounds negative, right? Like you're judging somebody, but organized, they're organized, decisive, they want control or they're very controlling, or they want things done immediately, deliberate, planned, very structured. People that approach the outside world in a more perceptive way, are more flexible. They want to use their experience. They're okay with taking more time, more spontaneous. So the question was for this one, you have 30 days to complete a project that requires 10 full days of work. When do you start? When do you do your best work? What would create stress for you? And what do you do and say in this situation? So Sharon will say that that I would put it off, that I do my best work later and I drive her crazy. And I do think I do better work when I'm a little time stressed, but of course that's not what I'm supposed to be teaching you. And you're supposed to work ahead of time and be more organized and more plan ahead. So again, you get to know the people you work with, and I'll tell people, lie to me, like tell me the date is earlier. Don't lie to me, but tell me that. Let's set an earlier due date for ourselves, because I do work better under pressure, I think, but that's probably not true. I perceive that. But again, learning in your group, the way different people are. And yeah, you definitely, even in my group, I think our group is fabulous and we've been together for a really long time, but there's things that I know bother one person about another person about details or big picture or time frame. And so as the manager, you're trying to facilitate and smooth over some of those things. So, all right, I'm gonna go get Kara because this took a lot longer because of the time we lost in the room.
I'm here, Josephine.
Oh, hi, Kara.
Hey.
I know I lied to you totally. We had breakout room problems in the beginning and then the fire alarm thing.
That's fine.
So I hope you enjoyed that little bit of fun. And that's it. I'll leave you with Kara.
Okay, Josephine, I'm gonna do it from here. Oh, does she want to go? Perfect. All right. So we're gonna shift gears one last time this morning. We got a whole array of different topics. So let me just make sure I can share my, oh shoot, post-disabled participation. Uh-oh. Bear with me. I gotta go get the ability to share my screen. Hold on.
I'll do it, Kara.
Okay.
I got it. I think I got it. Oh, wait, give you the ability. Hold on. Okay. That should work now.
I'm co-host.
Attention. Your attention, please.
Okay, guys. Do you hear the announcement I was bad with my door shut?
It's a lot better.
Okay. And do you see my screen that has the full version of the PowerPoint up? Perfect.
Yes.
Yeah. Okay. So the last topic today is professional development portfolio, which is what you will be doing once you are an RD, once you pass the exam, what you have to do every 5 years for recertification. Okay. So it is through CDR. And it's not something you will be doing the day after you pass your exam. It's something you want to actually think about what your goals are over the next 5 years to, where you want to work, what kind of new knowledge do you want to gain. And you actually don't need to submit the learning plan anytime soon, really. You can submit it at any point as long as you postmark it, which in this case, you're really just going to submit it online. You're not sending it in. No later than 120 days after completing your first CPE activity. So I do have some screenshots, and we'll show you what it looks like on CDR, how you actually create this portfolio, and then what counts as credits towards your continuing ed credits. So they do have to be based on this individualized learning plan that you create for yourself. So I put here the link, and I would definitely suggest downloading this presentation and having it available to you because, like I said, you may not create your personal learning plan for a year or two after you pass the RD exam, just depending on where you're working and how you're gaining those credits. So I have some screenshots and I will show you, but basically you use this learning plan is on a platform called CDR Competency Plan Builder. And basically it's a digital tool that helps you to create this 5-year cycle. So it is a personalized plan where you choose different spheres is what they call it. So let me just pull it up because it's easier to show you than try to explain it. Let me share this document here. Okay. You see the new document with the screenshots of CDR?
Yeah.
Okay. So this is actually Josephine. She recently submitted her new learning plan. This is what we call the dashboard. So once you log in, this is where it'll take you, your landing page. Do you see my cursor moving? Okay, sorry, I'll try not to move it too much. This view PDP guide is actually really helpful. So it's a more detailed explanation on how to use CDR, how to build your portfolio, as well as what continuing ed credits account for, but it is also in this presentation. So if you ever do lose the presentation, you can at least go to this guide and it'll all be there for you. So once you log in once and you create your profile, then you will just start submitting your learning plan. I'm going to skip over this. So basically you're going to select spheres, which will then give you competencies that you have to choose and performance indicators. And then you'll review your plan and submit it to CDR. And you get an automatic approval for whatever you submit to CDR, and it can be modified. So if you submit something and then you realize that you're doing continuing ed credits in a different sphere, which I'll show you in a minute, then you can modify it. This is a new platform, so I haven't used it myself. So we're thinking that you can modify it as much as you want. It just says it's modifiable. So I would still give it a lot of thought prior to submitting your plan. And then there is a tutorial video and frequently asked questions. So they do have a good number of online resources that you can use. Okay, so these are the spheres. So there's 14 different spheres related to nutrition and dietetics profession. You select a sphere to add a sphere, and then you have to select specific competencies associated. So we have some screenshots of the competencies. The only required sphere is ethics. So everybody has to complete at least one credit or competency within the ethics sphere or category. Then you can choose really any number of other spheres that you want. So you can choose all of them, you can choose 2 of them. It doesn't matter. But I think also to keep it more vague, selecting more is only beneficial, because it says down here that you do not have to meet every competency on your plan. So if you select 10, 15 competencies, but you are doing continuing ed credits that only fall into maybe 6 or 7 of those competencies, it's okay. You're just giving yourself a larger variety to be able to achieve your CPEUs over the 5 years. Right? Does that make sense? Okay. So once you select whatever competent or whatever sphere you want, so Josephine gave screenshots here of the ethics sphere. In the essence of time, because I think we only have a couple of minutes, I'm not going to read them all, but it does just give you more information or explanation of how you can achieve this overall sphere. So she selected ethics, which identifies with and adheres to the code of ethics for the profession. So now these are more detailed explanations. So just to read a couple of them, demonstrates and maintains competence in practice, which is 1.1. 1.2 is demonstrates integrity in personal and organizational behaviors and practices. So something to keep in mind is you're not achieving these competencies through the work that you are doing, but you are achieving these competencies by doing continuing ed credits. So you have to really think about where you're going to be in your profession and how you're going to achieve those. So that's why I do suggest waiting to see what your job is, if you're going to do a master's, because I'll show you what credits actually count. Okay. Another example for critical care sphere 10, which is screening, assessing, diagnosing, intervention monitoring and documentation, and the different competencies that go along with that. Again, if you choose a sphere, you have to choose at least one competency. You can choose as many as you want, but at least one of them. And then once you're done selecting all your spheres and all the competencies associated, it will give you what your personal learning plan looks like, and you will review that before submitting. So for sphere number 1, Josephine selected 1.6, which is adheres to confidentiality and privacy legislation, standards and policies. Then it provides you with performance indicators, which is more of a guideline of how you could achieve these competencies. So it's just like breaking down a larger category into multiple different ways on how you can achieve that. So it's giving you more and more ways to use continuing ed credits to fit certain competencies. So it is pretty useful. And let me just show you, if you go down to the competency 1.6, which is for ethics, it gives you the main category again here. And then it'll give you 6 more performance indicators, which are guidelines to achieve those competencies. So implements appropriate measures to protect personal health information using appropriate measures, safeguards client confidentiality when sharing, transmitting, storing, and destroying personal health information. So if you're viewing a webinar and on the webinar description, it has anything similar to these performance indicators, then you know that you met that competency and you can use it in your activity log. Okay, so it does take a lot of thought into how to select your continuing ed credits to meet these competencies. Okay. So let me stop sharing and go back to the presentation. So those two documents are on Blackboard for you to go back and review. Okay. So once you do submit your plan, what qualifies for continuing ed credits? You see the presentation again, correct? Okay. So academic coursework. So if you are thinking of doing your master's, you can probably submit your professional portfolio almost immediately because you will know what courses you will be taking over the 5 years. So you can look at course descriptions and basically be able to determine what you will fulfill, what competencies you can fulfill within your courses. That's actually what I did for my first 5-year recertification. I used my master's. So I knew 1 semester credit, only one, is a 3-semester course mostly. So 1 semester credit hours, 15 CPEUs. You need 75 for the 5-year cycle. So if you're continuing on to get your master's, you can easily achieve 75 credits if you're getting 1 semester credit for 15, equal to 15 CPEUs. Some institutions do trimester, so it's a little bit different. It's 14 CPEUs, quarter credit hours. I don't know a lot of institutions that do that, but if they do, it's 10 credits. And then the MOOCS is basically pre-recorded webinars and courses and whatnot. And that's basically you get 1 CPEU per 1 contact hour. Okay. If you are using your academic coursework for recertification, you do just have to submit your transcript or course completion certification if it's something smaller than an actual degree. So that's not very difficult. Okay. Other things, so say you work in a hospital and you can go to grand rounds, or if they're presenting patient case studies, then you can get 1 credit, 1 CPEU for 1 contact hour. As well as if you decide to go on and get some sort of a certification like CSSD, again, you can get 1 CPEU for 1 contact hour. I did my CLC, which I forget, it was a full week, so I forget how many credits it was, but it almost fully again covered my next recertification cycle. So there are many things that you can do in order to achieve these 75 credits. And it seems like a lot, but it actually, you can get those 75 credits fairly easy. Okay, if you go to Fancy or any other conference and they have exhibits, you can get a maximum over the 5 years of 15 CPEUs during those 5 years, and a half a unit equals a half a CPEU. So a half a unit, I think this really should say half an hour. Oops. Half an hour equals half a CPEU. So if you go see a couple different exhibits, then you spend a couple hours there, then you would get the appropriate number of CPEUs. If you do something like culinary skills training or physical assessment training, any experiential skill development, again, 1 CPEU equals 1 contact hour. That's pretty much the theme here. Interactive workshop, same thing. Journal club, if you work at a hospital, that allows you to attend journal club. Or if in the future you become a preceptor for us, you can still attend journal club and get 1 contact hour or 1 CPEU per contact hour. So we do Zoom in our preceptors outside of Stony Brook for our journal clubs, and we do 9 of those a year. So that's 9 credit hours a year. Okay, but you do have to be a preceptor for that. But many hospitals do that as well. Webinars in real time. So if you're watching a live webinar, not pre-recorded, it's 1 CPEU per contact hour, and a pre-approved recorded webinar. So it has to be put out by CDR, or at least approved by CDR. You can have a maximum number of 30 CPEUs over the 5 years. And again, 1 credit per 1 contact hour. Poster sessions, half a credit unit for a half a contact hour. And again, a maximum of 15 CPEUs over 5 years. So I guess they want you to have different live type of educational experiences rather than just poster sessions or pre-recorded webinars. So that's why they put maximum numbers there. If you precept for us, or if you precept for any dietetic internship, you can also get a maximum of 15 CPEUs over the 5 years. And it's kind of broken out weird. So you can get 3 credits per year. And over the five years, it would be 15 CPEUs. So when we are talking to preceptors and trying to get preceptors for you guys, we do, use that as a selling point. You can get continuing ed credits for precepting. You can attend our journal club. You can have access to our library and review sources. And that as well counts here as the professional reading. So reading peer-reviewed articles. So all those different ways as preceptors that you can get credits. If you do research, you can get a total of or maximum of 60 CPEUs over the 5 years. Or if you do a residency or a fellowship, if you complete the program, I think you automatically get 75 CPEUs. Okay, any questions with that? So it's not as intimidating as it seems when you think of 75 credits, like, oh my gosh, that's a lot, but you'll be doing these things regularly throughout your job experiences. And overall complete those 75 credits fairly easy. I think when I was working in a smaller long-term care facility, I had less available options to complete the CPEUs because I didn't have many RDs. It wasn't a big facility. But if I precepted, then I could get a lot of different CPEUs by being connected to an institution. So always try to keep that in mind too. If you're working in a smaller institution, try to connect yourself to a dietetic internship or a larger institution or organization. Okay.
Cara, I do have a question for you. You mentioned that one semester in the master's program is 15 CPEUs. So would that mean that all you would need to just send them would be a total of 5 credits? That's pretty much just 2 classes, and that would make enough for 75 continuing education credits, which is 5 years technically.
Yep,
Oh,
exactly.
wow. Okay, perfect. Thank you.
So that's very simple, right? If you're doing your master's, you can check that box off right away. You can do your learning plan and kind of forget about it for the next 5 years after you complete those 2 courses. So it is nice.
Where would ethics come in that? I was thinking about that, the master's, but then how would you fulfill the ethics competency?
So ethics, there's actually a lot of free resources on eatright.org. I think CDR does send out a few different activities that you can do. It's actually really simple. There's always free resources to do so. But you can also, if you do a research course in your master's, you can count that for ethics as well. A lot of them will contain some sort of an ethical component to it. So it's not so hard. Once you look at your
one. It's just one it's just one CPEU that you need?
Yep,
like
just
for
one credit for ethics. Yep. Okay, any other questions?
I have one more question, sorry. So if you would already have the 75 credits just from the master classes, would you still need to complete that one ethics?
Yes.
Okay.
Thank
you.
Yep. So you can go over the 75 credits. I did one year and I was like, oh, darn, I wish I waited to go to Fancy till the next year because then it would have counted towards my next cycle. So, I mean, it's something to keep in mind, but like I said, over the 5 years, you tend to be able to have more than 75 credits for different activities that you're just doing regularly. And just staying on top of the field of dietetics. So you'll notice that when you're submitting your learning plan and submitting your activity log, that they build up really fast. So you can either use a paper log, but I printed mine, but I really just fill it out online. So I print out what I have for the learning plan just to keep that on hand, or you could save it to a document on your computer or whatever. Just so you remember what you selected for your learning plan. And when you're looking at different webinars or whatnot that come through that are sent through email, then you can see, this is something interesting to me and does it fulfill my learning plan? Or then you could right away modify your learning plan to make it work. The activity log can be submitted at any point during the 5-year cycle. So like I mentioned, if you hit 75 credits after one semester of your master's program, go ahead, you can submit it. Or you can wait till the day before it's due. Really doesn't matter, as long as you complete those 75 credits. Like we said, you have to submit one CPEU for ethics and professionalism. And it does take CDR about 6 to 8 weeks to get back to you after you submit your activity log, for them to say that, you know, you've achieved and met all the competencies that you needed to have your recertification complete. But it is recommended to keep all your files and documents on hand for 2 years past your certification cycle, because they can audit you. Okay.
I have a question about the plan that you were saying. So you have to submit the plan ahead of time. So I know you said that it is modifiable. So does that mean that, like, you know, say, you know, you could fill it out however, you know, make your plan, but then as the 5 years goes along, can you just like change it all the time? Like, see something comes up? Because I'm just thinking, like, how would I know ahead of time exactly, you know, what I'm gonna wanna? So can you just constantly change it, like, according to what comes up that seems interesting?
Yeah, I think so. Like I said, I haven't used this platform. It's new for everybody. But it does say it's modifiable. So can you modify it once, twice, 3 times? I'm not sure, but I think it seems like you can at any point. But again, when you're thinking about what you want to submit initially for your recertification, wait a little bit so you have some sort of an idea of any avenue, any job that you're going to be working in, or a specific field that you want to focus on. So keep that in mind first. And then from there, if you choose things, try to keep it vague. And then if you have a webinar that you view, or you go to a conference and you really feel like it doesn't fit any of the competencies that you selected, I do believe then you can modify it. Okay. Any other questions? Okay, so if you don't have any other questions, it's on Blackboard. Like I said, I would download those just so you have it, because it's not something you will be doing anytime soon. So, I mean, you can, but most of you will wait a couple months at least to do it. So have these documents downloaded and saved so that you can refer back to. Okay. On Blackboard also is that larger CPC, or I think it's PCP, guide, where it tells you more information on your learning plan and what activities include for recertification, etc. So it's there, but like I said, this presentation has pretty much all the information that you need. Okay. All right. Just quickly, for the distance interns, we are not going to do your review of the clinical and professional portfolio right now. You'll take lunch. I'll figure out another time that we could do those and get back to you. Okay. And the on-site, you guys are free to go.
Thanks, Kara.
Thank you, Kara.
Yeah.
Have a good day.
Goodbye.
Thank you. Bye.
Bye.
Kara, do you think our clinical portfolios also due? Do you think they're gonna check it next week? When do you think they're gonna check it? I don't know if they told you.
They didn't.
Okay.
But I can ask Josephine and Sharon and Lorraine to send you guys an email.
Okay. Thank you, Kara.
You're welcome. Have a good one.
You too.
So you guys can, distance can take a lunch until 12:30. And just so you know, there's a little bit of a modification to the schedule, because this just happens all the time. So you'll still be doing the same 3 presentations in the afternoon, but they're just gonna be flip-flopped a bit. So
They're gonna be what a bit?
They'll be flip-flopped a little bit. So same time frame.
Oh, okay.
They're gonna go in a different order.
Okay.
Okay. And did you see online on Blackboard, I did release the renal presentation this morning. I released the mock interviews, so look at those before tomorrow. And I will release all the rest of the presentations now, since you guys will be starting those right after lunch.
Wait, Kara, where is that? Because I just looked a couple minutes ago and I can't find it.
Okay, so on Blackboard, there's
Uh-huh.
Evaluation and Review Week tab on the left-hand side.
I don't see it, but I also always mess up, so I see where it should be on yours and it's not on mine.
Huh. Let me see. Does anybody else have an issue with it?
Can someone
I,
else check?
I
Let me
see
see
that.
that. You see it?
I see, I think so, yeah.
Why am I not seeing it?
Does
Okay,
somebody else?
I'll figure it out later. It's not important right now.
Well, actually, let me know. So Alana and Caitlin, can you see it? Because Rachel's in a different group than you guys.
Which thing specifically are we looking at to
The
see?
Evaluation and Review Week.
Oh, you mean the whole folder? Yeah.
I don't see it on mine.
Okay, I will work with Sharon, who's the expert. I feel like here it would tell me if it's blocked or something. Hold on, let's see. No, it seems like it should be there.
I don't have it either.
Oh, hold on. Can you try to refresh and look again?
Yeah, let's see. Still not on mine.
I did just hit this permit users to view the content. So maybe after lunch, try to just like sign out, sign back in, let me know if it's not showing. Okay.
Sounds good.
Okay.
Thank you.
You guys excited to be here for review week?
Yes, I didn't think this week would
It
ever
went
end.
by so fast.
Rachel's been with us for almost 2 years now, so I don't know if she can say the same, but this past year went really fast in my eyes, at least.
Yeah, it didn't go by as fast for me.
I
When
bet.
is the when's the on-site review evaluation week?
So they actually started earlier this year just because of COVID. We were actually in New York lower percent of COVID in the summer. So we started them earlier. We started them in August. So they only have about 2 weeks, maybe 3 weeks left.
Oh, okay.
The rotations are done next week, and then they have some research seminars and review week.
So was today the only day that we're mixed with them, or are they going to
Yeah.
appear a different day? Okay.
Today's the only day you guys are mixed with them. From now on, for the rest of the week, it'll just be you two, you four.
Okay.
All right. Any last questions? I won't see you this afternoon. I have to go over to the greenhouse. Any last questions?
I don't think so.
Okay. Tomorrow for the mock interviews, they start at 9:30, or I'm sorry, they start at, what time do they start?
On my thing, it says 9:30.
Yeah, that's what I thought too. I don't know what I have downloaded here. So 9:30, dress appropriately, look a little bit professional, pretend like you are going to a job. Have your have your professional portfolio available, resume if you want to just kind of like hold it up and explain it. It's going to be a little lenient, but we do just want you to get that like back and forth interview process under your belt and see what it feels like and what kind of questions are asked and whatnot. Okay. All right, go take
Okay.
lunch before we run out of time. You have about 22 minutes, so go eat something. And Josephine and Lorraine will be with you for the rest of the afternoon.
Thank you.
Thanks.
All right, bye.
Hello, folks. So I want to just pilot test something because if this is for the later talk that I'm going to be giving you guys. I wanted to share a video at that time, and I just want to see if the video, if you hear it. I have to turn off. Hang on one second.
Because on Blackboard, they couldn't see the evaluation and reviewing folder at all. Oh, I checked that. I did, but I fixed it, but they said it didn't, I guess it didn't process on their end yet. We have to refresh or something? So I want to try, just make sure that they have
the presentations for evaluation all of them. Okay. All of the presentations. Okay. Hold on, let me ask them. And I have this feedback, which I guess is your, which I turned it off. It is muted there. Is it your office or? Sorry, guys, I'm just having feedback here. I'm trying to figure out where it's coming from. Kara wanted me to ask you if you guys now in Blackboard can see the folder for review and evaluation. We can see the presentations.
I can now.
You can now. Okay. I wonder if the research one is there. Well, we'll see. Otherwise, I'll save it afterwards. They can, Kara. Okay, let me just close the door. Okay, so I have a presentation on research that's really focused on the exam and the kinds of things that you need to know for the exam. And then the last 5 or 10 minutes or so, I want to talk about our research project. So Rachel, at that time, I'll let you go. I mean, you're welcome to stay, but you finished yours last year, and we were just having some conversations individually, and I wanted to kind of wrap that up.
Did you do the same thing? I'm just curious, like was your
No, they
research-
did something with COVID and micronutrients.
Oh.
So it was different.
Okay, totally different.
Equally as painful. Not painful, equally as informative. Let's say that. All right, so I think it's this screen. Although when I hang on one moment, there is my research. This one. Okay. So are you guys seeing the presentation mode or the small slides? Presentation mode?
I see that
Okay.
presenter view.
You see the RD examination review research topics?
Yeah.
Okay, good. Okay. So some of this, some of this I'm just going to tell you have to memorize because it's stuff that's really on the exam. I really kind of pared this down so it was very specific for the exam for this review topic. Okay, so, and most of what I say is going to be here on the slides because this way you have it when you go to study. And this is taken from the Academy's research manual, so it's very much Academy-ish, which is helpful for the exam. So much of this you'll know already, but I don't want to assume, so we're going to go through all of it. So there's basic research and applied research. Basic research the goal is to increase the body of knowledge, explore unknown areas, and all variables are subject to rigorous control. As an example, the examination of the structure of polyphenolic compounds tends to be kind of lab benchy kind of work. In applied research, we use applied research to support operational decision-making, testing concepts, interventions, goods or services. It's research typically with humans, and research with humans involves more independent variables, making control difficult. So you have your independent variables that you're trying to control and your dependent variables, which are, like in our COVID study, it was whether the length of stay. Also in the earlier study, Rachel, it was, I think we looked at length of stay as well. So it's your outcome variable. So with humans, you can't control everything. With mouse studies, like rat studies, with basic research, you can order mice that have the exact same genome. So you're taking that individual aspects out. You can order the chow that you feed the mice, exactly the same. So with human studies, it's a little bit more difficult to control for everything. And it's more applied, but then we're practicing on humans, so our patients, you don't know their genome either, so it just makes things a little bit more complex, but it's where we need to get to. So with research design, you consider your research question, the time that you'll need to do the research, the space and resources that you need, the number of subjects. Usually you calculate using a power analysis, which is you can look up the formula about how to do that, but typically I've never seen that on the exam. But to determine if you have enough statistical power, enough subjects to potentially find significant results that are there, you would do a power calculation. And then there's ethical considerations. For example, we're considering some work with protein feeding, a feeding study giving patients different amounts of protein and patients with inflammatory bowel disease. So high protein, especially animal protein, is a known contributing factor. So if you want to explore low protein diets and to see it, low protein meaning 0.8 grams per kilogram body weight, which just meets their needs, you can't have your other group getting high protein. That would be unethical because you know that's damaging. So we're just going to have kind of usual dietary intake and low protein, but we're not doing a high protein group. And then resources available. A lot of times when we critically review the literature, we're like, why didn't they do that? Why didn't they do that? And they had such a small sample. Why didn't they recruit more? Because it's resources to, limiting. So there's only, every research project has limited resources. There is quantitative and qualitative research. So quantitative, you're collecting numbers typically, and qualitative is more, you can think of focus groups as a qualitative type of analysis where you're looking at people's perceptions, their knowledge as they describe it, as opposed to a knowledge test that would be quantitative. So with quantitative, we have experimental, quasi-experimental, and non-experimental. So experimental research, you're examining a cause and effect. It's the gold standard is your randomized controlled trials, clinical trials. So very structured, a lot of control variables. Quasi-experimental or observational research, you might think of cohort studies. I'm going to give you some examples in a moment, or case-controlled studies. And then non-experimental research designs are observational. You're not controlling anything, you're observing. And epidemiological research, which is descriptive. And I'm going to show you examples of all of these. So in experimental research design, all factors are held constant except those manipulated by the researcher to determine cause and effect. So the independent variable is typically manipulated, the amount of protein in the diet, for example, in a feeding study. And then everything else is held constant. We're holding calories constant and other factors constant. There's in experimental research, you have a randomization process. So randomized selection of subjects from a fairly homogeneous population. So you look to get, for example, if you want to study the effect of diet intervention on IBD, you're going to rule out patients that have cancer, or rule out people that are pregnant, or rule out, because you want your sample to be homogeneous, because that's controlling for some other individual factors. So homogeneous population, you're going to randomly assign people to be in the control group or the intervention group. So completely random. And random is not every third subject. It's not by address, for example, because there's subtle non-random factors in there. So especially address, it might be the environmental factors. Maybe it's the water in that particular community, for example. So random has to be truly random. We usually use random, have computer randomize. And the computer randomization process would tell you, okay, of the 20 subjects, subject 5, 10, 8, are in this group, completely random. And your sample is the subjects you pick from the general population that you want to study or to learn about. Okay, we talked about random assignment. The treatment, you have the intervention group receives the treatment being tested, and the control group is given a routine, traditional care, or placebo. Single blinded means the subject is unaware of what a group assignment they're in, and double blinded means that the subjects and those providing the treatment, collecting and analyzing the data, are unaware. So typically just the statistician knows, because as the person who's conducting the study, you'd be surprised. Like we did the feeding study and we had to analyze the cheats. So I know that we're controlling for protein. So if I'm the one doing the computer analysis, nutrition analysis of the cheats, I might want to minimize the slice of pizza because the cheese has protein. I don't want that to impact my results. So as the researcher, you want to find significant results, and you tend to just interpret things with a bias. So it's better if the researcher and the subject are blinded and only the statistician who's doing the analysis knows. who's in what group. Quasi-experimental, so now we're getting into where there's less control, and that might be a cohort study. So a cohort is a group of people with similar characteristics that are followed over an extended period of time. You may have heard of the nurses study, where they identified a group of nurses and then followed them forever and studied all kinds of things. And it's used to study the impact of lifestyle factors, which determine exposure to different things. It might determine exposure to fiber. It might expose, lifestyle factors might determine exposure to certain pollutants, or estrogen, for example. In the nurses study, they looked at that as well. So you're looking at the impact of lifestyle factors and disease incidence over time. So you're following these people, you're seeing, you're collecting all kinds of data about lifestyle factors, including diet, leisure activities, physical activity, medication, etc. And then you're looking to see what happens over time in terms of disease incidence, meaning incidence is the new numbers, the number of people that develop diabetes over time, for example. So with the nurses study, they started in 1978, and I think they are still following these people that are still with us. And they've just published a tremendous amount of data looking at different lifestyle factors and incidences of diseases over time. So identify, this is an example. So this was to identify individual or patient, a particular disease or condition, and with exposure to factor of interest, that doesn't flow so well, matched to another individual or case with the same age, gender, weight, medical history. So this is our case control. So now you have your cases, and then you try to find your control group consistent of people that are matched on certain factors. So you typically match on age, gender, weight, but also medical history. There's also an interesting study where they matched on sociocultural factors by finding the controls in the same family group. So they live in the same house, so they're going to have a lot of exposure to the same kinds of things, but now age would be different. So you can only control on so much. So you pick your cases and you say, okay, who's going to make the best control group, and then follow them over time and see what happens. So in this particular study, they were looking at to study the nutritional risk factors and status of vitamin D levels in patients with breast cancer. A total of 100 women, they were the cases that had breast cancer, with confirmed breast cancer, were matched with equal number of healthy female controls of similar age and socioeconomic status were included in the study. Okay, so those are your cases and your controls, and you're studying the relationship between exposure, level exposure to factor of interest and prevalence of disease. And in this study, they found a significant association was found between low vitamin D with risk of breast cancer. Okay. And then descriptive research is used to devise hypotheses and propose associations that can be studied in a more experimental way. Cannot be used to test hypotheses or demonstrate cause and effect. Examples are epidemiological studies, and we read a lot about epidemiological studies, and people then want to say cause and effect, but you really can't. Mediterranean diet, like looking at people that in the Mediterranean that follow a Mediterranean diet and then saying, well, they have less cancer. So you can't prove anything with that, but it's descriptive and it generates hypotheses that you can then study in a more controlled fashion. Correlational studies, case series, surveys, surveillance systems, these are all examples of epidemiological studies. And then qualitative studies use narrative work. Focus groups is a great example. In-depth interviews as another example. So this is an example with epidemiological research. So the effects of artificial sweeteners on type 2 diabetes glycemic parameters. So study disease patterns, frequency of disease, which can be measured by incidence, which is new cases of the disease, or total prevalence in the population, which includes those that had it, as well as the new people that are getting it, and potential etiological and risk factors. So in this case, the objective was the present study was carried out due to the importance of artificial sweeteners in diabetic patients for comparing the level of blood sugar before and after consuming products with artificial sweeteners. A total of 30 outpatients were included in this clinical trial. The patients were prevented using artificial sweetener containing diets for 3 months, and they used the frequent diabetic diets instead. After this period, patients were fed with diabetic. Why is this language so weird? Especially diets containing artificial sweeteners. What they find? The results are indicative that consuming foodstuffs containing artificial sweeteners increase blood sugar in diabetic patients. This must be a translation from another language. But this is epidemiological. You can't say that artificial sweeteners increase blood sugar in diabetic patients. It's epidemiological. There have been a few, though, with artificial sweeteners, but you can't say cause and effect. Non-experimental or qualitative research, again, focus groups, ethnography. And Lorraine presented a little bit on this about how you do coding and content analysis to develop hypotheses that you might want to test later on. Historical descriptive studies, also non-experimental, and case studies. You might see case studies that are published, like a really interesting case, but of course you can't speak to cause and effect in a single case study. Other types of research, review of research, so review articles and meta-analyses. We looked at some of these during the internship year, and they summarize the statistical results of controlled empirical studies and clinical trials, especially when most studies had small samples. And they have, through statistical methods, they combine the results of many studies with similar hypotheses and small samples that allows for estimation of strength of the relationship between the variables over all of the small studies that we'll put together. Okay, so terms that you might need to know for the exam. Cross-sectional data, data collected on a group of subjects at a single point in time, like a snapshot, a single point in time. Longitudinal studies follow patients over time, over a prolonged period of time. And the baseline data is compared to data at the end. Prospective studies start with the belief that a behavior will create a particular outcome, so they follow patients forward in time. And retrospective studies look at manifestations of an outcome and try to uncover causes or relationships by going back in time. So the subjects that we did over both years were retrospective, where we went in the chart after the patients were discharged and we looked backwards. In terms of research, the general principles, you know, the hypothesis, null hypothesis. So hypothesis is a proposed explanation for an observable phenomenon. And the object of research is to test the hypothesis. And the null hypothesis is a statement that there is no relationship between variables, that there is no difference. And the alternative hypothesis is a statement that states the opposite, that there is a relationship. Variance is the measure of the amount of variation.
Just a quick question about that.
Sure.
Because I just had this in like a graduate course I was taking. So the alternative hypothesis, in essence, that's the same thing as just hypothesis, right? That's what you're going to, what you're setting out to test, right?
Yes, the overall hypothesis is usually written as the null, that there is no relationship between dietary protein and time to remission in IBD. That would be your null hypothesis, which is usually your hypothesis. It usually is worded as the null. And the alternative is that there is a difference in, I forgot how I said the other one. There is a difference in IBD exacerbation based on protein intake. So the alternative is that there is a difference, and the null is that there is no difference.
So I guess it depends what you're testing.
Well, you test the null. You're always testing the null. Statistically, you test the null. And the alternative is that there is a difference. And you could say there is a difference, or you can say you could give directional, like there is an increase in exacerbation or a decrease. But usually it's just worded as there is no difference. So the null, that there is a difference. The null is no difference. Alternative is a difference. And the next slide might explain a little bit more. So hold on just 1 minute.
Thank you.
Yep, we'll get back to that in a moment. The variance is the measure of variation of all scores, usually determined by the standard deviation. The dependent variable, the outcomes are variables of interest, the outcome variable, and the independent variable are the ones that are thought to influence the dependent variable that you control. So I'm thinking protein affects IBD, so that is my independent variable, and I'm going to control that through my feeding study. And the sample size is the number of subjects in the study, and it needs to be large enough to show significance if it's there. We have random samples, completely random, drawn from the entire population. For example, all members of the target population have an equal probability of being included in the sample, and therefore you can generalize to the population at large. Stratified random sample means that the larger group is divided into subcategories or strata. So with our IBD study, we thought about doing stratified, where we would stratify them based on disease severity, because there's a disease severity score for IBD. So you can get, you could say, okay, I want a certain number of subjects in the very severe, a certain number in the moderate, and a certain number in the not severe. And this is if you really think it's important to have representation across those groups, because if it's completely random, you might get all severe. So if you think it's important that you have representation from different strata, then you stratify your people that you've recruited first into the different strata, and then you randomly pick within each strata. Systematic sampling is a procedure for selecting a probability sample when lists of the population are readily available. And this is like every fourth or every third from a mailing list. That's systematic sampling. Cluster sample is a procedure that first samples a larger group and then specific subgroups or units. So RDs in Illinois, and then a cluster might be RDs in urban hospitals that work in urban hospitals. Accidental samples of subjects are readily available but not screened for any particular characteristic. It's not random. It's the first 100 to answer an advertisement. So that might sound random to you, but what might influence that? Well, maybe people that don't work and they're home to hear the advertisement, or people that have cell phones that can respond quickly. So it's not really random. It's not random. Correlated sample, the classic example are homogeneous pairs, like twins. Individuals matched by a diagnosis is a separate example of a homogeneous pair. And they are identified and assigned to separate groups. So one twin would be in the control group, one would be in the intervention group. Or you identify two patients of the same age that have breast cancer, one you put in the control and one you put in the treatment group. Independent samples are when there's no relationship between the two individuals in one or more groups, or no relationship between the individuals in the two groups. Control of bias. So bias is a distortion of the results caused by some factor other than those under study, and it can mask the true relationship between the factor and the impact outcome. And an example is the psychological impact of researchers or subjects. So to avoid bias, you blind the study so subjects don't know what assignment they're in. Double blind, again, is neither the subject nor the researcher know. And the placebo effect, subjects respond to what they believe are expectations or because they're participating in a study. So that's what we're trying to avoid by blinding, right? Is that placebo effect. Control groups should be representative of the population under study. We talked about match groups. Experimental and control groups are similar in size and number, not randomly assigned from a population to either experimental or control group. So when you're matching, you're controlling for things, so it's not random. Self-selection of subjects that choose to be in an experimental group. So a lot of the supplement studies, we have to, have that where patients are willing to take a vitamin supplement or a herbal supplement, and therefore they join the study. That's not really random. They are biased and likely to want to see an effect. When we have our variables and when you put them into a statistical analysis program, you have to characterize the variable by the categories shown here. So sometimes they'll use these terms on the exam. Nominal variables are variables that group different categories with names, not numbers, like male or female. Dichotomous is when there's only two. Responses fall into two mutually exclusive groups, like a yes or no question. That's dichotomous. It's a subset of the nominal variable. So it's categorical. Ordinal variables are categorical variables that are ranked in a continuum. Think of a Likert scale. So set of items to which the subject expresses an opinion or attitude and agrees or disagrees to a particular extent. So it might be 1 to 5 or 1 to 7. So that's a scale. Continuous variables take on any value of the measurement scale under consideration. So energy intake, height, weight, temperature. So those are continuous variables, and within continuous, there are interval and ratio scales. So an interval variable are variables in which the categories have equal value between scores. Equal value between scores, like temperature. Ratio scales are variables in which the categories have equal value between the scores and a meaningful 0 point, i.e. something does not exist at 0. Examples include age, you could be 0 before you're born. Weight, you really can't be 0, but 0 does mean something. And height. Validity and reliability, definitely memorize these definitions. I've seen this on a lot of different sample tests. So validity is the ability of a test or an instrument to measure what it's intended to measure. So like this body composition, really measure body fat. Is it valid? And you compare it to a gold standard like DEXA, used to be underwater weighing. Reliability is the extent to which measurement is reproducible, consistency of results. So is your scale reliable? If you get on and off your scale 3 times in a row, does it always give you the same weight? Accuracy is a quantitative measure of validity. Gram weight of a cup of flour to establish accuracy of the measuring cup. So is the shape of the measuring cup actually measuring a cup? And you could see if that's accurate by weighing it. So accuracy is a quantitative measure of validity. Precision, quantitative measure of the reliability of an instrument, described by the amount of variation that occurs. Okay, so validity goes with accuracy and reliability goes with precision. And replication is the attempt to reproduce the method and results of earlier research to determine validity and reliability of the original study. Just make some flashcards, keep memorizing them. Okay, now this one, I actually found this online because it's so hard to conceptualize, in my opinion, at least in my brain, unless I had a real example. So again, we'll go through this, but you're gonna have to sit down quietly by yourself and just keep going over this and have index cards. So the difference between sensitivity and specificity. So there's a prevalence of the disease, so that's shown here as T disease divided by total times 100. That's the prevalence. That's how you would determine prevalence. So those with the disease over the total times 100, total in the population. So sensitivity is the probability that a test will indicate disease among those with the disease. So you can see here, and this to the right, we have truth up on top. They have the disease or they don't. And then that's the columns. And then the rows is what the test result is, positive and negative. So if you have a positive test result and they actually have the disease, that's a true positive. A is a true positive. You can have a test result though that's positive and they don't have the disease. That's a false positive. You can have a negative test when they have the disease, and that's a false negative. You can have a negative test when there really is no disease, and that's a true negative. So if you go across the row into positive, then you get a positive test result includes the true positives and the false positives, and a negative test result includes the false and the true negatives. And then if you read down, you have the real truth of who has the disease and the real truth of who doesn't have the disease. And if you add those all together, you have the total population. So sensitivity, again, is the probability that disease will indicate disease among those with the disease. So you take A, those that have the disease, you divide it by A plus C, which is your true positives and your false negatives, and you times it by 100. You just have to look at this. And if you just go through it yourself, not me reading it, if you just go through it yourself and put some numbers in, and down here I put some numbers in, and just go through it and make your index cards and talk yourself through it. All the words are here, everything is here. My source is here if you want to go back to that. But I think this is the best way for you to, conceptualize it, is to actually do these examples, all right, and make up your index cards. I've seen this on the test, so I would spend some time on this one. There's really nothing more I could do to explain it. You just have to go through the numbers. And I think by me verbalizing it, it almost is more confusing. Okay. Compliance is strict adherence to study design, and there's types of non-compliance. There's dropout or attrition, and there's failure to comply with the protocol due to a change in motivation, or it's just hard to follow. They might stay in the study, but they're not really following. Ethics, we talked a bunch about. You have to really consider your conflicts of interest as a researcher. When you publish, you have to disclose anything that any association you might have with the treatment. Subject related issues, you have to ensure confidentiality. We talked a lot about this. You did the CITI training. You code your data so that after people have been assigned and you have their data, you just code it so that you don't have to keep, you don't want to make available the subject's name or identifying information. So you give them a code, and you should have the code and the person's identifying information in one spot that's very well protected. And you have to report positive as well as negative results. Research evaluation checklist. Requirements, you have to clearly state the problem. Usually you pull in prior research here, clearly define how problem is observed, appropriate length of time to observe development of a problem. Develop your research question and hypothesis, design the study to test the hypothesis, create your intervention, your measurements, plans for analysis. You have to plan your analysis before you actually do your study. That's ideally what you're supposed to do, so that there's no bias built in there. Precisely describe the subject group selection process, the appropriate number of subjects by doing a power calculation, and how you made the assignments. Obtain your IRB approval, conduct a pilot study, obtain funding, and then do it on a larger scale and write up your conclusions. It's really, your responsibility as a researcher to make your results known, add to the body of literature. Descriptive stats will definitely be on the exam. Frequency distributions, how is a variable distributed among the subjects. So frequency distribution, arrangement of numbers on a graph showing the number of times of a given score. And this is where we look for the bell-shaped curve. For example, for this year's project, the vitamin C was not normally distributed. There was not a bell-shaped curve. Make sure you know the difference and the definition for mode, median, and mean. How these are shown in different tables. Variability, the degree to which scores vary. Again, standard deviation is our measure of variability. The range, what that means. Z-scores are when you convert the scores from 2 or more different tests into standardized units, and indicates how many standard deviations a value lies above or below the mean of the data set. I'll show you an example in a minute, and I'll show you an example of skewed distributions. They could be skewed to the positive if the median is less than the mean, or negative if the median is greater than the mean. I'll show you in a minute. So, okay, the distribution, bell-shaped curve is here. That's where we get our standard deviation measurements from when we do the mean, plus or minus 2 standard deviations. That's really only meaningful if your data is normally distributed. The z-scores on the bottom, a positive z-score is 1 standard deviation to the right, negative z-score is 1 standard deviation to the left. You should know in the pediatric literature that we look at z-scores for height and weight and BMI for growth parameters. And here's an example of skewed data. So the median and the mean are not, the mean is to the left of the median. So you have some data points all the way to the left, which pull the mean to the left, but not the median. And the mode is the most common. Okay. All right, standard error of the mean. measures the confidence level relative to the population sample size and describes the variation relative to that population. So the sample mean is the usual estimator of the population mean. However, different samples drawn from the same population could, in theory, have different values of the sample mean. So if you have a large population, that has a mean, but you sample a group here and they have a mean, but if you took a different random sample, the mean would be different. So the standard error of the mean is the standard deviation of those sample means over all possible samples drawn from the population. The standard error of the mean can refer to an estimate of that standard deviation, and it's computed from the sample of data being analyzed. So it's a statistical term. I haven't really seen this on the exam so much, but the standard error of the mean is not exactly the same as the means, the mean of the sample. This one I don't think is on the exam so much. It's more higher level stats. Descriptive stats, we talked a lot about correlations between two variables. The Pearson product moment correlation coefficient describes the strength in that relationship. High correlation does not imply cause and effect. Just because two things correlate, there could be a third thing causing both of them. So correlation does not imply cause and effect, and that's definitely could be on the exam. Common effect size, so 0.1 is considered small, 0.3 is medium, and 0.5 or greater is large. Correlations only go 0 to 1. And we have a positive correlation, so as the X variable goes up, the Y variable goes up, and negative correlation, when one goes up, the other goes down. Inferential statistics are used to describe the data and infer results to a larger population. So going beyond describing our population, but now we're trying to make predictions. And this is where we get into significance. So significance tests could be one-sided or two-sided. I don't think this is on the exam, but one-sided is if the hypothesis specifies in advance that the treatment group is different, either positively or negatively. So you don't just say there's no difference. You say, well, your alternative hypothesis would pick a direction, saying that there's a positive or a more negative. So two-sided is no direction of the relationship is given. So the null says no relationship, but the alternative, you can either say there is a difference or you could pick a side. Usually we don't. And the two-sided is no direction of relationship. You have to have a really good reason to pick a side based on prior literature. A chi-square test is used to show the relationship between two categorical variables that I would know that might be on the exam. I've seen t-test, that language or that word used more on exams, and that's used to determine how significant the differences are between the mean score of two samples. So you have two groups and you're looking to see if the mean between them is significantly different. And that's a t-test, and the pair t-test is used with pre and post intervention data on the same subjects. So that the data is paired because it's the same person. Okay, so you have the difference in IBD symptoms, let's say, before the intervention and then after, but it's the same people, so you have to control for that. So that's paired. All right. I don't think they'll ask you about regression, but regression is used to determine the association between two or more variables and to make predictions based on their linear relationship. So you have an age on the x-axis, BMI on the y-axis, and then you have your regression line, which is the line of best fit for all these variables. And then you could make judgment based on, let's say there's no one 70 here, but you can make based on this line, you can make an estimate of someone's BMI at 70 by using the line, right? So you would go up to your line, then go to the BMI, to the y-axis, and then say, okay, it looks like it would be about 31. So that line of best fit is then used to make predictions in the future. Repeated measures analysis of variance looks something like this, where you have different groups depicted by the different lines. And then over time, you're checking a particular variable. So you're looking to see if there's significantly different patterns of these 4 different lines in their blood glucose. and if that's significant. So analysis of variance is used to say if the patterns of a quantitative variable is different among different groups. So interpretations of current research, when you're reading research, recognize limitations. We talked about that. Violations of the research protocol, sources of bias, sample size might be too small, response rate, compliance, attrition, missing values. These are all potential limitations. Okay, now we're getting to something that's going to be really important is the next slide. So hypothesis testing. The outcome is a determination of whether the original hypothesis is supported by analysis of the data. So we talked about the null and the alternative. The null hypothesis is a statement that there's no relationship, and the alternative is that there is a relationship. And this is often on the exam. So this concept, and they ask it in different ways. So your hypothesis is that there is no relationship. And if it's true and there is no relationship, and you accept that null hypothesis, you're making the correct decision. There's really no difference, and you state that there's no difference based on the outcome of your statistical procedure. The hypothesis, it could be true that there's no difference, but there really is no difference, but you state that there is because that's the way your statistics came out. So it's like a false positive. And it can happen. Statistics is not 100%. So the null hypothesis could be true that there's no difference. And sometimes we accept it, but sometimes we make that type 1 error and we reject it. And we say, oh, there is a difference. We reject the null. We reject that there's no difference, meaning that we say there is a difference, but there really wasn't. So that's a type 1 error. And you can also say that the hypothesis is false, the null hypothesis. So the null hypothesis is that there is no difference. And you could say that that's false. So there really is a difference. Did I say that other one right now? Well, let's keep going. So the null hypothesis is false. So the null hypothesis is that there is no difference. And you're saying that that's false. There is a difference. So there really is a difference, but you state that there is no difference and you accept the null. That's a type 2 error. And the null could be false, that there is no difference. Oh, the null hypothesis is that there is no difference, and that could be false. So the null is that there is no difference, but it's false. So there really is a difference. So there really is a difference, but you state that there, and you state that there is a difference. That's correct decision. Okay, so that's the difference between a type 1 and a type 2 error. And again, it's just one of those things that you just have to memorize. You'll probably promptly forget after the exam, but you just have to memorize this. The p-value is the probability of rejecting the null hypothesis when it is true. That's what the p-value means. It's the probability of rejecting the null hypothesis. So the null hypothesis is that there is no difference. You reject it. So you say there is a difference when there really wasn't. And that's what the p-value stands for. And the null hypothesis is that there is no difference. Okay, so if you accept the null hypothesis, you're stating that there's no difference if you accept it. If you reject the null hypothesis, then the alternative hypothesis is accepted and you're stating that there is a difference. So you reject the null and there is a difference. And you're stating that there is a difference. So again, one of those things you have to read through yourself, make some index cards. And then the peer review process, for if you choose to go into research. I just had one of my alumni say that they did our online masters and it really made them want to do an online PhD. So they're going on to do a PhD and will then probably go into the publishing arena. So the whole peer review process, we depend on that, right? When we read the research literature, that there are experts in the field that have reviewed it and deemed it to be appropriate, and it gets published. So we depend on this peer review process when we're looking at literature to guide us in our patient care. So it's really important that it's hard to get published because you want to make sure that what is published is true. So if we start on the bottom here with an electronic submission, when you submit a study to be published, the first person that sees it, usually the editor-in-chief, can reject it right out and say it's not appropriate for the journal, or it doesn't, just reject it outright. Or they can submit it for review to people that agree to be reviewers for a particular journal. So when you get a PhD and you're a professor, a research professor, you're expected to volunteer, it's professional volunteerism, to review articles in various journals, to be a reviewer. So you get assigned a few articles a year, and they take the name off so you don't know whose work you're reviewing. And then it's reviewed by the OE, which is our overseeing editor, and the EIC, which are the reviewers, the editor-in-chief, that's the editor-in-chief. So it goes out to review. The reviewers might reject it outright, or they might recommend that it can be published with some revisions. That's kind of common. So the person who wrote it gets a chance to resubmit, send back for review. It can be returned one more time for some revisions, or it can be rejected outright. If you submit again, you'll get that's probably your last shot, and it would be rejected outright, or it gets accepted. So the review process is usually at least 2 go-arounds. That's pretty standard. And that is it for our formal presentation. So we have, let me just check my calendar. Okay, so I have a few more minutes. So again, stand by, Rachel, if you're interested. I don't know if I gave you a headache with those terms, you could sign off. So for our research project for the research group, and for you guys to be able to put it in your portfolio, I said you can use the poster, and you can. But in talking with you, I realized the poster's not perfect either, and we're gonna do it. Resubmit it for women in. We submitted the abstract again for Stony Brook's Women in Science poster presentation or research seminar. So one of the things that I wanted to clarify is that you can actually pull up the poster. You can use the poster, but the poster is above and beyond what we originally said was going to be your group project as a group, and I'll clarify why. Let me just pull up the poster. Oops. Where is it? Okay. Okay, so I had given this to you guys. I gave you the recording, and the recording I think some of you used in the PowerPoint, which is fine. Well, it's not there's when you're explaining the poster, when people come to your poster session and you're explaining it, I tended to use more casual language than you'd really want to put in your actual formal presentation that would go in your portfolio. So originally our question was based on the fact that there's no consensus about vitamin C or vitamin D specifically in the literature, whether it can help or help our COVID positive patients, right? So prior research on the relationships between micronutrients and patient outcomes has been mixed. So we wanted to add to that body of literature. So we did everyone's hypothesis. I mean, I gave you guys individual feedback on your hypothesis. That was fine. The methods were, I think, overall okay. You guys had the inclusion exclusion criteria, and you could use this demographic table as your first kind of results, but it will be different than the sample that you had available to you at the time when the assignments were due. right? So I just want to make sure, I think I told all of you this. I think you guys did a great job. I think you learned a ton. I just want to make sure that what you put in your portfolio makes sense. So if you are going to put this in your portfolio and you want to use this demographic table, I know you guys know how to do this. We did this together. So it's fine for you to put this in there. But then I needed to help you get the correlations that mattered, because the way we designed it, we were looking for the relationship between the micronutrients and the outcomes. So this second chart would still be adequate and okay for you to put in. Makes sense. So you know well and can explain well the difference between ordered, what the MD ordered and delivered, and that we included the calories and nutrients, micronutrients from both the formula, the Prostat, the propofol, and the micronutrients. So I'm very comfortable that you can explain the ordered and how that differed from the delivered, and that the reality is somewhere in between, right? Because the I's and O's weren't perfect and the orders cannot always be fully implemented. The length of stay, I know you know what that means. The total vent days, I know you know what that means. One thing I don't know if I told you was the CRP change. So in our data set, when we created this final data set where each subject is a row, we took the average nutrient intake over the 7-day period, the average CRP. But I thought that's not really good enough, because the average CRP is going to include, let's say there was a correlation between C or D and CRP as a marker of inflammation. Well, if you're giving them that micronutrient for 7 days, you would expect, it's high in the beginning. If the micronutrient helped, it would help bring it down. But now you're comparing the average nutrient over the 7 days to the average CRP, which includes the highs. So I'm thinking that's not the best indicator if there's a correlation. It would make more sense to do the difference. If vitamin C is going to help or vitamin D is going to help, it would create a bigger difference, because the CRP would come down, inflammation would improve. So I don't think I shared this with you guys, but before I put this together, and I took the Annie was helping me. Before I took the 7-day average, I took the difference. I calculated the difference for each subject. So I took the first CRP in the 7-day period and the last, just created a difference. So these difference scores are what I thought would be really important. And so in our poster, that's what this CRP changes. And the higher numbers indicate a greater reduction, because I took the first. So let's say CRP was 100 and it came down to 10. The difference would be 90. So positive big numbers mean a positive big change, a decrease in inflammation. So if the change goes up with CRP, that would be a good thing, right? If vitamin C goes up and the change goes up, that means a good thing. So then what I wanted to share with you. Okay, so then I did the correlations with the C and the D, and I didn't send this to you yet, I just did it. So this is the vitamin C ordered and the vitamin D ordered. And here I did do ordered because if the physician ordered vitamin C IV or a multivitamin, the patient's got it. It was the tube feeding that was often stopped or started. But most of the micronutrients, if we're giving enough, are going to come from the supplement. So I use the ordered. So here, the CRP change and vitamin C is a big whopping 0. But remember, this is the, it's good to show this too, and I didn't do it with D, but I can before I send it to you, is we gave only 4 patients more than 2,000 milligrams of vitamin C in early part of 2020. So that's our limitation, right? Many of you picked up on that, is that it was really hard to show that vitamin C mattered because we simply didn't give enough. So in the current group of interns that have a few more weeks with me, they have some extra research days at the end, and they're going to do more. And there's 2 people that are doing their CQI project for their inpatient rotation. They're going to do more in March, April 2021. So now our sample will go from 38 to much bigger, and we should see a lot more patients with a lot of vitamin C Vitamin D, we still weren't doing a great job of giving a lot of, but we'll see. So right now with the vitamin C, this is MD order, no correlation with change in CRP as a marker of inflammation. Really nothing for total days vented, and really nothing with length of stay. I mean, they're not even 0.1. With the vitamin D, with CRP change, again, it's 0.08. It's really nothing. And negative is actually would mean would mean that the more vitamin D we gave, the more D, the less change. But remember, the big change scores are good, but it's really 0.08. It's not even 0.1. So the only thing that's a little bit is actually the vitamin D with the length of stay, but tiny, 0.1 again. So probably not significant. So as we were analyzing the data, so that answers your question once I give you guys the correlation. So if in your poster you want to just focus on these, you could put these two results, and then I had the vitamin C one there. I'll give you the vitamin D one too, so you can have the scatter plots, and you could call it a day and just say there was no correlation between the micronutrients and length of stay, vent days, or decrease in inflammation. What this poster shows, and what we talked about towards the end of the research rotation, is, okay, well, man, I really expected there to be a difference. There's a physiological reason why there could be a difference, and that was in the PowerPoint presentation that you guys listened to in the beginning. So, and looking at this data, I started to think, well, we're just not giving them enough calories and protein. So this is, the left is protein, the right two things are calories, right? So for protein especially, most people got less than a gram of protein a day, right? Less than a gram. Calories, they got, well, the mean for calories ordered was 23, delivered was 14. The reality is somewhere in between. So they didn't get enough calories, but they really didn't get enough protein, because the ordered was 22 plus or minus 14. And the protein kilograms per kilogram per day was 0.8 ordered and 0.5 delivered. Reality is something in between. So the calories like are okay-ish kind of because of the propofol, but they really didn't get enough protein. So then I'm thinking, well, maybe it's because we're not controlling for calories and protein, and therefore not seeing an underlying relationship with C and the D and the outcomes, because we're not giving them enough calories and protein. So, so then we were like, okay, well, we were advancing our question. So the objective was to determine relationships between macronutrients and outcomes that may confound relationships between micros and outcomes. So again, what we started out with your group in the beginning of the year was, do micronutrients impact outcomes? And then as I was seeing that that's not true, I just was, it's, again, as long as you talk about it honestly, and I would have to really spell it out more if we were to publish this, but we started to say, okay, we're not seeing a relationship. We're not giving enough, but maybe now that I'm seeing that we're just not giving enough calories and protein. So then we looked at these relationships, but they're still not hugely, very, very strong. The correlations here. And I realized I didn't put the correlations on the poster, which I'm going to add. So they're not very strong, but they're in the neighborhood of 0.1. So I still think now when we collect the data, if we control for calories and protein, maybe we'll reveal a relationship between C and D, because the correlations, actually I have to see where they are. So this is the MD ordered calories per kilogram, and vent days was almost -2. So more calories, less vent days. more protein, less vent days. So for vent days, there's almost a 0.2 correlation in this real sample that came at the end. Length of stay, a little less strong, but at least something. So there does seem to be a relationship between vent days, the outcomes, vent days, length of stay, and the macronutrients. So to me, it does speak to the fact, well, once we control for these and we give enough micronutrients, maybe that will still reveal a relationship. So you can simply put in your posters or your presentations, that's going to go in your binder, your PowerPoint presentations, this graph, the total vent days of all patients and C, and I'll do it for D, and because it's so quick, and the length of stay for both. You could just put those micronutrients in and there's no relationship. And you can kind of in your conclusion state that. But if you want to make the leap, because I told you guys could, because everybody put so much work into this poster, you can use this, but I just wanted you to understand a little bit more about how we jumped to these scatter plots. So you'd have to change the hypothesis as well, so that so it all gels together. So you kind of have to make a decision. And if you want me to look at it one last time, you're done with the rotation. You all did great on the rotation, and that's fine. But if you want me to look one more time at what you put in your professional portfolio, I'll do that. But just stick to one story. Either stick to the initial story and have your hypothesis reflect that about micronutrients and outcomes, and there's no relationship. And I speculate it might be because we didn't give them enough protein and calories. That's the simplest. But if you want to change your hypothesis to be something like, we speculate that there's a relationship between calories and protein and outcomes that's masking a potential relationship between the micros, then these graphs make sense. Otherwise, you'd put the graphs with the C and the D and the outcomes. Does that make sense? I have Samantha, Caitlin. Is Miriam not with us? So I'm not seeing her because I think we're missing some people. Okay, so I'm out of time. So, like I said, if you want to decide which way you want to take it for your professional portfolio, send it to me one more time. I'll look one more time, okay? And then either way you want to do it. And everybody got their individual feedback. Okay, I'm leaving. Lorraine's got the control buttons, I believe. I think, Lorraine, I may have to make you a co-host. Or no, you're in the driver's seat where you are. So I think I just have to stop sharing. And I'll leave you guys for a while and I come back
I don't know if you can hear me.
We can hear you now. You can't hear us. Can you hear me? Do you hear me, Lorraine? I guess not. Let me go pop in. Hold on.
Can you hear me? No. Do you have me muted for some reason? It doesn't. There's a different adventure here. I just left. Maybe that helps. Let's see. I'm muted. You didn't hear me either. Can you hear me? You can hear me. Somebody
Yes.
else talk.
Yes, can you hear us?
Rachel. Yeah, Rachel. I can't hear you. But why? Kate, would you try to talk? Unmute and talk, or Sam? We can't hear you.
Hello? Hello?
We can't hear you.
Hello?
What is that?
Hello?
Should I try to go on in my, try to mute, then mute. Yeah. Should I hit audio settings? I'm muting. Oh, speakerphone. Test speaker and microphone. say yes. You can pause, so speak. Hello? Yeah, okay, say yes.
Hello.
Okay, now we can hear you. So I can hear Caitlin. Rachel, talk.
Hi, how are you?
I don't know what it was, but it's fixed. I'll fix it. Okay. Yay. So, so I try to make this fun. So, but this will be, should largely be a review. We're going to start off with food service systems. So, it's a lot though. And I don't know if it was posted on Blackboard. Do you guys have a copy of the slides or no?
I think I saw it on there when I looked earlier, but I haven't downloaded it.
It says food service systems, looks like this. Okay. Well, if you can pull it up and follow along, it'll probably be good. We'll talk about a few things, but I have a lot to cover. So I'd rather spend the time on the, like if we have some problems that you have to, like food service ones you have to calculate, we'll probably just spend a few more minutes on those. Okay. You know, it's been a long day, but this is fun. A lot of this will be review. Okay. So this is considered domain 4 and accounts for about 14% of the test. So you're going to say to yourself, why does she have 111 slides? Not sure. It went by the study guide, and this is what they told me. I had to have enough stuff to cover all this for what you're going to take and what they can ask you. Okay, so getting into food service systems, we're jumping in right away with the menu. So you have to take into consideration, and let me share my screen with you. That would make more sense, right? So you could actually see. This would be dietetic internship. Review course. And it was right here. Yeah, I was trying to review it first. Okay, now I can share my screen. Okay, there we go. All right, of course, because I'm trying to, okay, there we go. Okay, so food service systems. So the first one I'm going to talk about, you guys can hear me, right? Okay. And I'll move this bar out of the way. Okay. So the first thing you want to do when you're designing food service systems or analyzing or looking at them, you want to take into consideration logistical constraints of the operation. So what that kind of means is employee skill levels, the kitchen equipment you have to work with, what the workflow looks like, and product availability. Variety and complexity may increase the personnel. So like room service, you probably need more people to pull up room service than you would if it was a traditional, everybody has a choice of maybe 2 entrees and the tray goes up to the, up to the room. So you may need more people, but you probably have a lot less waste. So there's a lot of give and take. Certainly there's different kitchen equipment you need for room service. And you may need skill set. So the ambassadors, you probably want a few of them that are bilingual and represent the community that the hospital's in so that you can have them take preferences. And you're going to look at workflow. Okay. Okay. So you're also looking at styles. Some of these will be familiar and some of them won't. The table de hotel is a complete meal service for one price. A la carte, I think most people know what that is. That's everything's listed separately.
you have a combination, maybe it's one price for the appetizer and the meal, you pick two kind of things. There's a fixed menu, it's a single menu for several months. And then in food service, we've had cycle menus, usually like spring or fall cycle, designed really for people in long-term care so they get some variety based on the seasons. And now we have even, I think in a lot of long-term care and rehab places, they have more room style service. So the other thing is the business of balancing the menu. So you want to balance the food costs, the menu prices, and the popularity of the items. And your financial and marketing considerations. So this is a big ticket item. It's really well loved. So maybe we put that at the top of the menu or like at the top of the entree list because so people's eyes are drawn to it and that might be what they would likely order. Aesthetic, color, balance, texture, and flavor. When you're designing a menu, even if it's for a room service style thing, you're saying, okay, they can order salmon. What goes good with the salmon? Would it be a baked potato? Would it be rice? Like what would it be? I did design one time a meal and it was all white. It was like cauliflower, mashed potatoes, and I think a white fish, and it was too white. I mean, you can throw a garnish on there. I also did one, the pureed one. I didn't know what it was going to look like. It was pureed fish. It was fish Florentine, so it was pureed spinach that looked like goose poop, and then like some kind of like other white blob. And I was like, wow, I designed this. So I fixed it afterwards because sometimes when you're trying to get the nutrient part and the fish that you can get and all that, you didn't look at what it looked like. So that was eye-opening. And the nutritional composition. So you want a starch, a veg, and a protein. And one of the big questions that we always talked about was how to ensure nutritional adequacy with room service style menu. So when you're doing a menu and they have a choice of two entrees, you can analyze the menu down to everything, the last juice you give them. But when they have the free ability to pick, which is more like what they would do at home, how do you know that they're getting everything? So you may save a few and analyze a few of the very popular menu items that a patient would, or say, I followed 3 regular patients throughout the regular texture, regular diet patients, and this is what 100% of their requirements were met. And I did 2 grams sodium, just so you have an idea if you're giving them the nutritional adequacy that you would want. So there'll be pricing things, pricing questions. You guys are quiet, so please stop me or talk. There's menu pricing. So it's a desired food cost percentage pricing method. That's what it's called. And the director decides on a reasonable food cost percentage and then divides the menu items standard cost by its reasonable cost food cost percentage. So the selling price is, and in this case we did $1.50 was the food cost, and then you divide that by the, I guess what the food cost percentage would be, and it ends up being $4.55. And this is called the desired food cost percent pricing method. So this is how you ensure that I think it's usually like a third, and a third. So it's like a third of what the cost is. I think a third of maybe marketing and the other one is profit. So that's kind of what you're looking for is the profitability. All right, so we did times 0.33. Oh, I didn't do food cost percent. Oh. Sorry, I'm trying to like rework my numbers. So I did 150. Oh, okay. This time I did it right and it came out to be $4.55. All right. So that's the selling, the cost of it, how much markup you're going to do, and then that's the price you're going to sell it for. Okay. So the diet manual guides what's served in a hospital long-term care facility. So you should always, in any facility you walk in the door, you should like ask to see what the diet manual looks like. If it's an A&D one, then you can look at that. We've all probably looked at those, but you kind of want to see what they're serving. And they're supposed to be serving what they say they are. So if a regular diet is supposed to be 2,000 calories, let's say, generally speaking, and you look at it and it's not, then that would be something that you would want to question. Also, when you're calculating needs, so if you calculate someone needs 2,500, the regular diet provides 2,000, you have to then fill in with some snacks and stuff. You want to look at nutritional adequacy, allergies and sensitivities, see what the policy and procedure is for that. how they handle cultural and religious restrictions, and what modifications for vegan or vegetarian options are available. Okay. The other thing is you want to always look at satisfaction indicators. So we have Press Ganey in New York. Did anybody have a different type of satisfaction survey that patients got on the way out the door of the hospital? Anybody remember?
Ours did, I think it was called My Rounding, maybe. And it was like
Okay.
6 questions you would ask the patients.
Okay. And was it hospital wide or was it just for your department?
It was, I believe it was hospital wide.
Okay, so that's what they want to do. They don't want to have a large survey. They just want to know from patients generally, how was your stay? What was the food like? What was the care like? That kind of stuff. I think on Press Ganey, there's only 1 or 2 questions related to nutrition, and some of it's related to food service. You can also use point of sale data. So when they're scanning everything with barcode, that tells you how much has been consumed and how much to order. How popular an item is, what the potential waste is, and what the cost is. So these are, is it cost the right price? Is it overpriced in the cafeteria compared to what people in the area can afford? Potential waste and popularity of the item. Okay, those are all things that go into kind of satisfaction indicators. Now for emergency management, and this is probably a fair game question, long-term care and hospitals are supposed to have a 3-day supply of food. However, I don't know if this is going to change with the COVID-19 because when we realized we didn't have enough feeding pumps and we didn't have enough formula, we started to order a stockpile. So you could see with the pandemic, 3 days wouldn't have done anything for us. The 3-day supply is supposed to be if there's a hurricane, a power outage, maybe a bad snowstorm where the trucks can't get through, you would still be okay. And it's a 3-day disaster menu. And the way to ensure that that stuff doesn't go out of date is you have to, I guess, every couple of months go through and rotate out. So if you have peaches that you're going to put on the menu for dessert, you would have to go through there once in a while, use those peaches and replace it with a new batch so that your stock is always up to date. What is a 3-day disaster menu? What would it look like? And would you need different foods? So, it depends on the disaster. You can only plan for what you have, but you might decide to do like breakfast might be cereal and milk because that's what you can reasonably get them. You might do a sandwich and soup, hoping that you could get something hot, which would be the soup. And dinner might be something else, might be casserole, and everyone would get that. Then what you have to decide is, okay, so the texture people that need texture change, so they can swallow safely, what are you going to give them? And also you would have to decide like the renal diets or I think really the potassium restricted renal diets would be the ones you'd be concerned about, making sure that they didn't get like a banana or something. So those are some of the things you would have to kind of come up with. So based on the COVID-19 emergency, we had to stockpile feeding pumps, bags, 2 feeding products. We needed paper goods and disposable trays because at that point we didn't know how it was being transmitted. And you had to have adequate food for a menu, and probably people, if they were going to stay, or if you had vaccination sites or stuff like that, or we opened a field campus here, we needed more food for those people and adequate for the personnel. So if you have people working, you're going to have to feed them. So those are just some considerations for COVID-19. So like you can't plan for every possible disaster, but you at least have to have some kind of game plan, like when you know this was happening. So Josephine ordered 100 more pumps. We got outbid by 50. So 50 arrived and 50 got bidded out to somebody else. We eventually, I think, got all the pumps we wanted, but it was, we were getting ready in case we had to bolus feed, and so we asked for gravity bags. So that was our other thing that we had to. So every other hospital in the country was doing the same thing. But normally you do bids. So you purchase, you receive bids. And if it's not an equal product, that's not what you want. So you write a specification. Purchasing, they award the contract, and administrators usually sign these contracts. Okay, you have to be very specific how you write it so you get what you want. Okay, so this is inventory management. Okay, so considerations when choosing a vendor. They are responsible for the safety of the food, so they're transporting it to you, so they can't throw it in the back of their car and drive it to you. The trucks have to have sufficient refrigeration and freezer capabilities, and you can ask to see recent health and sanitation reports from the company, and that's probably a good thing to do. you should dictate the delivery schedule. And you're going to plan it. You're not going to have them delivering ice cream in the middle of when you're serving lunch, because no one has time to put it away. And you have to have an appropriate inventory system. And now there's such better inventory systems. So there's full line suppliers, one stop of very diversified suppliers. So on Long Island, we have J. King's, I think US Foods, and probably Cisco is nationwide. Am I right about that? So Rachel, you probably have Cisco and US Foods in New Jersey, right? Have you
Yeah, I believe so. I mean, I see them all the time.
You may even see a J. King's truck there once in a while. I'm not sure. What
That I
about,
don't.
yeah, well, because that's more of a Long Island company. But what about down south? What do you guys see?
We have US Foods and Cisco here too.
Okay, all right, so those are the big suppliers. There's also local specialty wholesalers. They have better prices, but it's very limited selection. National jobbers, I've never referred to anything as this, but it's used for large operations. Some sell full lots and some will split them. So you may do this for, like, say if you go through, I don't know, 4 million disposable trays, you might go to a place like this because you can, if you have storage for them, they'll probably give it to you at a better price. Or you might link up with a sister hospital and say, we'll split the order. And then supermarkets, sometimes you have to run there for something like a specialty item. If the patient on hospice wants chocolate mousse and you don't have it, or they want a papaya and that's not something you normally have, you may do something like that. Or the order doesn't come in. You're a smaller operation and you're having fish on the menu and it doesn't come in, you may have to go. Okay, so technology is so much better than it used to be, but you still have to do some hand counting. So this is a better way to track. Everything's barcoded and you can know how much you have. And there's handheld devices. Okay, and so you always have a par level. So FIFO is first in, first out. Don't kid yourself, this doesn't happen. If somebody's not checking, they put the can path of least resistance, they put the can in the front that you just got. You're laughing because it's true, all right? So you have to be, you know, if you go into food service, that's some of the things you're going to be checking, is those kind of things. You want to establish a minimum level where manager is alerted before you take the last case, can, or item. Nothing's worse than on a Friday finding out that they took your last case of Osmolite 1.5 and you have nothing for the weekend and nobody said anything. So you kind of give a little small cushion to your par level. So if you need usually 2 cases to get through the weekend, maybe it's 3 as your cushion, or maybe 4 as your cushion. So I put here, when 5 cases of tube feeding or left, more is ordered and can arrive before there is no more. It's happened. I worked in hospitals like this happened all the time. It's not that much fun. Okay. So inventory amount translates into dollars. So it's wise to have a cushion, especially like in the winter, you want to have a cushion. And maybe even if you're in a hurricane region or something like that, you may need to have a cushion. But you don't want to have a lot of capital sitting on the shelf because that's just money that's sitting there. Perishables, meat, produce, and seafood have a 2 to 3 day shelf life, and inventories should be very tight on those. And turnover, most items should be turned over within 5 to 8 days. Standing orders can be used if sales are consistent. May order more of a special events plan. So if you're a 150 bed nursing home and you order, I don't know, 300 milks every Monday, you probably don't have to play with the order a lot. But if on the other hand, you're doing a joint event with the nursing home across the street, that day you would have to change the order. But there's nothing wrong with the standing order. Primary vendor, if you can utilize one vendor and you give them most of the business, you can save on many deliveries and you may be able to get better service. But you still have to make sure that the pricing is competitive. And cash, some vendors will give a discount if you pay early. A lot of hospitals, when they got into trouble, you know, they were many days out on paying, and then it got very hard to get food in the door. So now this is how you protect yourself with a purchase specification. You have to have the name, the quantity to be ordered, and what the unit size is, the brand or grade of an item, and what unit is used to establish the price. Then there's other specifications here. You have the name and description, the weight, the shelf life, storage conditions, all these things are here. So with the state of New York, which is who we work for, when they order, they have to have a very specific specification. Otherwise, they might be forced to take a lower price on something, but it may not be the same quality. So what you want to do is make sure that you specify on all these levels the exact product you want. so that you don't have to get the cheapest thing when it's not exactly, doesn't really fit the bill. So ethics in purchasing. So this is where, and this happens, you need 2 or 3 people involved in placing, receiving, and paying for the order. If you work in a very small place, you should still have 3 people involved in this. One person places the order, the other person checks it in, so they don't know what the other person ordered, and then it goes to either a separate department or a separate person for paying. This is to make sure that somebody doesn't order 5 cases, only 4 get delivered, and they split the profit for the other case. Those things do happen, unfortunately, but you got to do what you can to ensure that doesn't happen. Sometimes you can have employees change job from time to time, and this will kind of ensure that everyone stays honest. And you can also randomly do inventories to make sure they're accurate. Just because you have it on a barcode doesn't mean, just because the inventory report says there's 5 cases there, you have to go count those 5 cases. And you also want to verify prices for expensive items and look at any kind of variations. You know, we had the same census, but our meat bill last quarter was 20% more. Why was that? And those are things that you would have to look at. All invoices need to be signed, and the delivery person must sign for any missing or damaged items. You double check the delivery against the order sheet. You verify the quantity. You check that it's the correct order, the pricing. We used to weigh the meats, and we had a meat scale at the VA when I worked there, and everything should be dated. You verify expiration dates. Any swollen, dented, or rusty can should be removed. And every facility gets some, so they have to have a dented can rack to make sure that they're far away from the ones you're going to use. Delivery people should never enter storage areas. First of all, I don't think they're covered by insurance in a lot of cases, and they have no business being in your storage area. Clear trash bags, discourage theft. And you don't allow all staff access to storage areas. If they don't need to be there, then you don't. Sometimes they have little alcoves where one person will pull out what they need and put it out there for the day. And this ensures that you don't have everybody just randomly running in there taking stuff. Line receiving is not a bad idea because inventories are printed with the prices and quantity blacked out. So this ensures that each item is counted and not recorded. All you know is it's an item. So, and then someone else matches it. And the prices can be kept confidential in that way. So this just goes into specific ones like dry storage. So I think everybody knows that the chemicals, the cleaning chemicals have to be well labeled and stored in a separate room so there can't be contamination. One time we got a shipment of mayonnaise in little containers and it tasted sweet. So we weren't sure what was wrong. We didn't know if it had started to go bad or what the problem was. But when we called, I think the salesperson, they said they found out there was some kind of accident in the place where it was manufactured, and the sweet and low accidentally got dumped in to the mayonnaise. So we weren't crazy, and the patients who complained weren't crazy. They had had it before, they knew what it tasted like, but that happened actually in the plant. So these kind of things do happen, but so you don't want chemicals anywhere near your food. The FIFO helps in dating. And then this just goes under temp. Then we'll ask you temperatures of fair game under 100 Fahrenheit for shelf life. It's cut in half. They want it to be 50 to 70. And they also, I think, want a certain humidity for certain things. I'll go into that in a few minutes. Pest control, trash out of the garbage containers emptied frequently and stored outside. That has to be. And you guys can stop me with questions if you want. So I think everybody knows you have to raise the storage, right? No supplies can be stored on the floor and a minimum of 6 inches off the floor. The shelves are supposed to be away from the walls. This is the humidity, 50 to 60% for fruit and vegetables, require a little bit more humidity. Ventilation is also important. So a lot of times we store our fruit and vegetables, I think, in the walk-in. If you have room, you may not always have room. Okay. So refrigerated storage. Usually you have more than now. You have thousands of dollars of food in the refrigerator. So you're not going to have one dinky little thermometer in there. That makes no sense. So you're going to keep more than one thermometer in a large refrigerator. The HACCP thermometers are on the outside. They're built right into the refrigerators, and they keep a running temperature log. There are also modern technology that I think the temperature of the refrigerators can be synced to someone's phone. So the food service director probably has the first warning, wow, this temperature is going up. We either have to call someone or I have to go in there and move it into another refrigerator so you don't lose all your stock. You want to circulate and keep space between the items to allow for airflow. And everything's stored in a clean, non-absorbing container. And I think you guys know that the raw food goes on the bottom, so it can't drip onto anything. Any of this not sound familiar from a long time ago? So the frozen temp is 0 to -10. And again, more than one thermometer. And keep cold air inside and only open when necessary. And so that's where we lose like a lot of probably have a high energy bill because people going in and out of the walk-in. So our walk-in doors are clear, so you can walk up to it and kind of get an idea where you're going in. They also have those, I always say salute to bacteria, but those clear plastic ones that hang down, they're disgusting, but they also help keep the air in, and I guess they have to be cleaned every now and then. So despite the fact that you have the barcode, you have to do a physical inventory, at least at the end of the year. Sometimes people do it quarterly. It's very time consuming, but at least you know exactly what you have. And then you can use the other systems in between. So you always want to be thinking with costs in mind. You want to determine efficiency in each area and if the expenses are in line with the budget. Again, we're keeping people honest. And you want to establish short-term and long-term goals as far as controlling costs. You want to maximize your profit, but you also maximize your profit. Do not minimize. You want to minimize your losses. Sorry, that's a boo-boo. Okay, so again, we said allow 15% over what is needed in case something's delayed. Analyze non-perishable costs and usage to see if buying larger volumes is wise. So everybody has difficulty with storing things. So it might be a phenomenal price to buy 100 clamshells, or not 100, 10,000. But if you don't have anywhere to store them, even though it's a good price, it may not be what you can do. With hospitals, it's not a static number of patients. Certain times of the year, it's a higher census. We're higher census now after COVID. Now we still have some COVID, but less because people put stuff off. So we've been very high census over the last couple of months. So all of our projections on sales, even cafeteria, all our food had to be adjusted upwards so you have enough. You always want to have a complete list of suppliers, order units, product details, and prices, just in case someone can't come in to order, someone gets sick, they get fired, they quit. And then the prices are usually renegotiated every 6 months. Okay, so now that I know you guys track usage, food usage. So I've seen all kinds of inventory systems. I don't know anyone works the best, but you have sign out sheets, and that helps you track what's used and how much. There's daily preparation form, and that helps you track food items and how much we used and how much you had at the beginning of the shift. The minimum amount needed form tracks individual food items and amount needed for each day. And then you have a daily yield form, and that helps track how portions came from amounts ordered. And that takes into account like the shrinkage when you cook something, 4-ounce hamburgers ordered, but then it shrinks by the time you get done cooking and it's really 3 ounces. Now this is multiply employee hours by the hourly wage to get the labor costs. Use projected sales figures and divide that amount into your labor dollars to find the labor percentage. So you take the hours that someone worked by their hourly wage to get the cost, and then you have to say if you do that for a day, so you do 15 people earning $17 an hour, and then your projected sales figure in the cafeteria is, I don't know, $15,000. That's what you would divide to get your percentage. All right, so take a few minutes and look at this. So financial data is shown here. What is the net profit? So you have cafeteria revenue, guest meal revenue, catering sales. Then you have the other costs here. So what is your net profit here? And I get to stop and sip coffee, and you guys get to figure this out for a minute. This is all coming in the top three. And this is all what you would have to take away from it. Does that help us?
Can I say it if I think I got it?
Sure.
Is it 15,850?
Yep.
Awesome.
Perfect. So why don't you tell us what you did?
So I added up the revenues plus the sales, and then I subtracted all the costs.
Perfect. So this is kind of an easy one to get your feet wet. But this is how it's done. This way you know. Okay, so this one gets a little more complicated, and I might have to show you the other one. So you're planning the budget for next year. Labor costs will increase by 10%, food costs by 5%, and operating costs by 4%. This year's sales were 150,000, labor costs were 40% of the income, and food costs was 40%, and operating costs were 15. What is the projected budget? This will take you a few more minutes to do. Here we go. This one got progressively harder quickly, right?
Lorraine, I have a question.
Sure.
How can we have 40%, 40%, and 15%?
That's a good question. Because it's oh no, you can, because it's a percentage of, those percentages don't have to add up to 100. I know what you're thinking. It should be like, 40 and 40 is 80, but it's a percentage of that. It's okay. Don't get caught up on that detail.
Okay.
Did you get a number?
No, I was stuck on that for.
Well, do you want to, I think we're going to walk through it together and hopefully I got it right. So you're planning the budget for next year. So the labor costs will increase by 10%, food costs by 5%, and operating costs by 4%. So we're taking the total sales in this case is 150,000. Labor costs were 40% of the income. So I think we start off doing 150,000 times 0.40. And we get 60,000. And then you times that by 10%. And you get 6,000. So for labor, you're going to get 66,000. Does that sound reasonable? So then, operating, so the food cost was also 40%, so it's that same $60,000. So we do 60,000 times this time 0.05, right? So we get 3,000. So it would be $63,000 for food costs, right? And operating costs will go up by 4%, but we're going to take still that 150,000 times the 0.15 because it's 15% of the budget, which is 22,500 times, what do we say that went up 4%? 0.04. Not, that's another $900. So that would be would be 2340, 23,400. So then if we add all this up, our projected budget would be the 66,000 plus the 63,000 and 23,400. Oh, and I got the right answer. And I'm still thinking about what you said about so much percentage of the budget. You're right. This is probably poorly worded. I didn't make this one up though. But it should probably, the other one should have been like 20% or, yeah, there's probably some other percentage in there. So I got 152,400 by doing it the way I said to do it. Did anybody get close to that? Did I? And I know I lost you, so where'd I lose you?
That's the answer that I got.
Okay. Did you get 66,000 for labor?
I
What did
did.
you get for food costs?
63.
Okay. So then if you take the 150,000 times 0.15, what did you get?
22,500.
Okay. And so you right there. So then what you did is you should take that 22,500 and you times that by 0.04 and you should have got 900. And so you add that onto the 22,500 and that's where I got the 23,400.
Right.
And then I just added them up together. So if you didn't get this one, take a few minutes and make sure you can understand how to do it. This one was complicated. All right. This one I think is easier. How much will it cost to prepare these eggs? So the cost of eggs per dozen is 75 cents, 2 ounces of oil at $1.14 per 16-ounce bottle, and 2 cups of milk at $2.75 a gallon. What is this? Huh, interesting. Elena, I'm gonna start now. Okay. So what do we do for the eggs? We just doubled that, right? So we got $1.50. Okay. 2 ounces of oil at $1.14 per 16-ounce bottle. So you could divide the 114 by 16 and then times that by 2. And then how many cups of milk are in a gallon? 4 quarts in a gallon, 4 cups in a quart, right? Did everybody remember that? Okay. So then you have to divide this by, what was I going to say, 16 and double it and then times it by 2. So really to prepare these eggs, I got $1.99. I think I did some rounding up. So it should be anywhere from $1.98 to probably $2. Okay, so that's how you would cost that out. Close. Now on the test, they might give you $1.89, $1.98 or $1.97, and you just have to, without rounding, round down or round up, but that one might be a tricky one. So now there's also depreciation costs if you buy equipment. So if you purchase a freezer for $1,500 and you expect it to last 8 years, and then you can sell the metal, or maybe it still works and you can give it to someone, sell it for $1,600. What is the depreciation cost each year? So it's 1,500 minus the 600 is 900. And then you would divide that by 8 to depreciate it. So every year it depreciates $112.50. Now you may not always know how much you get for it until you know what kind of condition it is in, but that's just a way to track the depreciation of something. What is the gross food cost for November using the following information? So you have your November 1 starting inventory, you have your December 1 starting inventory, and food purchases for November. So what you do here is you take November minus December's, and then you add on the food costs for that. And so it's 5,200 minus 3,100 is 2,100. And then you add, in addition to the 2,100, you add 2,500, which you purchased, and your grand total was 4,600. That one's not that hard, but just make sure you understand the logic behind it. All right. So now using the data below, calculate the average check for June. So you have the total revenue, you have the net income, you have the FTEs and the number of customers. There are some numbers here that you don't need. So this is another characteristics that they'll give you extra numbers. So the average check is just the number of customers and the total revenue. So the total, wait a minute, I'm sorry. I think it's the total revenue divided by the number of customers. Sorry about that. Yep. So you take the total revenue divided by the number of customers and you get $8.51. It's not asking you about profitability and it's not asking you about labor hours. It's just asking you to calculate the average check for June. It means per person, how much money did they spend? So they spent $8.51. FTEs doesn't go into it, and the net income has nothing to do with it. All right. Make sense? Caitlin, does that make sense? Okay, I think she froze on us. Okay.
Yes, ma'am.
Okay. So how to protect the food supply?
Yeah, I've been freezing a little bit. Actually.
Yeah, after I said that, I saw you scratching your eye for a couple seconds. Okay, so now we're moving on to HACCP. So this is hazardous analysis and critical control points. Food processors must identify areas that allow for foodborne bugs to get into the food and prevent contamination. So we're looking for ways to keep it from happening. This process is working, but there's also other technologies being considered. So one thing was corrugated cardboard boxes are not allowed in anymore into hospitals because they allow pests to enter the facility by hiding in the crawl spaces. That corrugated cardboard is that one with the little tunnels in it. So that was big to do, to change all the boxes over to another type that would be strong because the corrugation actually makes it stronger. So that's just one aspect of HACCP. It identifies and monitors foodborne hazards in basically 3 categories. They're the biological, chemical, or physical. All right. So you have to identify those points in the storage or preparation that must be controlled to ensure that the food is safe, like temperature. So if you want to make sure the tuna salad is cold enough when someone comes to stick a thermometer in it, you put the can, even though the can can stay in the storeroom and not be refrigerated, if you're going to make it and want it to be cold by a certain time, you put the can in the refrigerator for the next day so it's cold overnight. And so when they combine the cold mayonnaise, same thing if it's a new jar of mayonnaise, that goes in the refrigerator. So it's all cold when they make it. And if the health department person sticks a thermometer in it, it's already at temperature. You don't have to say, oh, I had to wait for it to come down because everything I pulled it out of the storeroom. That's not the way to do it. It should all be cold by the time you put it together. Critical limits have to be established to document that the appropriate parameters are met for each critical control point. Okay. So hazard analysis, principle 1, you identify significant hazards and you provide a risk basis for selecting likely hazards. You identify hazards that can be used to develop procedures to be followed to ensure or improve food safety. So that's how we ended up with that containers can only be so deep so that it cools everything down, and within 2 hours it cools it down, and then another 2 hours it's supposed to be at the right temperature. Okay, that was all established because of HACCP. And then you have principle 2 is identification of critical control points in food prep. So you have cooking, chilling, sanitation procedures, prevention of cross-contamination, employee and environmental care. So things like cooking has to be at a certain temperature for a specified period of time to be sure that you killed off any microorganisms. Or it has to be chilled within a certain amount of time. All right. Also, going back, let me go back one. You also have to, you want to make sure that it's the food's delivered safely, stored quickly, and inspected by qualified employees. So 3 establishes critical limits for preventative measures associated with each critical control point. So you think of them as a boundary for safety, temperature, time, physical dimensions. If you have a variation from that, then you have to look at why that happened and is the food still usable. So to establish these critical control limits, these are the things that are used. So we're going to be in a hospital or a nursing home setting or some kind of, larger food. We're not doing viscosity, chlorine, and salt concentration, preservatives, and titratable acidity and pH. Really what we're looking at, time and temperature, and maybe some humidity, which is in the refrigerators. This would be more of a research lab that would be establishing those. You're tracking the system's operation so that a trend towards loss of control can be recognized and corrected. It indicates when an actual loss of control has happened and corrective action is needed. You stick the thermometer in the hot entree before you start the line and it's not hot enough. That means you put it back in and you heat it up to the right temperature before you serve it to anyone. And it provides written documentation. So your written documentation is the food temperature log that you have. As long as someone actually fills it out, sticks the thermometer in there. Sometimes they're not filled out, and at the end of the month, it's miraculous how all the temperatures go in there. That's really not how HACCP was meant to be. It's really meant that you monitor it as you go along so you don't serve something that's not okay. If you have a deviation, then you have to get rid of the food. Correction of the cause of the deviation to ensure that it's under control. So if it's a rogue refrigerator that, you know, broke, you either get a new one or you get it fixed. And if you discover the food and it's like 45 to 50 degrees, it's too high, you really don't know how long it's been that way, you do have to throw it out. And you have to record all that. Maintenance of records generated during the execution of the plan, and the level of record keeping is dependent on the complexity of the food preparation done by the facility. So if you're just a reheat place, you don't have to keep the same amount of records that someone who's actually cooking a protein would. If you're cooking proteins, they have to be to a certain temperature. And then if you're sending it out to other places, then you have to put the layer of complexities that you have to then put into a refrigerated truck, and then it has to be delivered someplace. So all along the process, there are steps where the food can go bad. So this is production costs. So you have your planned menus and your standardized recipes. You have a measuring yield, and you have established portion control. So now in the hospital, we have planned menus. There is standardized recipes, probably somewhere in a dusty cabinet in the back of the kitchen. You do have a measuring yield, and that's when we estimate how much protein shrinks, because that's probably the one that you see the most, because it's most expensive is the protein portion. And then you have portion control. So this is where your costs can go high if you're given too large of a portion. And in the case of a renal diet, where you don't want to give them that much protein, you're also not really adhering to the diet. So to keep everything from malfunctioning in a kitchen, you want to keep all the machines and computers in working order. You want to look at things like gaskets on refrigerators and ovens, because that will allow, if they're cracked, it'll allow bacteria in there, but it will also allow it to disintegrate, so the oven won't keep the heat in, the refrigerator won't keep the coolness in. And you have to anticipate a need for new equipment. So like a dish machine is very costly. You can't just spring it on your administrator, hey, our dish machine, you know, is 40 years old and we need a new one. That's how you kind of lead up to it the year before. You can say, our dish machine is 39 years old. We've spent $10,000 this year fixing it. A new one is 40, but we have to now stop and say, is it worth putting another 10,000 in it when it's, you know, potentially not worth it anymore? Like those are things that you have to anticipate the need for new equipment. And a newer piece of equipment might also be more efficient, so you may save energy. So these are all things you have to take into account. So you have an operating statement or a performance report. It compares your actual fiscal performance to the budget and includes the budget for the accounting period and the amount from the beginning of the fiscal year. So you want to see, you know, if you have a budget of $10 million, are you on budget? Are you over? Are you under? If you're over, is it because the census was high and you had to order more food? Or is there, you know, food walking out the door? There's all kinds of things you have to take into account. So you do have budget variance, any deviation from the budget. Many times any variance that is 5% or greater may require a report. So if you have suddenly, usually you spend 25% of your budget on tube feeding products, and it's 35 this time, and the census has not been higher, well, you have to look at that. Did the prices go up? Did that group of patients for some reason need a more specialty formulas? Because not all formulas, as you know, cost the same amount of money. Did something expire and you had to throw it out? There could be a lot of reasons, and so that would generate a report. If a meat bill is budgeted at 1,000 for the month and it's actually 3,000, you definitely would be asked to explain why that happened. Why would you have $2,000 more of a meat bill? And then you have a balance sheet prepared at the end of the fiscal year. And it really just gives you one moment in time of a facility's financial status at that point. And it lists their assets and their liabilities. We talked a little bit about depreciation already. Buildings or capital equipment does depreciate over time. And usually you spread out the cost over the life of the item. So if a fax machine costs $7,000 in the last 5 years, the fax machine will be depreciated at $1,400 a year. What we did slightly different the other time was say it would still be worth something at the end. Current assets easily converted into cash, prepaid expenses, accounts receivable, money owed an organization for goods and services, your inventory, and any petty cash savings and checking monies. That's all considered your assets. Then you have fixed assets. So these are things they're not so liquid. Capital goods that depreciate over time, maybe some business improvements, painting, carpeting, upgrading. Okay, and then you have liabilities, your short-term debt of the organization, invoices of goods recently purchased for accounts payable. If there's a mortgage payment or a loan, your liability for payroll, your accrued liability, which in this case is like sick and vacation time, and unearned revenue, items that were prepaid but not delivered. So I don't know, I don't think in healthcare we do a lot of this, but stuff I guess could be ordered and paid for and not delivered yet. Now we're going into specifics of different different types of food and what you're looking for when you're ordering it. So I know this is an exciting stuff, right? Is this review for most, or is this some new information?
It's kind of some of both.
Say that again.
It's some of both for me.
Okay. So meat, fish, and poultry. A third to a half of your food budget is spent on the protein products. And then this goes into a little bit. Beef is a longer gestation and there's only one offspring. If you have to transport your beef across the country, that's another cost. It says 7 pounds of food for cattle to gain 1 pound. So then we have fish as 1 pound of food to gain a pound, chickens is 2 pounds to 1, and hogs is 4 pounds for 1. So it just kind of tells you how efficient things are. So myoglobin and hemoglobin make the meat look red, and that's why the packages when you buy them in the supermarket, they're exposed to the air is kind of that browner color, and it's more usually red underneath. Heat changes them to hemidin, which is a gray pigment found in well-done meat. Oxygen can combine with the myoglobin and form oxymyoglobin, and ground meat with a red outer covering and dark color inside turns bright red when exposed to the air. They also cure meats with nitrogen, which turns them pink like a ham or a corned beef. And brown meats means it's begun to deteriorate. And I think most of us can tell when it's going bad. Inspections are required by law, and grading is voluntary. And we do have grades established for beef, lamb, pork, and veal. And one is for quality, while the other one is based on yield, age, maturity, and quality. So you can freeze meat. It's desirable to have fast freezing to prevent these large crystal formation, which is undesirable in meat. Freezer burn occurs when the surface of the meat becomes dehydrated. So you don't really want to be ordering, first of all, you should be ordering that much meat for your facility, and you should be using it up before it starts to freezer burn. Freezing has increased storage needs, and smaller portions of fresh meat may be a better choice in some instances. We're not big on processed meat, but you will see it, corned beef and cabbage uses a dry rub, and these are just finishes that they'll talk about. When it's cured, the finished weight is the same or less before curing. Water is added, and the finished product is 110% of weight before curing. There's dry curing, where they're doing a salt or preservative, and it makes a brine. There's imitation, more than 110% added weight after curing. And then there's a wet brine cure. Meat is immersed in 55 to 70% salt and soaked enough to preserve the meat. Those are, processing that you can do for meats. So poultry is based on age and sex of the poultry. Greater quality, it's A, B, and C, and it's based on conformation, fleshing, fat coverage, lack of feathers, tears, cuts, and bruises, freezer burn, broken and disjointed bones, and they pack it a certain way in the polyethylene to eliminate freezer burn. And you get the kind of meat that you need or the quality for what you're going to do with it. If you're going to serve it as a half a chicken, you want to get a better quality than if you're going to make it like as a stew, where it could be a slightly less tender piece of chicken. Andy likes to ask a lot of egg questions, just to be fair warned. So eggs can be purchased in shells, as liquid, frozen, and dried. The weight distribution of an egg is usually about 55% is the white, the yolk is 31, and the shell is 11. The shells affect the grade and are graded on soundness, cleanness, shape, and texture. And they use scanners to see the interior of the egg. So they want to see that the yolk is in the center, that there's that aqueous nature of the white, size of the air cell, and blood spots. And egg standards are grade AA, A, B, and C. So produce, so regulations, the Agricultural Commodities Act of 1938 required that people in the produce industry be licensed and use fair business practices. The Agricultural Marketing Act of 1953 and 57 created agencies that established standards and grades for food. So before that, it was no HACCP, no real standards. It was the Wild West food. So let me just see what time it is. Okay. So you have hydrocooling is expensive and uses ice and water to rapidly cool produce. And refrigeration is a slower process. So like if you have a big tub of something that you want to cool down quickly, when we did our research project, not this year, the year before, we cooked and then we put it in the hydro cooler. It was like a big refrigerator and you just put the pan in there and it brought it down to the right temperature. It was pretty cool. There's vacuum cooling, which is a dry system and it's preferred method of cooling large quantities. You pull into a chamber and it uses heat in the items for evaporation, and it handles larger quantities at a lower cost. So usually US #1 is the most desirable grade. 2 and 3 are also available. You could have some combination ones, so it's a collection of items that probably fall into, mostly #2 and #3, maybe not that many #1. The field grade is as picked. So if it's like fruits or vegetables as it comes off the vine, they pack it that way. So some will be higher quality than others. You get what is there. Due to variable packing containers, net weight should always go into the spec. So the label for processed foods or produce should have the style, pack, variety, any artificial colors, content, pieces in a package, size, and serving size. And this would be, I'm going to say for processed, it's like canned peaches or canned fruit items. It's not for fresh. So milk comes in a variety of ways to do it too. So you have fresh, clean cow's milk, free from unusual odors or flavors, vitamin A and D added, and then the grading takes into account the flavor, odor, quantity of milk, fat, milk solids, and bacterial count. Then you have all these types of milk. So you have fluid milk, whole milk, ultra heat. Hang on, see if I can find it. Ultra, anybody remember UHT, ultra heat? Ultra heated milk packaged under aseptic packaging. Fluid milk is labeled according to the fat content, usually a little fat reduced. Whole milk is not less than 3.25% milk fat and not less than 8.225 milk solids. Filled milk uses a fat other than milk fat. I've never used or tasted filled milk that I know of. For evaporated milk, you have about 60% of the water is removed. The sweetened condensed milk, 15% is added sugar and the volume is reduced by 1/3. And dry milk is made by removing 2/3 of the water from the skim milk under a vacuum and the milk sprayed into a drying chamber. Did you know that there was all those different types of milk? I think most people know about the fluid or whole milk. So then you also have the pasteurization So hold is milk is heated to 63 degrees Celsius. It's held for 30 seconds and then it's cooled to 7 degrees. The HTST is heated to 72 degrees Celsius, held for 15 seconds and then cooled down to 10 degrees Celsius. And the ultra heat is milk heated to 138 degrees Celsius, held for 2 seconds, kills off all organisms, and allows this product to be stored in a closed container at room temperature for 6 months. Okay. So then we have cheese, and that depends on the ingredients used, age, and storage method. And I have the grades listed there for you. So it takes 100 pounds of milk to make 10 pounds of cheese. So that's also not the most efficient way to do it. And you have hard and soft cheeses, and it depends on what you're using them for. So in butter, flavor is the key for grading. So you have, it should contain no more than 80% milk fat, and it's graded AA, A, B, and C. Okay. Now we're going on to some equipment. We're doing on the time, so we'll see how well we do. So rack dishwashers. How many minutes per load does it take to clean dishes with a rack dishwasher? So 1 to 3, 5 to 7, 10 to 15. And the answer is 1 to 3 minutes available in floor under the counter models for small food service operations or quick serve restaurants. So this will clean the dishes very rapidly. It's like a coffee shop kind of place or very small restaurant. So this is what we have in most hospitals and nursing homes. You have the conveyor dishwashers. And what size facilities would use this? It really moderate size is the correct answer, and larger ones. Full service facilities use racks for dishes, and it's faster than a rack type dishwasher. So you put it on there, it goes through, and it recycles the water, and it does the job. One person loads, one person unloads. No, so it's used for high capacity. So the plate dishwashers are the ones that are real quick. High temperature sanitizing in a large conventional or commissary facility. So volume, you're loading it in, someone's taking it out. This is broilers, and this is food is cooked on a metal grate. It's usually gas, and it's used to produce that charbroiled taste. It's a very high energy user. Most common range is the open burner. Gas, so you can control the heat a little bit better. Often comes with an oven, and there's multiple configurations for the burners available, and that's based on what type of food service you're doing. What is the most common is a convection. The oven moves air with a fan, and it's either gas or electric. I'm sure most places also have a microwave, but convection is probably the most traditional type of it. All right, so we're taught that frying stuff isn't so good, but there are some places that do fry foods. And so it's always about, I guess the oil is very expensive. So what you want to do is preserve the oil life of the, the oil. You want to, excuse me, preserve the oil as long as you can. So the quality of the oil, the color, and the filtering in foods. So filtering in foods cooked. So you want the oil and maintenance are very expensive. So they will filter out the particles to keep the shelf life of the oil a little bit longer in a fryer. It's also probably one of the more dangerous pieces of equipment in food service. Griddle, sometimes called a grill, gas or electric, thermostatically controlled, can be double-sided like a clamshell, and can be grooved to create a charbroiled look. So that one's actually not a bad combination thing. If you can add the racks and charbroil it, and you can make pancakes on it, it might be a better choice for your food service because it can do more than one thing. You have steamers, gas or electric again. They can be pressurized or pressureless. The pressureless steamers are used in restaurants. Pressure steamers are common in on-site food services. And they're non-thermostatic. You got to use, when we were cooking for our research project, we used the tilted skillet. And I think we tilted it at the end so that we could clean it. So that was much easier. And I guess you can use for large batches of soups and stews. You can braise and brown, gas or electric, and it tilts up for cleaning. So it's a steam jacketed kettle, and so you could just remember that. That's how I was taught to call it. So it's heat, and it can range from 2.3 to 150 gallons. So if you're making a lot of soup or stew for a very large facility, that would be what you would want to make it in, is a steam jacketed kettle. We have holding cabinets. They're usually electric with room service. I don't know that we have a lot of holding things anymore. I think we cook to order, so we don't have to do that as much. But you may still have some food services that use these. May have humidity controls, and being insulated is pretty critical. And used in facilities with long operating hours. So you may have, like, you've had the patients, and they may hold the food for employees who maybe eat later on. In catering, we use them too, the holding cabinets, because you want to maintain the temperature after things were cooked. You can have a combination convection oven with steaming capabilities. And you may have capabilities to verify HACCP compliance, so that would be wonderful. And refrigerators and freezers come in all different shapes and sizes. So you have reach-ins, pass-through, roll-in, and walk-in models. They may be mobile or built-in. Maintenance is very important, and the external temperature readouts are kind of the norm. So you can look at the HACCP thing and see what the temperature was. Right after a delivery, you would expect it to go up a little bit, but it should, within a certain period of time, come back down again. And that's how you know it's working, everything's working. The reach-in might be near the line if people still have a line, or nourishment might do it. They reach in and they grab stuff. Pass through, I guess you could walk all the way through it. Most of the ones I've seen are walk-in ones or roll-in ones. Now I'm back to budget, so I don't know how I got here, but we'll just go through this. There must be some point I was trying to make. So the benefits of a budget is it forces management to consider future directions and development. You review your past expenditures as a basis for what's going to happen in the future. You have some standards of comparison against what you actually spent. You may have to address inflation if things go up, cost of living expenditures. It helps you set some goals and limits. And it provides continuity. So if you have a different boss, you can, they may review the budget, but you have something to say, yes, I spent this much on food. I spent that last year too. And there's different types of budget. So you have an operational one, shows the overall structure of the operation, revenue, expenditures, sales, supplies, services, small equipment, food, and labor. You have a capital budget, and that's really more for your big equipment, and if there's any plans for expansion. Then you have like revenue, you have cash flow, and that usually shows you what kind of cash you have on hand. And you can have a master composite of the operational capital budgeted balance sheet and cash flow budgets. There's other types too. There's fixed, and that's used to compare actual fiscal performance with expected performance. And that kind of is, like we can't do that so much in healthcare because it kind of says that your business will remain stable throughout the course of the year, which we know that doesn't always happen. Maybe in a nursing home that's very stable, that's filled to capacity, that might be okay for them. But the advantage is that managers can be provided with financial performance goals, and they can measure each quarter and budget cycle and see if they're meeting them. But it's not going to react to changes in business or other changes. You have variable budgets, and expenses are projected based on variable amounts of production, volume, or revenue, which is more kind of what a hospital would want. And it's flexible and can react to changes in volume. The incremental budgets, I think this is what we calculated with that other problem. So it's based on your existing budget, and that gives you a percentage added to each category to cover any changes. It can be variable as actual dollars allocated will vary in proportion to work done. And this one can be fixed or variable. And then the zero-based budget isn't, I don't think it's used too much, but it's not a bad idea once in a while. It's created from scratch every year. You might put some things like, okay, I can't change the rent and the utilities, they are what they are. But every category is reevaluated each year. So they may look at labor and say, is there any way we could cut this labor cost? You know, they don't just say it's okay and move on. And this is how you would just justify, yes, I need the minimum of this many full-time equivalents to be able to put out this many meals. And again, that could be fixed or variable. You have direct costs, and those are specific costs that can be identified with specific products, department, or activities, and food costs is in that. Labor and wages are direct costs. Salaries and benefits can be calculated as a percentage of that. And productivity is a measure of output per FTE or full-time equivalent. And an example would be include the number of meals per labor hour and its effect on the bottom line. So if you have a selected menu, it probably is a higher percentage of FTE to do that selected menu. If you don't, and you're in a nursing home and it's one or the other, probably your labor hour costs would be less. Indirect costs are expenses that cannot be identified with products, departments, or activities, things like taxes and insurance. Some overhead costs are not scrutinized as carefully as direct costs. You can save some money in indirects by changing insurance carriers, conserving energy, or changing service providers. So these are some ways you can save some money. Same thing in your own household. Fixed costs do not vary based on sales. So your rent is your rent, and your tax is your tax. And then this is just a formula for profit margin. It can be expressed as a percentage. So to determine the cost of an item or service, a specific percentage of profit is built into the price. So you have the net profit divided by the net sales. There are some profitability ratios, and that measures the ability of an organization to make a profit in relation to its sales or investment in assets. You have return on equity and return on assets or profitability ratios. Return on equity measures adequacy of profit in relation to the owner's investment. And then there's the return on equity and the return on assets, both using net profit. Again, I think we kind of went over some of this. You have current assets would be cash, accounts receivable, money owed to the company by customer, like a hospital bill. Fixed assets, money value of land, building, patient, patents, etc. And liabilities, the amount of debt. Do you have a bank loan? Do you have outstanding bills? And payroll? Payroll is usually the first thing that gets paid out. Everything else comes after that. You have capital or owner's equity. And this is the owner's share of assets or the amount the owner has invested in the organization. Maybe shareholders' equity or stockholders' equity. So in hospitals, that's usually a little different, but with some of them being all brought up together, we're run by the state, but there are other ones that are private and hospital entities. So this really gives you a snapshot in time. So you have assets, your obligations, which is liabilities, and residual claims of owners. So you end up with your owner's equity. So I think we're wrapping up this pretty much. So you have what records or tools are used as controls in food service. We have inventory, we have food production, census, profit and loss, personnel records, purchasing and receiving, storeroom records, and variance reports. So like in school food service, you have a profit and loss because they maintain their own records, and they're usually sustainable thereby. They don't get a big budget. So they have to show profit, and they have a profit and loss statement every month. Some control strategies are, some are short-term drives to reduce costs by increasing production or decreasing expenses. There could be some hiring freezes, early retirement, limiting raises to cost of living, and increasing responsibility or productivity arcs of expectations are common. So when we had a 10% rate decrease throughout the board, we had to look at all our food service personnel. We went to more convenience products because we were trying to cut our labor costs quite a bit. And we were shocked at how deep it went because we had people that had worked there a long time and their positions were in jeopardy. So these things do happen. And there's cost control formulas used in food service. This is cost per meal. So you have the total cost divided by the number of meals prepared. And then you have meals per labor hour. So you have the total number of meals served divided by the total labor hours to produce meals. In long-term care, they know the food service director and assistant director know exactly how much each meal costs because they have very tight guidelines how to bring it in under a certain price. You have meals for full-time equivalents, and you have labor minutes per meal. So I just gave you some of these formulas here so you can review them. Value analysis is the systematic investigation of all parts of an existing product or service with the ultimate goal of eliminating unnecessary costs without affecting quality. So value analysis in food service includes food costs, so menu, pricing, purchasing, waste. So if you have a product that you end up throwing it out, nobody likes it and they complain and you end up sending up a second meal, that should be cut right away, no matter what budget catastrophe you're in. It's just not a big winner. But you might be able to cut some costs on some foods if they're not a big seller. In some cases, we've been able to save costs by cutting the hours. So we're not, even though it's room service style of meal service, we're not open till midnight. It's not room service like you can get in a 5-star hotel. If you're not having ordered dinner by 7 o'clock, you're pretty much out of luck. And you can also look at the number of employees. If the census is down, you may have some per diem employees that you may not call in, or if someone calls out sick, you're not going to replace them if the census is low. And then you have operating and other expenses, supplies, utility, etc. This just goes into some of the energy. So this just talks about, how many BTUs it takes to bring 10-gallon pot of water to boiling. Must produce actual heat, then electricity to do the same job. So gas is not as efficient. Electricity is said to be a little more efficient, believe it or not. And then you can convert everything to BTU. So I gave you the formulas there. So you can conserve up to 20% of your energy, which is quite a bit. So you can use insulation. The light bulbs, everybody's changing to, or have done that already. All equipment should be in good working order. I don't know if you guys, I'm aging myself, but I had a frosted over refrigerator that was going. We did defrost it, and then our electricity bill went down quite a bit. I think it broke probably the next month, and we had to replace it, so we got an energy efficient one. But those things do suck, and imagine on such a big scale. The gaskets to get a tighter closure, and really encouraging the staff not to just be opening the door and standing there to look in. How you place everything closer together for workflow you would want, but also for the energy. And they say install low water cutoff devices in dish machines. So this is just looking more at equipment. So Joint Commission the equipment has to be constructed to exclude vermin, dust, dirt, splash, and spillage from normal usage and be cleaned easily. If on legs, must be 16 inches off the floor. It has to be spaced apart. And local building, plumbing, electrical, and sanitation codes must be followed. So the good thing about having distance is you guys all have different states and you have all different codes. So we can't teach you individually what happens in your state, but that is something, if you were a food service director, you'd have to know all these codes so that you could comply with them. And food service equipment has to be very easy to clean. And it's something that's going to be high volume, so you would want that. Let's see, main traffic aisle should be a minimum of 5 feet wide. This is fair game for questions. The aisles between equipment and work tables should have a clearance of at least 3 feet. The area in front of ovens or kettles should be 3.5 to 4 feet across and deep. Workable table heights are 36 to 41 inches for standing tasks and 28 to 30 inches for sitting tasks. You need a minimum of 4 linear feet of workspace for each employee, and 6 is probably preferable. Maximum table reach for equipment should be 20 inches. And shelves should be no more than 6 feet high, because then you would need something and it causes a problem. And if we stack, so you definitely don't want that. Usually you divide the kitchen into self-contained workstations and everything you need is right there. So you would have a refrigerator, like a reach-in maybe right there if you're doing nourishments, and a blender if you're making smoothies, those kind of things, all in that one work unit, and that's considered the most efficient. If you have to run to the freezer to get the ice cream and come back and go back over to get the blender from another station, that's not considered a good use of your time and not very efficient. And same thing with like having trash containers, like placed more frequently so you don't have to be walking across the kitchen. All kind of common sense stuff, but you don't realize how much time and energy it takes to do all this. The preferred metals are aluminum and stainless steel. The gauge is the thickness of the metal. The lower the number, the heavier, more expensive it is. So I worked in one place where we had this very heavy gauge steam table, but boy was it old and boy was it rusty underneath. So when it came time to replace it, we got something else, and the gauge wasn't as thick because we couldn't afford to probably replace it in its entirety. They bent it just putting it in. So you get what you pay for sometimes. And the numbers are generally 10 to 14 used for food service equipment. And this just gives you an idea, like for workflow, a straight line would be the best to avoid bottlenecks, but you can't have a complete like shotgun design. The workers would have to walk a great distance and it wouldn't be efficient. So this is just some ideas how you would do it. Receiving, storage, pre-prep, hot production, cold production service. So this then is just the schematic. Receiving, storage, pre-prep, hot and cold food production, and then it goes off to service. And then you have one of these. So you have receiving, storage is over here. We've all worked in a kitchen like this. Pre-prep is over here, then it goes over here, and then it goes that way. This is just, too much crossing over. So every time you have people doing that, you have a bottleneck and the flow is bad. So then you look to think, if you work in a kitchen like this, then you say over time, could we put cold production near the pre-prep? Could we put receiving closer to that? You start to look at ways you could make it better. So if you look in any kitchen you were in, you could probably think of a few ways that you can make it a little bit easier or the workflow a little bit better, right? So I guess yay. All right, so I know that was fast, but does anybody have any questions? I bored you that much? Nobody has even one question? Not one fun kitchen story to talk about quickly? No? Nothing? Really? I had a whole bunch of kitchen stories. No?
I just know that food service is not my calling.
Well, the only thing I'm going to say is it's good to have a little bit of experience doing it, because then you can work your way up the ladder. You could be a food service director or an assistant, or what I think my title was associate. I was really more clinical, but I also, was trained to it was a smaller hospital. Okay, we have to, Danny, the assistant director is on vacation. Somebody's got to order the food. The food service director wasn't there that day, so I could do it. Sometimes there's personnel management things. You kind of had to be the one to step in once in a while and be the calm voice of reason and tell them to separate and remind them they're at work and those kind of things. What else did I do? We did inventory. We did have some fights in the kitchen, so that was interesting. Trying to think of some of the other things. Mostly paying the bills was the hardest thing, because the hospital I worked at didn't have the money always coming in. So that's one thing. So then they don't pay the bills and you have to juggle vendors, which wasn't so much fun then. I'm just trying to think of other things. So think of it as, and you want to know a little bit what's going on in the kitchen, because clinically, if you want your patients to get certain type of food, or you want to know what's in that milkshake that they're giving them that you're charting is that many calories, you kind of have to watch what they do to know that it's actually that. So it's not bad to have a little hand in the kitchen and know what's going on. Samantha, you have any interest in the kitchen?
It's not my favorite. It's not my least favorite. I had a really good food service rotation, so that was really nice. No fun stories.
Rachel, any fun stories?
No, unfortunately not.
No, none at all.
Nothing funny.
Nothing funny. And I did work in one kosher nursing home for a very short period of time. So that was interesting because we
Which
had,
one?
oh, this was on Long Island. It was Garden Care Center.
Oh, I know that one.
And we had very short period of time because I think we had a pipe burst during that. It was interesting. But we had different color dishes for breakfast, or the milk and the meat, and everything was separated. So we had some different things that way. And storage, I'm just even trying to remember some of the things that we had that were different, but we had 2 sets of dishes. But they had the best disaster plan. She had that all roped off, and this is the previous director. I inherited this. So it was wonderful. She had all the 3 days roped off, and then she said yes, and then this is how we rotated out. She had a whole system, and so it didn't go bad, which was great. So that was just an interesting situation. And I'm trying to think, I think for some of the foods, we paid more money for them as well.
Oh yeah, the kosher food is going to be a lot more expensive.
So Rachel, I always made fun. So when we worked in the hospital, in Massapequa, the little hospital I worked at, we had kosher packs, and we never put them on in the beginning.
The kosher what?
The kosher packs. So they were like a kosher TV dinner.
Oh.
We used to, when the ticket came down, they're like, oh, we forgot to put the kosher dinner in, turn on the oven to 500 and throw it in there. So that thing was not good quality when that came out, and it was late, and it was a rarity that we remembered to do it because we didn't do it that frequently. But if the supervisor was on their game, they would have said, okay, before we start, is the dinner in the oven? Because it took like sometimes up to 45 minutes to do that. So that would definitely have been ready by the time we actually got done. But all those things take like some, coordination, and maybe if you start it and put it at the top of the sheet when you were like taking temperatures, you'd say, oh yeah, the kosher dinner, and put it in. Some other challenges we had. All right, so are you guys done now, or are you going, what's next for you? Because
No, they're not done. They have me.
Who's me?
Josephine.
Oh, okay.
And it's not a fun topic. I think you have to get up and do like jumping jacks, but it's stuff we have to make you aware of in terms of scope of practice. And
oh, that one. Okay. Yeah, you thought food service was bad. Just wait.
No, research too. Like I get all the boring topics. I will tell you, food service, one of my, well, not funny, but you do have to know. And I don't think any the clinical staff meetings I've had the last few weeks, it's like you'd be surprised how hard it is to get patients fed in the hospital, whether it be tube feeding and it being turned off all the time, or the wait time for patients to order food, or patients that are weak and sick, and families, we have limited visitation, so the nurses are trying to order for them, but they have so much other things to do. And now converting to ITSE, they know ITSE, right, Lorraine?
Oh, ITSE with the dysphagia guidelines? Yeah, I think so. Yeah.
Do you guys know what ITSE stands for? It's the new international standardized terms for the mechanically altered and thickened liquids, 1 through 7 numbers. So, it's just really challenging to create menu items that meet the specific criteria at each of those numbers. So, and things that patients will eat. So food service, every once in a while, they come back to me and say, can't we put like pureed bacon back on the menu? Because it's, for many people, it smells good. And it's really hard for me to stay on my ground. But as a nutritionist, I'm on the clinical nutrition side. My role is not directly in the food service side. And I have to keep saying no. And there's just too many food quality issues. And I believe strongly that, bacon is not healthy and we don't want to give people the message that it is okay by giving it to them in the hospital. So there's always this back and forth between the kitchen and clinical nutrition about some items, because food service has to be much more cost or, focused. And, we're thinking of the clinical care of the patient, and the two coming together. It's just an interesting point of interaction. So
Okay.
would you advocate for putting pureed bacon on the menu? Or would you hold firm?
Well, and also like the pancakes fit the bill unless they sat for too long, then they got a crust and then they weren't the right texture anymore. So
Yeah.
a lot of it was
It's
that.
tough. It's really hard.
I told them about the tube feeding, how during COVID you ordered 50 and 50 pumps somebody outbid us and they got sent away. And
we eventually got them though. It didn't take that long, but they jacked up the price during the very beginning of COVID. This was like the middle of like the third week of March.
I'm also interested to see what JACO does as far as like emergency supply. I mean, you can't really plan for a pandemic, but they might decide to increase, like instead of 3 days, it has to be like 10, or you just don't know what they're going to do.
Yeah, interesting.
Okay.
So when's the last time they had a break? But if we just plow through, and then I think I'm the last one. My last one on your schedule?
I'm not going to end this, but can I hit the X in the corner?
You can't end it. No, don't end it. Just mute it and turn the video off. Can you mute it though? Because I'm getting feedback.
Yeah.
Or I'll close my door, or both. Okay. Okay. So I have to close my door, otherwise I get feedback from Kara. Hold on. So let me share my screen. Oops, no. Okay, so this is the Academy website. So there are some videos that I'm supposed to share, like they'd like us to share with students, but they'd be like 40 minutes and they're really hard to listen to. They're just throwing terms out that don't mean much to you right now yet. So rather than go through the Academy's PowerPoints or the narrated PowerPoints, which are down here, I'm gonna bring up the actual 2 articles and scan through them and talk to you a little bit about them. And I think that will be actually a little bit more might be retained. So first, I'm not going to ask you because I don't want to put anyone on the spot, but I do think it's a good idea to be a member of the Academy. It's they do a lot of really important things in terms of some of the things I'm going to talk to you about now. Fighting for Medicare reimbursement for more than just diabetes, which is where we're at now, which is better than nothing. And it was a bunch of RDs that were in practice a number of years ago and active in the Academy like 15, 20 years ago, that got Centers for Medicare and Medicaid to approve for reimbursement under Medicare and managed Medicaid for patients with diabetes. So that doesn't just happen. It happens because there are RDs who are active in the Academy who are pushing and fighting for that and working at a national level and getting a seat at the table with national insurance companies. So we need younger people now to get involved, people newer to practice to get involved and to continue to fight for some of these things. So I really do advocate that you become a member of the Academy if you're not already. Student membership is, I don't know how much, but I want to say like $50 or $60. It's not that much. I know it's something, but it's not that much. And it gradually goes up, I think, over the first few years of your practice. So it's something that I really would encourage you to do. So the Academy does establish these documents that are important in healthcare. So the nurses have similar things, the PAs, the PTs, the physicians. So we have to have a scope of practice and standard of practice and have these documented in part of our educational process so that we can become credentialed. and be consistent with other providers in terms of getting reimbursement, etc. So there are 2 documents that we're just going to look through, and I'm going to point some things out, and I want you to know where they are. So if you are a member of the Academy and you sign in and you just there's a pretty decent search engine, just put in scope of practice, you will see this page. Now, initially, when you're first starting practice, you may not, I'm not sharing my screen, am I?
Yeah.
Thank you, Samantha. Oh, stop. Let's see. I thought I did. Do you see scope of practice now?
No, it's your calendar, I think.
Oh, I always get this backwards. It's been a year and a half and I still do these kinds of things. Okay, so thank you. So this is eatright.org, which is our website, of course. And then if you just Google scope of practice, this comes up. Now, when you first start practicing, maybe all this doesn't mean so much, but when you move into management and if you become active in the academy, I'm actually seeing some things here that would be really helpful for me to remember and to review again for in my work with the New York State Academy of Nutrition and Dietetics on the task force to get therapeutic diet order writing privileges in New York State. So it might be more useful later on in practice, but we do want you as a graduating intern to be consciously competent. So to know what you're supposed to know and to be responsible for knowing what you're supposed to know and to be responsible in working in an area that you are competent. So I have had RDs over the years who their first job, 2 come to mind, was as a renal dietitian, as the sole dietitian in a renal center. That made me a little nervous. And I'm not sure if that's 100% appropriate, but they did fine. They learned, they were very responsible, and they became credentialed. But what you'll see is that facilities are trying to control costs. So if they hire someone who's just graduated, they're going to command a lower salary than someone who has 3, 4, 5 years of experience. So that's why I hire entry-level RDs when someone retires or moves on. It's more cost efficient for me, but that person that I hire has the support of 15 other RDs, and I'm around and Lorraine's around, right? So they have a lot of support. Whereas being the sole dietitian in a long-term care facility right out of the bat, you could do it. I think you're all competent to do so, but man, that's taking on a lot of responsibility that I just want you to take seriously, and you're gonna have to really work hard to get the appropriate credentials to work in a dialysis center. You really should be have advanced specialty in that. So it is important to know the scope of practice and to evaluate your own scope of practice. So the documents I'm going to,
just like what you just said, from what I've heard, it sounded like in order to work in dialysis as a dietitian, I don't know if it's like a New Jersey thing, but you need like to have at least 1 year prior experience in clinical nutrition.
Supposed to. You are supposed to. And I don't know how this person got the job.
Yeah, that's what I was told by like this like regional director of Fresenius dialysis. Like
it is true. I'm pretty sure that's national, but sometimes odd things happen, and they don't have a review in a couple of years. No, CMS doesn't come every day. Joint Commission doesn't come every day. So sometimes facilities will do it, and yeah, I mean, I would caution people about putting themselves in that position. And that's part of what, we'll talk about today is making sure that you feel comfortable in the area that you're in your first job, and that you're not being put in an inappropriate position. So the scope of practice is what we should look at first. So I did just send, in between my 2 chats with you today, the PowerPoint with the information for the poster presentation and the CQI. I will make sure, and I asked Sharon to make sure that the research presentation was available to you, and these documents as well. But these are 2017, so they're going to be revised soon, and they've already circulated some documents, which I was going to share later, but I'm actually so intrigued by this that I'm going to show you now because it might help us just make this more interesting. So currently, I think the Academy is getting ready to update these 3, 4, because they're supposed to review them every 7 years at the most. So And in the standards, the competencies that dietetic internship directors and directors of didactic programs, we're starting to see things like this pop up in what we're supposed to be teaching you. So in each of your modules, there are competencies, right? And in the new FEG model, there are competencies and performance indicators. So they're revising the standards for not the FEG model, but for dietetic internships. They're going to be coming up very soon. And I don't know how I feel about this. I'm going to ask you how you feel about this. So, because I have to respond to a survey. So, some of the new ones that they're putting into practice that some RDs are questioning is a knowledge competency, practice routine health screening assessments, including blood pressure monitoring. Now that's been around before. I remember 10 or 15 years ago, we used to train RDs to do, interns to do blood pressure monitoring. That's not so hard, it's not invasive. And we've done that before. And conducting waived point of care laboratory testing, such as finger sticks. So I know a lot of CDEs, RDs do that. Okay, so that's I'm okay with that. Perform routine health screening assessments, including the things we just said above. And now they're adding vaccine injections. I'm not so sure how I feel about that, because people can have reactions to a vaccine that allergic reaction that I don't think we're equipped to handle. And I don't know who would train an intern how to give a vaccine, since none of us do it.
I don't want to do that. I don't want to be sticking people.
You don't want to be. No, I know.
That's not what I signed up for.
And you don't have to. I mean, even though it's in our scope of practice, as a practicing RD, you get to pick and choose what work environment you go into and what you do. So those, that's one. Then there's self-monitoring blood glucose. Then there's provide instruction for self-monitoring blood glucose, insulin administration, and adjusting diabetes medications. So RDs that are CDEs are doing this. So it's provide instruction, so teaching or telling somebody about insulin administration. So some RDs are doing that already. Insert nasogastric or nasoenteric feeding tubes. Some RDs are doing this. I don't know if in the states you practice, if you got to see it during your internships, but this has been around for a while. Initiate and conduct bedside swallowing. So now this is going into the speech language therapist area, right? And I don't know about conducting a swallowing screening. Again, things could go wrong. And again, are we going to be equipped to deal with that? And then there was another one that I missed. Where'd it go? Oh, maybe it's not in this document, but there's another one about pharmacotherapy. And with the TPN, if you're writing, a lot of states, including New Jersey, RDs can write diet orders and can write TPN diet orders. Elena, in where you are as well? Yeah. So some RDs are fighting for or think we should include in our scope of practice the insulin, prescribing the insulin that goes in the TPN bag. And I have a difference of opinion in that. In my opinion, and in New York State, I'm on the task force, I'm not advocating for that, because insulin is not a nutrient, it is a drug. And I really think if you want to prescribe drugs, then you really should go to medical school because there's a lot more that can be impacted by insulin administration. And you know, to me, it's a very, and maybe it's because of the diabetologist that I work with, who's very supportive of nutrition, extremely supportive, but he actually simplified the diet orders for non-endocrinologists writing insulin orders. So physicians that are not endocrinologists, he didn't think they were competent to write a lot of complicated insulin orders because of the negative consequences of hypoglycemia, primarily. So it is, every profession does this. They try to push the scope of practice and expand the scope of practice. So I see why the academy on a national level is doing this, because I know PTs are adding nutrition competencies to their competencies now, because I was asked to give a talk. So other professions do it too. So we can't put our head in the sand, but I just think we have to be a little realistic. So So these things do have real meaning, especially when you're in management or working at the level of the academy, either nationally or at the state level. So scope of practice. I do have to read some things to you that I highlighted here. So, we're describing what we can do basically, and it conveys to other providers the education and credentialing requirements for a RD or an NDTR, so the 4-year degree. And it's important for us to have a defined scope of practice, and then we try to defend that scope, right? So that other providers don't do it. And everybody's trying to invade everyone's turf, basically, is what it comes down to. The scope of practice throughout this document will describe the relationship between the NDTR and the RDN. So the 2-year degree person that doesn't have an internship and the registered dietitian, because in many states, the RDN will oversee DTRs, right, or the NDTR. New York State, or at least at Stony Brook, we don't do that so much because something having to do with the union, and DTRs would make almost as much money as RDs, but couldn't do as much. So it's more effective for us to just hire RDs. So at Stony Brook, we don't have DTRs.
Are RDs unionized in New York?
It depends on the facility. So that's not a state requirement. At Stony Brook, we are.
Really?
Southampton, they're not. Stony Brook, Southampton, they're not.
What about the city? For the
I
city?
think it really varies based on the healthcare system or the hospital specifically. So I don't know about all.
I've never heard of
I don't
that.
think so. I actually don't think many. I don't know of a city hospital that is, but maybe downstate. Maybe the SUNYs are. I know certainly we are. I don't like it.